It's not quite a bright day, but I think that every day is a bright day for CARIM. A couple of decades of history have proven that to ourselves and to the world. And today I will start with giving you an overview of some highlights and some digits from CARIM of the last and the previous last year. So CARIM has a mission. We change this once in a while. And basically, it's you can read it here on the screen. Perform top cardiovascular research in multidisciplinary teams with the best and most friendly researchers, regardless of sex, gender, ethnicity, or religion. Write plenty of grants to enable this and publish in top journals while explaining the meaning and importance of it all to the general public. And the more time I spend in this field of research, the more I'm convinced of the fact that doing research with people that you do not connect to is senseless. And therefore, within CARIM, we're still much more looking into getting a good fit with people rather than expertises and really top-sided researchers. So I think we're doing very well with it, and we're trying to create a family, multidisciplinary family that works together and connects with each other, because then that's the only way that science can be moved forward. The power of CARIM, I believe, is in identifying young talents at a very early age, and then guide them to like a successful academic career. And we have several machinery in place to stimulate this. And of course, the one that you know best is our HS BAFTA grant. And HS BAFTA stands for Harry Struiker Baudier Award for Talented Academics. And Harry is here today in the audience. I can't see him. It's a big honor, Harry, that you came up all the way from France. Can you stick up your hand? There he is, all the way in the back. Thank you. I'm actually not sure if there are people online. Are there people online? Tara, are there people online? There are people online. And I hope also that Rob Reneman, our founder, is online watching us now from his house. He was unable to come because his legs won't carry him anymore. So he says hi, he sends his love to all of us, and we're still happy that he might be hanging around in his chair at home to watch us. Well, the HS BAFTA has three levels. We have the pre-PhD for bachelors or masters. They can interrupt their academic study for a year, fully paid, and can do research in a department that they like. We have a PhD. I think this is the most powerful one for PhD students. They can go abroad for 3 to 6 months with a little grant of like 10,000 euros just to cover their extra expenses. And they can have experience there, cultural exchange, scientific exchange. And of course, they're in a better shape for then going for a national grant like the Rubicon or in-house for Coatstra and all these kinds of grants. And then we have a 1 year fully postdoc that is paid for after. And you have to go also abroad to a famous institute. And then with the idea that you come back, but if not, that's also good. At least then we have another ambassador for CARIM set into the big world. We also used to have a tenure track program, but the faculty took that over. But then we'll still cherish our tenure trackers, our previous tenure trackers, and we call them talent trackers. And we have regular meetings with them every year to discuss their advances or their questions and their needs. The people that were here last year see that one is missing. That is Ingrid Dijkgraaf, but Ingrid Dijkgraaf made it to full professor. So she dropped off the talent trackers and she is now on her own. She is a big lady now. So these ones, their future is bright. We see them every year, and we hope they will continue to work for our nice institute. The professors, as said, there are many. And as you would directly see, half is female, half is male, so that is really nice. So we succeed in something at least. These ones have become a professor in 23-24, and actually Judith has to still wait for I think 3 or 4 days, because she will be appointed December 1, so next, or I think it's on Sunday, so a Sunday child. So this is actually our developing talent within CARIM. And everything, of course, we get from our huge PhD community that we have in CARIM. We have approximately 250-300 PhDs students attached to CARIM, and we have a very good society, the I'm CARIM group, You can see them here. They're very active now. They made a great movie. I showed that last year, so it's still on the website. You can look at it. So why you should become a PhD student at CARIM. But they also make this guide, and this guide is really very helpful. Here you see already the 3rd edition of that guide. You can pick it up at CARIM if you'd like it. There's so much information in there. Even if you're like a later or a more advanced PhD student, it's still very helpful. So if you don't have a copy around, at your office or your department office, pick one up at CARIM Bureau. At least then also we see some people, because maybe not everybody knows where we are. I call it Patagonia, so we're like in the really far furthest away 5th behind alley that you can find in our university signal 50. CARIM has 3 divisions, and we try to make it simple over the last decade. And you all know, of course, this sort of plan from CARIM. We have 3 divisions: blood, vessels, and heart. And that's really easy to understand. And now, of course, we are very closely attached to our hospital colleagues in the Heart and Vascular Center. And basically, we are on the verge of almost done to get together and really fuse these 2 hospital and academic units to one CARIM plus HVC unit. And as you can see, if you align the main topics of the Heart and Vascular Center, you can see that they really fit very well with our 3 divisions. So the blood fits very well with cardiovascular thrombosis. The vessels, a lot of research is being done on metabolics. And of course, the heart typically goes with heart failure, being both the old-fashioned heart failure as we know it, but also arrhythmia, which is of course heart failure by itself as well. So this fits very well. And also for all these 3 divisions, we have extensive postdoctoral clinical courses, the CAS-AM, the EVC, and the DASCAM. And these courses are very well visited. People are in line for these courses. They cannot all attend. They are very famous. And what is more important, they are supported by the national and international professional societies, as you can see on this slide. When we figured out a way to try to attach the Heart and Vascular Center to CARIM, we said, well, we're going to put in some money and develop some translational lines from the bottom. We put on PhD students, and basically we started with these lines on atherothrombosis, on aorta pathologies, and heart failure and arrhythmias. And this we actually grew until what we are today, with these 3 previously shown very strong connections that we have. And if you see here, the green pillars, they are technological pillars, and it's the stem cell, the Scrum lab that is now operational and growing, the imaging, the biobanks with all the tissue and the data in there, and of course the modeling, especially modeling the heart and predicting outcomes of therapy. And if you look closely, these basically are 4 technology pillars that do not use extensively animal experimenting. So we're going a little bit towards using man as experimental models, and especially with the stem cells, of course, this can bring us to a incredible height. We're developing this, and I'll tell you a little bit more about that later. So last year, I told you we were going to fully integrate CARIM and HVC boards. And what really helped is that we got a new director of the Heart and Vascular Center. And with him, I think within half a year, we now finalized joint board of CARIM and HVC. You can see that on this slide. So you see on this side, this is the management team of CARIM. We have the daily board, which convenes monthly. The Heart and Vascular Center has their management team and their daily board. We joined those 2. You can see that on top. We meet monthly and once a year, and this will still come. A lot of people are invited for sort of an annual big meeting, and maybe also coupled to a sort of semi-symposium to hear about everything that we would like to implement in our new joint venture. So this was actually very effectively done within half a year. Thank you, Kevin, for thinking and doing with me. Our website, please visit it. There's a lot of information. There's so much information there that I believe that not everyone looks at this website regularly because we get many questions that you can find back on your website. If you have suggestions, please tell Tara. We're going to expand a little bit so that we have all like more information about grants, about procedures to get grants, especially internally. Getting these fees to help you write with grants. A certain path has to be followed to get that. If you don't do that, you disqualify for those grants, and that's actually a pity. So use the website and please give us feedback on how it should evolve and improve. Some key figures of CARIM. We're all really steady, around 20 million annual budget. In 23 we got 10 million indirect funding. That's very good this year. I think we'll reach that again. Danny, you're nodding. He's not. Danny's nodding. So that works out. We have 11 clinical departments, so that tells you something about our translational activities. 6 basic departments. They are very strong, maybe twice as strong. So then we have 12, 11. So that's something that we should think about. 63 PhD theses, that is very high and all of very good quality. A lot of scientific articles. I think we made this huge jump during COVID when everybody had some time to write, I think, and that we kept. So we have a lot of scientific papers with an average index of higher than 2, so meaning higher than twice better than the world. And if you then look how many papers we have in the top 1, and that is 3.3%. So that is more than 3 times world average. So that's very good. So the grants, we were very successful. Here you can see all the grants that are above 250,000 euros. And we have 2 Ledux this year, and these are also very difficult to get for Leon and for Uli. And WO, also very competitive. We also got quite some of those. Veni for Job, that was very good. And here you can see even more. So we reached actually almost 10 million, and maybe we can top that of 23, and we hope that will work. Another advancement we had is by Michiel Henskens. Michiel Henskens was asked to coordinate the Hartenbank from the Dutch Heart Association, and this has become a success. Basically, this started a couple of years ago, also with the help of Blanche Groen and Roger Veltrop, and they decided that the initiative should come from Maastricht. And it was a success. They worked together with the Brain Bank, so now they work hand in hand. And I think, Michiel, if you're here, I think you now included the 21st heart already. And there's a really nice website. You can find that with a sort of self-explanatory map how to donate your heart. And it's a really nice website. And well done, Michiel. There are more prizes. You can see them here. We have Stijn Achten, got an important ISTH award. Annie Baker got an ERC Advanced, his second, and that is quite unusual, so he is a pretty rare breed. Michel Jacobs, at his farewell event, he got the MEMC Plus Award. We got the NHR Kwaliteitsprijs to Kim van der Velde, the Bachelor Student Prize to Jente Willems, big award in London for Judith Sluimer, and present here also today, Vanessa Breuker got the Best Presentation Award at the National Dutch Society of Thrombosis meeting in Koudekerke. So congratulations with that, poster girl. Then we had a crowdfunding activated, and you know that every year when you have a crowdfunding and you reach a level of 25,000 euros, CARIM doubles this with another 25,000, and that can get you ahead for doing your research. This year it went to the Hart Maat team, and that's a really successful team. It's a good impact on society, but also on science, and I could congratulate them as well with their maybe even a second time that they got the crowdfunding. And this year I heard that Joost Lumens is preparing something, so good luck, Joost, and reaching the 25,000 euros. The organogram of CARIM, You might know this, but we've changed it a little bit. So the executive board, in green you see the Research Council, Grants and Incentives team, the strategic board, and the Diversity, Inclusivity and Social Safety board. The green blocks directly have a representative in the daily board of CARIM, and the white ones through indirect connections. Under the executive board, there's the 3 divisions, the 6 programs, and the 6 basic and 11 clinical departments. The educational program committee is also here. And an important feature of our new executive board is the priori. Every year we choose 2 CARIM members by draw that can then have a seat in the board for a year. There are some change in the division leaders, as some division leaders disappeared and some are close to their retirement. And on this slide I will show you the new division leaders. Judith Sluimer will be division leader blood as of next year, and as of last month Casper Schalkwijk has become division leader of vessels, and Professor Lumens has become division leader of heart. So thank you already for your efforts until now, and Joost Lumens already represented me at the faculty board, and he did such a great job that the dean said I can stay at home and he can or she can now do with Joost for the rest of the time. So that was a very good compliment. The boards, the Research Council, this is actually the most important board of CARIM. They evaluate all our grants that we either send out to NWO or the Hartstichting, but also the internal ones, the PhD call, the postdoc calls, the BAFTAs. They do it all, and they do it with an immense amount of energy, and I think we cannot thank them enough. And they now just finished the PhD call. The results of that call are now known. You'll be informed very shortly. And maybe, just maybe, I just talked to the director of the Health Foundation Limburg. There's an additional one that can be funded through the Health Foundation, as we did last year. So the ones that are not rewarded by CARIM, there might be a second chance, but we have to look into that. So the results will be you will be informed of results pretty soon. The Grants and Incentives team, you can see them here. They help us in identifying the good grants, where to submit, and also how to submit. The strategic board, they advise the daily board, the executive board of CARIM, when they're asked, but also when they're not asked, so they can criticize what we're doing. They do this really effective, so thank you for that. And then we have our educational program committee, you can see here. And this program committee is responsible for the PhD programs and how to run them, and also the master programs by the Education Institute. We chose recently 2 people for the CARIM confidential board, 2 confidential advisors, Dr. Magdi Nagy and Professor Peter Leeuw, who is here present today. Thank you, Peter. And these are for all the youngsters and also all the elderly. If there's something, if you encounter a challenge that you're not sure if this fits with the job, and you're not sure if you have to go directly to the confidential advisor of the faculty or the university, these 2 people that interact also closely are ideal to talk to and see how they will advise you to get along or get ahead with your challenges within CARIM. And so if there's anything that you're not sure about, ask them. And a decade ago I would say visit the Beauty and the Beast, but I think I cannot say that anymore. But Magdi and Peter, they will listen to all your challenges, and you can already talk to Peter here today. Some strategic initiatives. We increased the number of technical staff. Technical staff is our backbone. Technical staff is the only continuity that we have in our departments. So we really should take care of them, treat them well, and we're going to invest a little bit more in them. We're still working on our expert group of cardiovascular data sciences. There are some positions, so if you're interested, contact us. Same with the Committee of Diversity, Inclusivity and Social Safety. We have our CARIM PhD call. I just mentioned this. So the results of the 24 call are known. In 26, we'll have another one, a little bit less, because the faculty is sitting on our backs a little bit, taking money from us. So we are not sure if we can do 3. The CARIM Assistant Professorship, that was a really successful round. We have a candidate, and he might be here. He started in this month, Paul Mendes from Charité in Berlin. He joined the group of Judith Sluimer, and is he here? Good. Can you put up your hand, Paul? Hi, welcome, Paul. And so that was also a very successful program. I really would like to continue that, but we have to see how we will manage in the coming years. Then this day, for the first time, we're going to announce the CARIM Anna Maria van Schuurman Stipendium. That's for a young, talented female researcher to get a startup within our CARIM Institute. We invested in the CARIM HVC Lighthouse program. I'll show a little bit about that after this. And we're going to organize, under the lead of Sabine Damen, a CARIM postdoc retreat in which postdocs and assistant professors can go for a weekend or maybe a Friday and a Saturday to a remote location, talk about life, talk about science, and of course drink extensively in the evening. And CARIM will pay for that all. The CARIM Lighthouse project. So we decided last year to put a dot on the horizon, and this is basically sort of an analogy to what JFK said when he said we're going to land on the moon before the end of the decade. And we said we're going to apply a clinical CRISPR-Cas treatment to a patient, and then most likely with arrhythmia. And we have set together a team, and if you look closely, you see, okay, where are all the ladies? There's one, but basically what we're going to do is get arrhythmia patient, and most likely from the worm study from Paul Volders and Rachel Terbekke's families. We're going to get stem cells out of that. We're going to recreate the myocardium in the lab. We're going to see if we get a laboratory phenotype. We're going to repair that with CRISPR-Cas, and then we're going to apply that procedure to the patient with help of cardiothoracic surgery. And this is outlined on the next slide. So when we have arrhythmia, you can see that we can take the white blood cells, we'll get them back into the induced pluripotent stem cell lines, from which you can then differentiate into the cardiac tissue, which we can then put in the lab. It will contract. We can see if we get an arrhythmic phenotype. And this is, of course, now the big challenge. So if there's anyone in the audience that thinks he can help us with obtaining a arrhythmic phenotype of stem cell-derived cardiac tissue in the lab, come to us and help us in getting this goal. And then, of course, we're going to repair this mutation with CRISPR-Cas, and the successful one we're going to apply to the patient, returning the patient's heart back into sinus rhythm. And this is a long-term goal. We have 5 years. We're going to invest a lot of money in it from CARIM. And already we had a meeting, and it was a vibe in that meeting that was unheard of. So it's really nice to have everyone together, all different divisions, clinicians and basic scientists, to tackle this big program. So if you think you should be part of the program, contact us and we'll take you up in that community. We have some highlights as well, because we do also some social activities, and this is Walk with Your Doctor. It's an annual walk. It's organized by the Health Foundation Limburg, and you can see here there's a check of 50,000 euros. That's beautiful, and that will all be put back in research. Not all cardiovascular, but a lot. I think this one will probably, because it's this will all go to cardiovascular work, I believe. It's really nice. Go there. It's always like in the late summer. It's always good weather, and join them and get your team together and get them to donate for the Health Foundation Limburg, because Health Foundation Limburg helps us again. We have the World Thrombosis Day every year at 13th of October. That is the birthday of Rudolf Virchow, who designed or actually hypothesized his triangle. What are the origins, the etiology of thrombosis. And this time we went to a elderly home, Vitala Plus, and then we tried to convince them that they should put the Dutch Thrombosis Foundation in their last will, but we're not sure if we were successful with that, because also the Thrombosis Stichting has a great lack of money, because everybody donates to the Dutch Heart Foundation. But for the thrombosis, there's a special foundation, so do not forget about that. Mensana in corpore sano, the longboat rowing, prominente roeien, CARIM won again, 4th time in a row. And that's not only because there's only one longboat, but we did really well. And this time you also see the team again with the big prize here. And I think there's 4 times CARIM on there now. And so next year we do it again. So if you would like to be part of this team, it's really a very nice experience. You get some lessons, so there's no experience needed. And then you go on the Maas and you pull your arms out of your body, and it's really nice. And afterwards, of course, there's fun, drinks and some food. Same with Maastricht Mooiste. We also participate with that. You can see here, after the run, the successful candidates. You see Sandrine smiling, very happy, and also a runner. That is good. Social, we even go further, as most of you will know, because we sent the invitation. Every first Monday of the month, there's CARIM Café. Please meet there, meet each other, talk about science, and have some beer. And that was my half hour. Almost. So please go there. It's a nice atmosphere there, and you can have some drinks and talk with your colleagues. Well, I think that concludes my overview of this year. Today we have a very great program. As you can see here, the lighthouse as a metaphor on the front. We start now with the clinical care session moderated by Kevin Vernooy. And then we have some special lectures in the afternoon. One by Hans Bruinings, who might join us later in the morning. And then, of course, at the end of the day, our famous Robert Reneman lecture is given by Professor Shiv. He is here today. He came late last night. We had some very nice dinner and is now setting up his presentation. Okay, with that, I would like to end. Thank you for your attention and invite Kevin to come forward and start the first session. Moet hem even aanzetten. Naar voren en boven, ja.
Tilman, thank you very much. I think we should start with the first presentation. And it's called, now the session is called Clinical Care. I think it shouldn't be called Clinical Care, but Clinical Research. And especially since we are really fusing now the Cardiovascular Center with CARIM, I think we're really a translational institute. So we shouldn't talk about them and us, but it's all together. And with that, I would like to introduce Bas van Bussel, who's going to talk about to look more precisely. And Bas is actually one of our internist intensivists, so working at the Department of Intensive Care in our hospital. And he's also, I could say, a clinical epidemiologist. I'm looking very much forward to your presentation, Bas. The floor is yours.
So, thank you, Kevin, for the introduction. We'll see how it works. So it's about to look more precisely. That's what I'm going to talk about. You'll hear what I have to say on that. Oh. Just have a see how this one. Does it work? Oh. Yeah, it works. So this is me in the clinic. You can see I'm at work in a team with many others. So there are nurses, surgeons, anesthetists, intensivists, and we all work together on this patient. You see that a lot is going on in the emergency ward. And you can also see that a lot of resources are used because there are many people of the hospital involved with this patient at this moment. So from the COVID pandemic, we learned that scarce resources drive patient selection and worse outcomes. In the panel, you can see data from the National Intensive Care Evaluation, which we evaluate together with them. And on the x-axis, you see time. On the y-axis, you see the observed expected number of patients that were admitted in Dutch ICUs. The blue areas indicate the peaks of the pandemic, and you can see that the occupancy ratio was much higher in those moments of the pandemic. This had repercussions to the non-COVID patients, like the normal ICU patients, also the cardiovascular patients. You can see this in the lower panel. It's the same figure, but then this is plotted for the non-COVID patients. And you can see during the blue areas, or during the peaks of the pandemic, many patients were not admitted to the ICU. So this looks like patient selection. And what happened to those patients? We also evaluated their outcome in terms of survival. And we found that the total survival was worse in these patients. So you see the odds ratios here plotted for the total group, but also for the subgroups. And look, for example, at the CABG patients. The ones who were admitted during the COVID period did worse in outcome terms. So we feel that use of resources to do the most for the most is important, but then we have to have good selection criteria. And we can do this based on data for prognosis. And here you see, well, all of you are probably familiar with this arrow C curve. We use data to make models, to do better predictions and make decisions in care, to do the most for the most patients. So from the COVID, all the doctors in the ward said we should get models for COVID patients to get this prediction going. So I'll tell you what we've learned. Here you see a systematic review which we did, and we reviewed all the prognostic models that were available. You see the red bars indicating the risk of bias. The green says there's a low risk of bias, and red there's a high risk of bias. And you can see that the over risk of bias in all these 580 prediction models that have been developed during COVID was really bad. And most of the problems were in the analysis part of the models. So then we said, well, how do these models work then if we apply them to data from our region? So we collected data from Belgian part, the Dutch part, and the German part, and we applied this model to this cohort. So we did an external validation of the most promising models. And the most promising prediction model for prognosis in the region was a model that had unclear risk of bias. There was no model with low risk of bias. So we got to an area on the curve of 0.7, which is quite all right, but not the one that you really need for that patient that's in your ward. So then we thought, well, let's add more data to it and update and extend this model and see if we can get better prediction for this prognosis for the patients. And we got to an area in the curve of 0.74. Well, you can say this is okay, but I think we still need more to apply these kind of models in the clinic. So some say that, or some believe that more complex modeling will be the solution to this problem, but well, we don't know that, do we? I think that complex modeling might help, but we also need to look more precisely at the data. And with precisely, I mean we need to look more accurately and precisely, as in the right panel in the top right corner. You can see that's what we need. The bullet needs to be on the right spot, and all the spots need to be in this bullet. So that's what we need. So this is a picture that shows you how prediction modeling, how you can think about this. It's about the population you want to do prognosis in, also the performance of the models, which I already show you was not very good during the COVID period. And then it's also about the variables, the green bit. So I will talk about the population and the variables bit, because that's often omitted by many. And I'll show you some evidence for that. So I'll talk to you about table 0. I'll talk to you about reporting and measuring the predictor variables, how you can do this properly in clinical science. And I'll show you 3 examples of enriching data sets in a way that we can learn more about these data sets, about patients. So last year, my colleague Frank van Rosmalen was here, and he explained this in this spot, this paper. It's about table 0, documenting the steps to go from a clinical database to a research data set. I will not rehearse his presentation, but I will give an overview. And what he basically did, he put the plug into the electronic patient dossier, electronic patient files, and collected all the data. And he had 55,000 admissions in the ICU between 2013 and 2022. And then he started cleaning meticulously. And you see all the steps in the figure going down. And he went to true admissions on the ICU down to 21,000. So that's a real different number. And this is just about the patient numbers. And you can imagine if you apply machine learning to the data set of 55,000 or to the 21,000, you might end up with totally different results. So this is about the population. The population is important to get prognostic research going. What about the predictor variables and the prognosis for the ICU? Here, 2 of our PhDs and postdocs, Eline Cox and Danique Meijs, did an extensive systematic review, and they reviewed all the prognosis models that are available in the intensive care. They got to almost 60 models, and from those models, they started to collect all the variables that were in those models. So now we know which variables are used for prediction in the ICU, and we have collected all of them. There's almost, this is a small written, but I can explain to you. So all the models had almost, in total, there were 750 variables, and Elina and Danique classified them into categories, such as demographics, chronic diseases, acute physiological derangement, laboratory variables, to get more of an overview, and outcomes as well. And then they started to score whether the units of those variables were reported in all those prediction studies. That was quite done in a good way. Next, they scored whether the definition of the variable was reported. And this appeared unclear for several variables. So this has to do with reproducibility. How are you going to reproduce your prediction model if you don't know the definition of your variables? Then they also scored the method, the moment of measurement of the variables. And in the ICU, this is important because we continuously monitor our patients. So we have a blood pressure every minute. So you need to describe in your paper which blood pressure you took, the first one, the highest one, the latest one. But that's not reported often. And then finally, they looked at the definition of the variables. So in the ICU, you can measure blood pressure using a cuff, interarterially. There are some different methods. And if you don't report that, if you just write down blood pressure, you still don't know and you cannot reproduce those prognostic modeling studies. So Elina and Danique did hold this job, and it says that the reporting of variables, it can be much clearer to get to more reproducible studies. So then, what about measuring variables precisely in the clinic? We can, and I would like to invite you to look at this poster later on. It's by Eda Eidenitz. She, I will not, it's a sneak preview, so I will not explain everything to you yet. She looks very precisely into the right ventricular function during mechanical ventilation and investigates what are the effects on the heart by the mechanical ventilation. And in this poster, you will find out that we can measure very exactly in the ICU. So there's an opportunity, I think. So what about enriching data sets to learn more? I told you I'm going to show you three projects. This is the first project is the Humanicare project. And in this project, we aim to combine the clinical care with research. This is a nice interview that Claire Pinks, which is a fellow of the intensive care, she's trained to become an intensivist, gave recently. And it explains about the Humanicare project. And it's about, knowing the patient, the person behind the patient that's admitted in the ICU. Many patients are admitted, they are intubated, you cannot talk to them, so you don't know what this patient wants in life. And we feel that we could learn more by including these kinds of variables in our data set. So Claire and other clinicians started to collect data on quality of life before ICU admission, for example, or how family connections are for this patient and hobbies of the patient. So this kind of data is often omitted, but we feel that it's important to do, prognosis that is relevant for patients in the future. Then another way to enrich data set to learn more is our clinical facial approach. You might have seen this in the CARIM report, also this picture. What we did here, I will explain to you as follows. As a kid, you might have been sick at home with your mother, and your mother said, well, you don't look well today. But what does your mother mean at that moment? She says you don't look well, you stay in bed, and then you try to recover. These kind of variables are also used by healthcare professionals in the ICU ward. They look at the patient and say, well, you don't look well today. But it's very hard to quantify this scientifically. So here you see the picture of 15 egg-like faces that have been drawn up by Iwan van der Horst when he was in Groningen still working. And he said, well, I look at the eyes, they get slit more, and I look at the color of the face. So very pale, normal face, or blushing face. And then he set out to a team of students, and they went to score these faces in ICU admitted patients. And they just scored. They were students at third year grade, and they really don't know everything about diseases yet, but they were not biased, and they scored. And in this way, we tried to characterize this view of your mother when you're sick. We added this to the data sets. And then we started to analyze and investigated whether the facial expressions were associated to multi-organ failure over time. So we measured multi-organ failure during the 7 days after admission. We used the SOFA score for that. That's a well-known score in the ICU. And you can see that we found that the black line below is about the people who had the eyes open mostly. And they had the lowest SOFA score during the 7 days. So we concluded that there's also prognostic information in the facial expression of the patients. And that's also a way how you can look more precisely at your patient and enrich your research data sets. So together with colleagues in Eindhoven, we went further and because we were interested in this topic, and we did a systematic review on this topic to learn more. We identified 13 studies and identified 35 new facial clues. And those facial clues are potential clues that we can investigate in another way, and they were divided into 2 main topics. It's about facial appearance, for example, a pale lip or a blush in the face, but also facial expression. A patient might look sad, and you can differentiate between that. So this obviously needs further study, but we're onto that in this field. Then a third way to enrich data set. In the beginning, I already showed you some data of the National Intensive Care Evaluation about COVID, but we went back to NICE and started on another project. This is about socioeconomic status. Well, we know that Statistics Netherlands has very precise data on socioeconomic status on the household level. And we know that our National Intensive Care Evaluation, which we use for benchmarking ICUs between different regions and different centers, has a lot of clinical information about patients. So basically what we did, and Jip de Kok is one of the PhD students working on this from Maastricht, we did move the NICE registration data and couple that one to the Statistics Netherlands data environment. That was a hustle. It took like almost 2 years to get this done, but it is done. And we managed to, from the total data set between 2014 and 2022, for all Dutch ICU patients admitted in the Netherlands, we went from almost 700,000, and finally some dropouts. We got over 500,000 patients coupled in the right way. And we're now investigating the socioeconomic status of those patients. In the right panel, you can see a map of the Netherlands, and we divide this in ROAS regions, the acute care regions, and you can see that the most intense color is Limburg and Zeeland, and the middle of the Netherlands, and those are the areas where the socioeconomic status in the ICU population is clearly lower than, for example, in the middle of the Netherlands. So these are the first results, but Jip and colleagues are working on evaluating more results, and what the question we actually want to address is, can this socioeconomic status differences in population explain some of the extra mortality that we observe in especially Limburg hospitals? So we think that there is more information in this kind of data, and we try to evaluate this on a national level. So we'll come up with more results, I think, in the next year. So to look more precisely, as healthcare faces scarcer resources, we must use precise data to guide us and to do the most for the most. I think this is very important. We have to look beyond the data analysis methods. Everyone wants to do machine learning, AI, but we also have to look at the data, as I showed you, and I hope you agree with me now. We need high quality data, and that's both precise and accurate. Then we need collaboration, as I showed you, to enrich the data sets, the existing data sets, to address new questions. And this can particularly be done within CARIM for cardiovascular diseases. I didn't show you yet, but we have more data sets ready that can be enriched by several of you if you want to collaborate with us. And we like also to have diverse care and investigator teams to foster more precise patient characterization, because all the views help to get the patient characterized in the most complete way. So the take-home messages are, we know our data, we know its origins, we like to do things properly, and we aim to foster data collaboration. That will finish my talk.
Bas, thank you very much for a very comprehensive presentation and to see how complex it is actually to use large data. Are there questions from the audience? To kick off, Bas, I was wondering actually with the prediction models, because on the ICU there's a variety of patients who are actually admitted, from sepsis up to elective patients after CABG, for example. Can you all combine that data, or is that valid or mostly used, or should you have like subgroups? How do you look at that?
Well, the models that we use mostly now, the PACO4 model, is a very model that we use for benchmarking, and that actually uses all the patients because you want to compare ICUs between each other. Of course, there are also initiatives to look at patient groups or subgroups, and there might even be, more specific prediction models for those groups. So I think you need both. It depends on the question you want to ask and the research question you want to investigate. Of course, if you have general questions, say, well, is my ICU, is the survival in my ICU as good as the ICU, for example, in Genk in Belgium, or do we have differences? Then you should do the whole population. But if you want to know about cardiovascular diseases, particularly, then you should use different definitions and also different models. What I find interesting is that within our HVC CARIM, for example, we collaborate a lot with our cardiovascular surgeons, and they have their own models. And these are the same patient groups. And it would also be very nice to do comparisons between those models and see why there are differences or other differences between the ICU cardiovascular group using the ICU models versus the cardiovascular surgeon models, for example. But I think that's interesting to explore further. Okay. Yeah.
Thank you, Bas, for a very interesting presentation. I was just wondering, so the way we categorize patients now is, for example, with a prior history, let's just say diabetes. And I also agree, we just say this is a diabetic and this is a not diabetic, and we just categorize them into different groups. But of course, there are differences between diabetic patients, and the same for heart failure and other diseases. The question is, how far are you willing to go? How further can you distinguish this until you decide at a certain point that this is a group? Because you also have limitations because of the number of patients. And so at what point do you decide this is enough stratification and we decide to take that group?
Well, so prediction is always about populations, as I showed you, and the ROC curve will never get to 1. Because patients are really different. But for practice, it would be nice to have stratified the models to the most you can, but then you need to have the data. So the data, in fact, will determine how far we can go with stratification and learn more on specific patient groups. But that's still, then it's still important to categorize and label your patients rightly. So you have to have the diabetic patients labeled rightly. So, for example, in the COVID period, we measured HbA1c in the COVID-admitted ICU patients, and we found a lot of new diabetic patients. So those will be in your general data set, but you will miss them if you look at the history of diabetes only. So it's also about how to classify them more precisely. And basically, it's also a question about how big are your strata to do valid modeling. But I think it's interesting to look at all the interactions between those diseases, because that can also teach us something. Yeah, thank you.
All right, with that, I would like, are there more questions? Sorry.
Thank you very much for your presentation. I have a very quick question about the missingness of the data. You are very nicely showing how important it is to don't have missingness, because of course rubbish in, rubbish out, especially for complex models. But now you found out and very nicely quantified the missingness in the data, but what are your views? How would we go back to fill the missingness in the retrospective patients? Because these are ICU patients, they are likely not coming back. What are your views on that? How to retrospectively adjust for missingness?
Well, that's also a very good question, because missing data is always an issue with the retrospective data. There's information bias. It can be because the patient is sicker that you miss the data. It can be because it's random, and that's what you need to find out. You can only think about that. Basically, what we're doing now with the big data set I showed you of my colleague, the table 01, is that we trying to develop general cleaning methods because they are not available yet. So we use rules to do cleaning, but that goes data scientists together with clinicians go through the data set. For example, I went through the data of heart rate, and a heart rate of 0, then the patient is not alive. But is the heart rate of 0 a valid number or not? It depends. In the ICU, sometimes the heart rate is 0, and we do CPR. So you need to really understand your data to classify something as missing or wrong and what it means. So I think you need to collaborate with data scientists and with physicians and nurses to evaluate what the mechanism of missing data is. And for each mechanism, there are different solutions. Some you can do with imputation methods, and some you can only use to think about or stratify or work on into your analysis. But missing data itself, well, it can also be a challenge, but it can also teach us something.
Thank you.
Mark.
Thank you, Bas, for your excellent overview. From the clinic, it's a challenge, I think, which patients should be transferred to the ICU. So my question is, do you also focus on research before the ICU? This for your patients which you are judging with the SIT teams in the clinic, maybe we can also look more precisely to what factors would be useful to take into account whether a patient should be transferred.
Yeah,
what do you think about that?
That's a very relevant question. Together with some of our colleagues, Rob Driessen and Verona Gerardo, and they're also here, I think. We already dove into this question with colleagues from Catharina Hospital, and we try to get there is a model that helps to do this, the Escobar model. But we need to validate this for the Netherlands. So we're starting a big data collaboration with Catharina, with Erasmus, to get a lot of ward data together to evaluate this model and try to even adapt, and like I showed you for the COVID models, to update and extend those models for the Netherlands to see whether we can do some more prediction on readily available data. The SIT teams are very important for the ICU to do outreach on the wards to help nurses that if patients are deteriorating. Well, me and my shift, I also have to decide to take the patient to the ICU or not. So this is a real question, and we already set the first step to do the data sharing and the protocols to get these data together to learn more about this. I think that's a very important. Well, for if you want to see and evaluate passende zorg or that kind of care, it's a very important question. Yeah.
Bas, thank you very much for your presentation again and the questions asked, and then we'll continue with the next presentation. Thank you, Bas. The next presentation will be given by Elam Bidar, one of our cardiothoracic surgeons in our hospital, and he has a very interesting title, calling a Song of Ice and Fire. So Elam, I'm looking forward to your presentation, how the title matches your presentation.
Yes.
The floor is yours.
Thank you, Kevin. I will try to open it first. Very sorry, I don't see it here. Ja, hij gaat. Het is heel raar. Oké. Ja, dat deed ik net met een verdwijnt helemaal.
Goed. Dat ziet dit ding. Die gebruik je toch niet. Of zeg maar goed.
Okay, yes, we can start. I'm Elham Bidar, one of the cardiothoracic surgeons here in Maastricht, and part of a really great CARIM HVC family, as Tilman said it. And today I would like to discuss a new surgical strategy that we have developed in the past 2 years. And the bottom line is, I think nobody likes hypothermia. But we use hypothermia during complex cardiothoracic surgery. And I'm going to first start with the dilemma of using this in complex surgery. And I'm going to conclude that, well, reducing hypothermic circulatory arrest time is beneficial for patient outcome. And stay tuned, because at the end, I will demonstrate a new surgical strategy that we have developed. So to fall with the door in the house, this is an open chest setting of a beating heart. And I hope you can see the right ventricle on top and the ascending aorta with a normal diameter. I hope you can see the difference with this heart, because this is as an ascending aortic aneurysm, which has pushed the heart aside. And these patients are operated electively because there's a correlation with development of type A aortic dissection, which means that blood enters the vessel wall through an intimal tear, increasing the chances of developing further rupture and sudden death. This is what a type A aortic dissection looks like in an emergency setting. You see the blue coloring of the aortic wall. And typically, to repair this pathology, also aortic aneurysm pathologies, we use a systemic hypothermia. So we use ice and cool the patient down to stop the circulation. Hypothermia is not a new technique. It is literally the oldest method in the book. The first intracardiac defects were repaired in congenital heart disease while patients were placed on ice baths. And this is based on the idea, on the fact actually, that cellular metabolism significantly decreases at colder temperatures. And furthermore, hypothermia has other advantages, such as reducing intracranial pressure and reducing ROS production. These days, we don't use ice baths, not for this purpose at least, but we use cardiopulmonary bypass. And this is a machine that drains the blood from the right side of the heart, applies oxygen and the right temperature to the blood, and pumps it back into the aorta. And as you can imagine, if we have pathology of the aortic arch, we have to stop the circulation, not only because the arch finds itself in the crossroads between the heart, the brain, and the lower body. We have to stop the circulation towards the heart, but also the brain and the lower body, to find a bloodless field to be able to repair the defect. So this is a gold standard technique which is used worldwide by most centers. This is a schematic view of an arch aneurysm. Typically, patients are placed on cardiopulmonary bypass. The body is cooled up to, on average, 25 degrees. Then a cardioplegic and circulatory arrest is induced, and only the brain is perfused continuously through separate cannulas in the carotid arteries. Afterwards, the procedure is performed and finished, and the cardiopulmonary bypass is reinstalled and rewarming initiates. So there are three main events during this procedure: the hypothermic phase, the ischemic phase, and the reperfusion phase. And to start with the hypothermia, this is an illustrative analysis of a large registry of almost 4,000 patients, which has been published recently in 34 centers who underwent exactly this procedure. And this figure shows two important points. First of all, you can see that the depth of hypothermia between centers differ enormously. There's a range between 18 degrees to 28 degrees. So there is no real consensus between surgeons about how deep we have to cool in these patients. Secondly, and perhaps counterintuitively, you see that, well, patients who are operated in warmer temperatures have less mortality as compared to patients who are operated at colder temperatures. So this is an area which is not really clear yet. But what we do know, and what has been studied extensively, is that the correlation between the duration of the ischemic time and correlation with mortality. The longer the cardiac ischemia, the longer the visceral ischemia, the higher the mortality. So how this translates to patient outcome, this is a recent meta-analysis of 1,300 patients undergoing open arch repair, and you can see, well, patients have up to 2 weeks of ICU stay and up to 40 days of hospitalization and up to 20% mortality in elective cases, which is not really a nice clinical outcome. And in light of current discussions within healthcare systems about concentration of healthcare and centralization in more expert centers, one argument might be that doing that might improve these outcomes. And this is a study that illustrates that 2 of the largest centers in Europe pulled up their data on aortic arch surgery, and they looked at more than 400 patients, and you see they also cool up to 25 degrees, and they need up to more than 2.5 hours of cardioplegic arrest time and 60 minutes of circulatory arrest time. And when we look at their outcome data, 5 days of intensive care stay, prolonged ventilation times, up to 20% in hospital mortality. So the point here is technique and expertise alone does not improve patient outcomes that much. So we have to look deeper into the surgical strategy. And one of the most common complications after the aortic arch procedures is the systemic inflammatory response syndrome. This is a recent publication from China of more than 500 patients from one center, and they show that SIRS is prevalent in 30% after these procedures, but is an independent predictor of major complications of prolonged ICU stay, and this is actually something that we often see within the intensive care unit. In its extreme form, SIRS is a form of a capillary leak syndrome, which is not a very well studied, not very well understood clinical entity, but is characterized by hypotension requiring a huge amount of fluid resuscitation, high levels of vasopressor need, and eventually leading to multi-organ failure due to organ edema. So to understand that, we have to look deeper at these steps to see how this surgical strategy leads to this capillary leak syndrome. First of all, at the cellular level, hypothermia reduces the activity of the ion channels, and especially ATP-dependent ion channels, and sodium-potassium channel is one of those channels. Due to this reduced activity, the intercellular sodium concentration increases. This leads to cellular edema, but also as a result of that, the sodium-calcium exchanger reverses its activity in an attempt to recreate equilibrium. But due to this process, intercellular calcium increases. And for example, within the heart, the SERCA receptors that have to reuptake calcium channels from the cytosol are ATP dependent. So they are not reuptaken by the sarcoplasmic reticulum, and it leads to calcium overload. Calcium overload is a precursor to apoptosis and several damaging processes resulting, for example, to arrhythmias and contractile dysfunction in the heart. But during this strategy, as you saw, we don't rewarm the patients after this phase. We go into an ischemia-reperfusion injury. And ischemia-reperfusion injury is a very well-studied entity, and it is mediated by Wnt signaling pathway and partly by Wnt calcium signaling pathway in several organs, such as in the brain and in the heart, which also leads to calcium overload. But in our clinical setting, what we often can measure is a systemic inflammation. And this systemic inflammation resulting from ischemia-reperfusion injury directly affects the endothelial barrier function. And this is the step towards the capillary leak syndrome. The most potent plasma protein, which is albumin, is usually transported through a transcellular pathway within the endothelial barrier function, through the endothelias. But the paracellular pathway is protected, and it's closed by tight junctions in the brain, which is called the blood-brain barrier, but also by adherine junctions. And physiologically, if there is a local tissue damage, for example, local inflammation results in activation of endothelial cells, contraction, and the contraction mechanism internalizes these adherins to open the paracellular path for larger proteins to repair the tissue damage. But once this inflammation becomes systemic, then there is a systemic inflammation, a systemic capillary leak, which results into a capillary leak syndrome throughout the whole body. And within the ICU, we often see up to 50% loss of albumin within the first 12 hours. So this is explained by these, but this is mostly theory. Large animal models have been very helpful in addressing this theory and applying it, understanding it at an organ level. So here are some illustrative studies. This is a elegant study in which they included 3 groups of pigs, and they connected them with to the cardiopulmonary bypass, and they cooled the groups from 10, 20 to 30 degrees, and they looked at the level of selective antegrade brain perfusion at these temperatures. They wanted to identify the right temperature for that, and they maintained a mean brain pressure, perfusion pressure of 50 millimeter mercury. Perhaps counterintuitively, the 30-degree group had a increased intracranial pressure while they were perfused continuously, but all the other groups showed normal intracranial pressure during the perfusion. After reperfusion phase, the intracranial pressure remained high at the 30 degrees group, while the most protective effect was seen at the 20 degrees group. So they conclude the ideal pressure, temperature would be 20 degrees. They further followed up their study by another study in which they included 2 groups of pigs, which they connected to the cardiopulmonary bypass. They cooled them to between 20 and 30 degrees, and they induced 60 minutes of circulatory arrest, and they took biopsies from the different visceral organs. And it was expected that 20 degrees would have more protective effects, but this was actually more organ specific. They found that histological signs of apoptosis, edema, and inflammation and necrosis were more often seen within the 20-degree group in the small intestine and stomach, while in the 30-degree group, this process was seen more in the colon and in the liver. So, not really clear, but there might be an organ-specific effect to that. The cardiac arrest, it has been thoroughly studied, and we know that there is a clear correlation between the duration of cardiac arrest and mortality, but especially in patients with reduced cardiac function preoperatively, even short-lasting cardiac arrest periods lead to high mortality rates. So, summary until here, we have seen ICE, usage of hypothermia and its effect on systemic inflammatory response, capillary leak syndrome, and we saw that expert centers can't really improve patient outcomes in these complex procedures. So we were confronted with patients. For example, this is a 25-year-old Marfan patient who had previously had an operation and had a right ventricular infarction, and who presented with a right ventricular failure, who had to undergo aortic arch replacement. And this is a 75-year-old patient who presented with a STEMI, myocardial infarction, with aneurysmatic left ventricle, with very poor ventricular function, and who also required urgent aortic arch procedure. So in light of the previous data, you can imagine that we were really kind of nervous about these patients. So together with our team of perfusionists and with Department of Vascular Surgery, and actually based on extensive expertise on cardiopulmonary bypass within the cardiothoracic surgery department, we developed this new strategy in which we aggressively perfuse the organs throughout the procedure with warm blood. So we connect the lower body through the groin, and we implemented a new pump with a new heat exchanger within the cardiopulmonary bypass to perfuse the heart after we finish the cardiac surgery, therefore early reperfusing the heart with warm blood. So I'm going to show an illustrative case. This is an 82-year-old patient with an aortic arch aneurysm. We typically cannulate the left subclavian artery to the cardiopulmonary bypass and the right femoral artery, and for that we use this nice cannula with a side arm, and through the side arm we are able to introduce a balloon which is deflated in the descending aorta in the beginning. Then we connect the cardiopulmonary bypass to the right atrium to drain the heart. And during this period, the whole body is perfused, of course. We start with debranching the carotid arteries one by one under continuous transcranial Doppler monitoring to maintain the right perfusion through the selective cannulas within the arteries. As you can see here, the left carotid artery and the brachiocephalic artery are debranched and perfused continuously. And then the period of cardiac root operation for this procedure, we need to stop the heart temporarily. And usually the next step after performing the root surgery is to maintain cardiac arrest while we are trying to repair the arch part of the aneurysm. And now, and this is the innovative part, we reperfuse the heart early on after we are done with the aortic valve. And you can see the clampus plates, and this setting is very interesting also for future research. For example, we discussed about gene therapies. So you can see the heart is clamped, isolated from the circulation, but it's still beating because it's perfused with a warm blood cannula. And this enables us to open the arch further and position the balloon that we have earlier introduced in the descending aorta in the right position and prevent further ischemic times of the heart. And the balloon should be positioned in the right place, à vue, where we can see it, because you don't know in the descending aorta where the fragile parts might be and where you might have complications. So we introduce it in the descending aorta, inflate the balloon, and at this point you can see both the lower body as well as the heart as well as the brain are perfused. There's no circulatory arrest, and we are able to operate this 82-year-old patient, and he had a replacement of the entire thoracic aorta until the descending aorta without circulatory arrest, in a beating heart fashion. So we performed this procedure in 25 patients, and we were able to, so we had a learning curve, of course, and in the beginning we still needed cardioplegic arrest sometimes, and sometimes still circulatory arrest, but we were able to perform this procedure without circulatory arrest in 16 patients, and without cardiac arrest in 4, and reducing, as I demonstrated, the prolonged cardiac arrest times in most patients. Patients showed really, especially because these were very high-risk patients who were included, showed a very good clinical outcome. They had an average ICU stay of 2 days with a median of 1 day, and they were almost all discharged within 8 days from the hospital. Unfortunately, one patient died due to ARDS, extreme transfusion reaction, and during our learning curve, we still encountered SIRS within the first 10 patients, but late at the final patients, at the last 10 patients, we did not see that anymore. There are still a lot of fine-tuning and limitations, of course. We have to look at the ideal flow and pressure at the right temperatures per organ. We are looking for and finding monitoring strategies to detect organ ischemia at an early stage, for example, biomarkers, to which we can adapt our flow, blood flow, amount of blood flow. And of course, we need to find better instruments. We are now working on a large animal model, on a pig model, in which we are going to compare the cold strategy, the gold standard, with our new warm strategy. And with this, I would like to thank you all for your attention.
Elam, thank you very much for this nice presentation. Always intrigued by the extensiveness of your surgery. Really, my compliments to pull this off. Really well done. Are there questions from the audience? Yes. Yes, you already have a chance, please.
Yeah, thank you for your presentation. I have a question about the etiology of aneurysm in the cohort that you showed, where you were able to basically avoid the cardiac arrest. I don't know if you could go to that slide. I'm sorry. It was to the end of your presentation when you had this one. So could you say something about the different etiologies of aneurysm? You mentioned, for example, a Marfan syndrome patient.
Yeah. In the beginning, we actually included patients who were inoperable, because they were deemed inoperable because of the expected long procedure ischemic times. So this is a first experience, and therefore actually kind of has a selection bias, but towards more poor patients. At the end, at this moment, we operate everyone with this etiology, whether it's a Marfan patient or not, whether there's aneurysm, and we have implemented this technique in an acute type A dissection in an emergency setting. And it's important to realize that this is not one person's expertise. It requires training of the whole team, perfusionists, anesthesiologists, surgeons, to implement it in the right way. And it requires really intensive communication during procedure with the clinical neurophysiologists. So it's complicating the procedure a little bit, probably, as compared to the gold standard, but the patient outcome is really improving. So therefore, we really believe in it.
Yeah, I think you're quite opposite, actually. I think it's not a complication and it's not a criticism, but you can learn a lot when you are at the stage of the biomarkers. The different etiologies likely will be also the source of differences in biomarkers, and then the reaction to the surgery. Thank you.
Thank you. Yeah.
Elam, just a simple question. In cardiology, we're much more randomized than in cardiac surgery. And I was wondering, did you consider to randomize the old way versus the new way? And sometimes you don't even reach the power calculation to really aim. You can't compare 100 versus 100, but sometimes even like 15 versus 15 will already give you a lot of data showing that the new one reduces hospitality of the hospital admission for length of stay, left death or things like that. Did you consider to do that, or you thought first establish this new method before thinking about it?
Yeah, it's a very good question. That's actually a very relevant question for all of cardiac surgery. And the randomization partly depends on the volume. To be able to do a proper randomized control trial, we have to work in a multi-center setting. And one of the challenges is to create this paradigm shift where people will agree to do this, because usually we use hypothermic circulatory arrest, and some centers still use up to 18 degrees hypothermia and total arrest without brain perfusion, because it's historically developed like that. So that's definitely what we are looking for, and we discuss it. We have already discussed it with surgeons at different centers already. So it's a slow process, but we're going towards that exactly. This randomized control trials.
The final question. Oh, you get it. Perfect.
Right. Okay. Elam, congratulations. I think it's fantastic work to modify your technique, because in open surgery it's quite hard to keep on improving and improving. I'd like to ask you more of a visionary question. Where do you think the aortic surgery, mainly the proximal aortic surgery, is heading to in the next years? Because we've seen in the other parts of the aorta a 90% move away from open surgery, with only a few indications left, like patients with redo surgery or failing stents or hereditary genetic aortopathies. While in the arch and the ascending, there's still a lot of open surgery. However, also there we see an increase in endovascular techniques. Where do you think this will go in the next 5-10 years?
Well, that's a good question. I'm actually if the goal is patient outcome, and you can improve patient outcome with less invasive methods. Of course, we're going towards stenting and trying to do that. And we're actually now actively working with your team on trying to develop endobental procedures to stent this during emergency operations. So this is a clear movement towards less invasive strategies. I think there always will be a place for open surgery, and I think this is a development of a surgical strategy, but also development of the cardiopulmonary bypass. It opens new possibilities. For example, there's a research on organ transplantation and organ perfusion during the process of harvesting. So this strategy will have implications which are a little bit, I guess, broader than just this operation. While I also hope that at the end of the day we will be able to perform this operation less invasively for the patients, of course. That would be the best.
All right. Elam, thanks again for this great presentation, and we'll continue up to the next. And the next presentation will be given by Christine Binkers. She's a vascular internist working in the Department of Internal Medicine in this center, and she will tell more about the pulmonary embolism multidisciplinary team. We're looking forward to this new involvement actually in our center. Christine, the floor is yours.
Thank you for the introduction. So I will talk about the pulmonary embolism response team. I have no disclosures. And then maybe I have some listening instructions, because I think you're all here with sharp focus, expecting maybe some scientific data, complex data to be shown. But then I have to reassure you, or maybe disappoint you, because you can sit back and relax. This will be a simple talk about new developments in pulmonary embolism treatment and how it affects our hospital. So if we talk about pulmonary embolism, it's a blood clot mostly derived from the deep veins within the legs that travels through the vessels and then through the heart and goes to the pulmonary artery. And there, depending on the size of the clot, it might block the main pulmonary artery or go more peripherally. And as you can see here on the CT image, you can see a thrombus at the bifurcation of the pulmonary arteries, blocking the right and the left pulmonary artery. So it is the most important cause of in-hospital death and the third most common cause of cardiovascular death. So there is a lot of progress to be made. If you open a textbook, then you will see that the pulmonary embolism typically is a disease with the abrupt onset of pleuritic chest pain accompanied with shortness of breath and hypoxia. In the real world, there are 50 shades of pulmonary embolism clinical presentation. You can have the truly asymptomatic patient, and mostly it's a patient who had a CT because of another purpose. Most often it is a malignant disease, and then there is evidence of a pulmonary embolism, and when you talk to the patient, there are really no symptoms. On the other hand, we have the patient who comes in the cardiac arrest and gets a reanimation setting because of the pulmonary embolism, and there is all of it in between. Also, the onset, it has like the abrupt onset, which is typical, but you also see the gradually progressive, and you also see the acute on chronic. So it is a really 50 shades of pulmonary embolism. And these 50 shades, they also have 50 shades of the clinical outcome. When you have a low-risk pulmonary embolism, the risk of mortality is really low. It's below 1%. When you have a high-risk pulmonary embolism, the clinical outcome is worse, and mortality reaches up to 60%. The ISTH last year, the group of Leuven presented their data on a high-risk pulmonary embolism group in which 57% died. So that's a high number. And maybe you all have read this. I don't pay for this article, so that's why it is this color. But maybe you have read about this woman. She, a 25-year-old woman with an unborn child who died last month in our region because of pulmonary embolism. So it affects all age groups, irrespective of cardiovascular risk factors. So why are people dying? It is the right ventricle. So you have a block in the pulmonary artery, and then there is an acute rise in pressure, while the right ventricle, it has a small wall. It's not built to get to pump against these high pressures, and it becomes dilated. And as it becomes dilated, it won't be able to contract as good as it should do, and the output decreases. You also have the septum that goes from the right side to the left side, so the left ventricle cannot contract properly anymore, and you have like this spiral of decreased right ventricle output, which leads to decreased left ventricle output. Then you have the diminished coronary flow, and you get ischemia. So you can measure this with cardiac markers. You have markers like BNP, which give some idea about the stretch of the heart, and also markers like troponins, which tell you something about ischemia. And you can assess, of course, the right ventricular function with imaging. And echocardiography is probably the best one, but we use a lot of CT, because when you have a patient with a pulmonary embolism, you already have this CT scan. And on the CT scan, you can get a lot of information. You can see that the right ventricle dimensions, they are bigger than they should be. And what we measure is the right ventricle, left ventricle ratio, and you see it increase in pulmonary embolism. And you can also see the bulging of the septum from the right side to the left side, which is not a good sign. So in the ESC guideline, there are 4 different risk categories defined, which is low risk, intermediate risk, which has intermediate low, intermediate high, and the high risk group. And it is based on clinical parameters, but also on imaging and cardiac markers. And we do this so we can see what treatment people should get. So you have the high risk and you have the other risk categories. And in the ESC guideline of 2019, there are actually only 2 tastes in therapy. You have on one hand side anticoagulant therapy, and the other hand side you have systemic thrombolysis. So the only difference, maybe I have to put a bit of nuance, is that some patients are treated at home, some are treated on the general ward, and some are monitored more intensively on an intensive care unit, but the effective therapy is just anticoagulant therapy. I came to this in which they use anticoagulant therapy in pulmonary embolism in a kind of randomized way. And half of the patients were given no treatment at all, and the other half were given unfractionated heparin together with vitamin K antagonist, and they saw a mortality rate of 26% in the untreated group and 0% PE-related mortality in the treated group. There was one patient who died, but it was because of bleeding. There was no safety board at that time, but still the investigators thought that it was not a good idea to continue this investigation in this way, and they decided to include only patients in the treated group to see whether this low mortality rate was really true. And it was true. There was no patient dying because of pulmonary embolism. There was one more patient dying because of treatment-related kidney disease. So I think that the role of anticoagulant drugs, we all know it, and it will never disappear in the treatment of pulmonary embolism. The role of systemic thrombolysis is a bit less clear. This is one of a meta-analysis looking at the effects of systemic thrombolysis on the outcome of pulmonary embolism. And as you can see, it reduces mortality. Here you can see that mortality is reduced, and it is in the high-risk group and not in the low-risk group, which is logic, because if you don't have a high mortality risk, then this aggressive treatment can only do you harm. Whereas in the high-risk group, when you start with a high mortality risk, you can benefit from it. If you look at the real data from this study, the mortality is really, really low for a pulmonary embolism group. And I think that's a big problem in pulmonary embolism trials. It's that there are selected patients and they are less sick, and the mortality rates are in general lower when you look at these trials. Still, you also see that perhaps the mortality rate in the control arm is underestimated, because a lot of these patients who are included in these trials, they end up getting systemic thrombolysis when their situation worsens. So you have a bit of an underestimation. However, this systemic thrombolysis, the main problem is major bleeding, which happens a lot in systemic thrombolysis. You see here 9% versus 3.6%. And the one that we fear most of is the intracranial or the fatal bleeding, which is a big concern. And also here, these are the less sick patients. So in the real world, these numbers will be higher. And to illustrate what happens in the real world, this is a study in Spain. 5,000 patients went to the emergency department with suspicion of having a pulmonary embolism. Eventually, only 1,000 had pulmonary embolism. That's the ratio 1 in 5. It's the same we have. But as you can see here, there is only a small portion who has the intermediate high risk and the high risk. And if you see at the outcomes in 2019, this publication, 10% mortality. So we are still facing these high mortalities. I have an interim conclusion which says that pulmonary embolism, it has a wide spectrum of clinical presentation, severity, and outcome. Anticoagulant treatment is the mainstay, and it is sufficient for most of the patients. However, some patients still die, and I think systemic thrombolysis, it has proven its efficacy, but it is still quite dangerous to give. And also doctors are not reluctant. They don't give it as easily as they should do according to the guidelines. So I think we still have work to do. And in the past years, there are a lot of new interventions in the literature. On one hand side, you have the catheter-directed thrombolysis, and I think that's a good idea because you can reduce the dose of drug that you need to give. You don't have to give it systemically. You give it directly to the pulmonary artery. It's inexpensive. It's easy. Everybody who can place a catheter can do this. It has a bleeding risk, but you can also treat non-central pulmonary embolism, so that's an advantage. It's fast, and you have a bit of a delayed effect, so that you should realize. On the other hand side, there is a very aggressive marketing of a lot of new techniques which have mechanical thrombectomy, so you really remove the thrombus and immediately the right ventricle gets relieved, actually. It's expensive. I've heard that these catheters are about 16,000 to 17,000 euros each. You need experienced staff. You have to train them. They have a learning curve. And unlike stroke, this is not happening every day. So the learning curve takes a lot of time. You can only treat the central PE, of course. It's time consuming, but you have a direct effect. And that's true. I've been there a couple of times, and you really see pulse rate going down in a couple of minutes when they remove the clot. So it's impressive. If you have a look at the direct thrombolysis, most of the literature is about this. I think this is the furthest in all of the new technologies, and this is just one meta-analysis. You can find like a few hundreds, and you see that mortality is reduced. So they did catheter-directed thrombolysis versus anticoagulant treatment, and you see a mortality rate of 3%. On this side, 2% versus 6%, and the bleeding it's comparable. Again, here this is not randomized controlled trial, so you should not compare them directly. But still, this is promising. The HiPITO trial is busy at the moment, and it's comparing the effect of the ecosystem. So then you do direct catheter thrombolysis, but you use ultrasound, so the thrombolytic agent gets more in contact with the thrombus, and you have a better solution. It's including 500 patients with intermediate high-risk pulmonary embolism, and I think data will be there in 2025. And this might be practice-changing if it turns out to be better. Then you have the new techniques. This is one of them, the Inari system. It's a very big catheter. It's 24 French, so it's like a big finger. They put it in the femoral vein, they go through the heart, and they go to the pulmonary artery. They go just in front of the thrombus, and then they have a 60 ml syringe. They open it and it sucks out the thrombi, and then you can really see the thrombus. So the problem with that is that you also get a lot of blood loss, but they have a system that they filter the blood and you can give back the blood. So this is a promising technique. The mechanical thrombectomy has shown that it really gives a better oxygen saturation, a better systolic blood pressure. You see that the pulmonary artery pressure decreases immediately. You see really improvements, and the complication rates that are now in literature are really low. They are below 2%. There are not randomized studies. There are a lot of studies that are industry-driven, and you see that at least the expected mortality is lower the mortality is lower than expected, but I have shown you that also in other trials, the mortality is lower than expected. So it's also because of selection. And here I can show you one of these open label studies from the industry, and what they show you is that the mortality is less than 2%, whereas in the control arm it's 30%. But this is, of course, if it's too good to be true, it's too good to be true, and that's the case here because they have really compared, it's not appelen met peren, I have read, but apples with oranges, because the patients that were included here in the flow retriever arm, they had a much better, they were less intubated, they had a lower shock index, so that it was not comparable at all. I had 50 shades of pulmonary embolism, 50 shades of outcome, and now we have really 50 shades of PE trials. You see all kind of different therapies. They are compared with each other, and they are compared in all different kinds of PE subgroups, and I think it makes it really, really complex. The data says we need more data, I guess. Although we have these 50 shades, we need independent, randomized controlled trials in relevant treatment groups. So the mortality rate should represent the mortality rate that we see in practice. So the ESC working group on pulmonary embolism had a consensus statement, and they say that actually the optimal management of PE is challenging, and it's based more on expert knowledge than on really evidence. And there should be a team of experienced people, a PER team, who should decide on an individual basis on the treatment of a patient. So that's what is a PERT? Yeah, PERT is a multidisciplinary team. It might be vascular medicine, might be hematology, interventional cardiology, or interventional radiology. It depends on the hospital which parties are involved, but it should be you should be able to consult it rapidly, and it should have a 24/7. It should give tailored treatment plan. It should have access to all treatment options, endovascular and medical. It should provide a good follow-up, and I think a good PER team should also collect and evaluate data and share data, because we have to learn from all these new treatment modalities. In Maastricht, we started with a PER team, and we are now a PER team of the intensive care unit, Thijs and Ronnie Schnabel. We also have the emergency department on board, so Willem de Klerk and Deba Westerman. The anesthesiology is together with us, then the interventional radiology, of course, because they do the thrombectomy. We also have co-workers at the cardiology department and the vascular medicine, and the Thrombose Expertise Center, and Dionne Brake also supports us. So we had like 1 year of preparation. We were developing protocols, and we have been, as it always is, a lot of meetings. And now we are live. We have an Odin protocol. It's almost there, I think, within a week. But while we were already developing it, we were already doing these PERT consultations. And we had about 2 PERT consultations a month, which resulted in a mechanical thrombectomy in less than 1 a month, I think 10 in a year. We had zero mortality, 30-day mortality. We had a clinical success of 60 to 70%, which is lower than literature, because in literature it's more than 90%. But I also think it's patient selection, because we have learned a lot about which patients we should not include in mechanical thrombectomy. We have some complications, which is bleeding at the access site, and I think this will result in some changes in our protocol, and we will do some preventive measures to not have these access site bleeding complications. So in the protocol, we have like everybody can phone us. It goes through the intensive care unit or the vascular medicine unit. And then we have 4 main PERT members, which is the internal medicine, vascular medicine, the intensive care unit, the interventional radiology, and the pulmonary. I don't know how to say in English, but together we discuss the case, and we do it at the bedside when it is from Monday to Friday between 9 and 6. But to be honest, of all thrombectomies that we have done, only 1 was during daytime, and all the rest, of course, is in the evening and in the weekend. And then we just phone. So we have a lot of telephone conversations to discuss on the case. as we have a now, we are also involving in the Torpedo NL trial. It is a Dutch initiative of Erik Klok from Leiden and Christian den Uyl from the Maastricht Hospital, and they want to include high-risk PE patients and then compare systemic thrombolysis against catheter-directed thrombectomy. So we are one of the 15 centers in the Netherlands that will participate in this study, and it will start hopefully in January already. So to conclude, new treatment options are there, they are promising, but for the majority of patients, I guess they are not needed. The exact role of these new treatment options is not known, and I think until maybe we have really good guidelines, we need these PERTs to help us and to thoughtfully decide on the individual treatment plan for PE patients. So I would like to thank you.
Christine,
if there are
very much.
any more questions.
Great presentation. Thank you so much. First question, what's now the biggest challenge? Because when I was listening to your story, indeed, and you showed on the end, it's just some patients present to the pulmonologist, some to the cardiologist, some to the internal medicine, and they never come between 8 in the morning and 5 p.m., so they always come in the evening at night. Where's the main challenges to coordinate this, to have like hemodynamics you use to guide the decision, the CT, sometimes you even want an echo maybe. What's the biggest challenge to really streamline this as good as possible?
Yeah, that's a good question, because it is very difficult to... First of all, we have to temper the interventional radiologists, because they are really eager to do this and they are good in doing this. So we have to temper them a bit, because sometimes the question comes from the wrong side. So it has to be the patient-derived question that comes. And then I think in our hospital, because we as vascular medicine, we are already 24/7 reachable for consultation of thrombotic questions. And I think in our hospital it happens a lot. So that makes it maybe a bit more easy to contact us. And of course, I don't see whether there is a lot of PE that is not reaching us. That's difficult. I'm not sure yet. I think in our hospital, which is quite small, and we as internal medicine, we are at the emergency department until 8 o'clock in the evening every day. I think that we cover most of them that come through the emergency department. But I think, for example, the ones that occur in hospital, I don't know whether we reach them all and whether everybody knows. And even when you inform people, you all know there are new doctors coming, there are doctors leaving. Every day there is a new team. And the biggest challenge is this is not happening on a daily basis. This is happening once in a month. So also we have 8 interventional radiologists. If you say that they all need to do 5 to have a good learning curve, you're like a couple of years further. And then you also, those 5 have to be evenly distributed among the interventional radiologists. So that's why I think the catheter-directed thrombolysis is a good candidate, because everybody can do it. I think if the results from HiPITE were good, I think this might be a better candidate, because in general it's easier to do.
Okay. Other questions? Yes.
Hi, Christine. I hope, is it on? Yeah, now it's on. Very good. Yeah, I really enjoyed your talk. Thank you very much. It was very, also for a thrombosis guy, quite informative. I was wondering, is there any innovation to be expected in the lysis options per se? And do the PE patients have a similar problem as the stroke patients, that the lysis doesn't always work? I was just interested in that.
Yeah, of course, because you don't know, the PE might be acute, but the problem might have been there for a couple of weeks already in the legs. So one thrombus is not the same as the other thrombus, but I think it's a nice opportunity we have now to retract those thrombi and to investigate them. Are they different? Are they the same? What structure is there? And should we do something else? Or maybe we can even predict on CT imaging how the thrombus will look like. So I think it would be good to have a better look onto the thrombi that we retract.
Other questions? No, then I think we will end. I think, Christine, thank you very much. And Tilman, the clinician had a little bit of a problem to stay in time, but what time will you want to reconvene?
Let's give the people 10 minutes.
10 minutes extra. So we'll reconvene at 11:40. Thank you very much.
Very nice. Very nice. Can I just leave my Gelato.
Good morning, everybody, and welcome back to the second session of our beautiful CARIM Dag. And I have the honor to also have the most beautiful session to chair, as we're going to honor our current laureates. And we're going to start off with Matthijs Kluitmans, who has received a Dekker Senior Scientist Grant. Matthijs, the floor is yours.
All right, thanks. And thanks for the opportunity to speak here. I want to talk about p-values and t-waves. I want to talk a little bit about the grant I've gotten, but also reflect a little bit on getting a grant. First, the content. So my topic is myocardial infarction. And we know that after myocardial infarction, there are some patients that have an increased risk for sudden cardiac arrest due to VT and VF. Those high-risk patients, we can give an ICD, which can save their lives. But we currently are not very good at predicting which of these individuals are actually at high risk, which means that we often implant unnecessary ICDs that do come with side effects like a bleeding and infection risk at implantation, but also during the lifetime of an ICD, inappropriate shocks, which are very awful to have. There's also socioeconomic need. Every year in the Netherlands alone, we implant 6,000 ICDs. And only 3%, so 97% of those do not provide any therapy in a year. That's a very big amount of ICDs that do not really add any benefit. They do have a high cost though, so 20 million euros yearly in the Netherlands alone for unnecessary ICD implantations and clinical follow-up. And over-implantation of ICDs is therefore also highlighted by Zorginstituut Nederland as a serious issue that we as caregivers need to address. In other words, risk prediction for sudden cardiac arrest after myocardial infarction really needs to improve for the benefit of the patient and of society. So why is that? Why are we not good at predicting which of these individuals are at high risk and in need of an ICD? Currently, when we look at the risk for sudden cardiac arrest after infarction, we look at the function of the heart in terms of contraction. Left ventricular ejection fraction is the main determinant of whether a patient would need an ICD or not. Sometimes you can also look at imaging, like really look at the substrate in terms of structure, so fibrosis and scar. But what we typically do not look at or cannot look at is the electrical substrate. And there's something to be said to actually look at the electrical substrate, because arrhythmias, of course, are electrical issues, right? So I proposed the Dutch Heart Foundation a solution, or at least a path to a solution, which is to actually start looking for that electrical substrate with a non-invasive technique that can do high resolution mapping of electrical characteristics. I also want to make sure we move towards clinical applicability, so start looking for clinical markers of sudden cardiac arrest risk as well. So the technology I want to apply is one that we implemented in Maastricht a while ago, electrocardiographic imaging. It takes imaging, it takes extensive body surface potential mapping, so extensive electrocardiograms, and from those we reconstruct on the heart surface the electrical characteristics like activation times and recovery times. We have been running the study in a group of patients in the Vigilance study, which is a group of patients with unexplained sudden cardiac arrest, so individuals that suddenly drop down and we do not find a reason for the sudden cardiac arrest. And this is an individual where you can see that activation is normal and recovery is abnormal, as imaged by electrocardiographic imaging or mapping. What you can see here, in particular in this region, is that the red and blue regions are very close together, which means that early repolarization and late repolarization of tissue are very close together, and that's what we call a repolarization gradient. This was not something we could see on the ECG in these individuals, and ECGI really helped us uncover this. And if you then model that into a computer model, you can see that if you give a stimulus, a trigger, we get unidirectional block and the start of a reentrant arrhythmia such as VT and VF. And also in a clinical study then we showed that this was present in these individuals in this larger clinical study, and really highlighted that we can, for the first time, start to explain why these individuals get sudden cardiac arrest. Now, my hypothesis, or my statement to the Dutch Heart Foundation was that I believe that this technology can again bring really revolutionary insights if we apply this now to myocardial infarction patients, which is a much larger group of individuals. What I want to do is firstly collect data. We have a high-risk group and a low-risk group. The high-risk group is data already available to us through a collaboration, patients that already have sudden cardiac arrest and in whom the ICD is already giving relevant shocks, and a low-risk group, so the typical patient that would get an ICD. We have a control group available as well, and in those we would collect the imaging and the body surface maps, but also clinical data like routine ECGs, and use that for electrical characterization. So we would perform ECGI on those data to get a non-invasive map of activation and recovery. ECGI, however, is a complex technique to apply. It takes a long time to do it in a single individual, and you really need the expertise to run it. So I also want to move towards clinical detectability in a simplified way. So one way to do that is to simply go back to the routine ECG and see what we can uncover there, particularly when we know what to look for as determined by ECGI. And for that, we have also a much larger database available. Ultimately, whatever we find, we're going to connect to the patient outcome, because we will have follow-up data in these individuals, and also evaluate in an external database of more than 3,000 patients from Eindhoven. So what I expect to come out of this project is mechanistic insights in the mechanisms that result in arrhythmias after myocardial infarction, as well as representative clinical markers that can help us in a simplified way. Ultimately, that should result in a reduction of implantation of unnecessary ICDs, and that's not something that you get that easily. It's not just a single publication, of course, so we need a path to success there as well, which is, of course, the science, but also getting the right people together in, for example, a user committee, and really design a randomized controlled trial to investigate this. I also believe that this project is about much more than just unnecessary ICD implantations. It will also help us to actually implant more ICDs in those patients that do need them, but who we currently miss. And then when you're talking to the Dutch Heart Foundation, there is a slide where you talk about why should I get it. I feel very uncomfortable back then, but also now, so I removed that slide. And I'm just happy that the Heart Stichting ultimately decided to give me this grant. So I also want to reflect a little bit on getting a grant. And what I think for this grant was important is, first of all, perseverance. I actually submitted this idea already 2 times to the Dutch Heart Foundation. I was never invited for an interview, but suddenly I was. So what changed? I think one of the things was feasibility. I focused the science much more, partially based on the feedback that I got from reviewers. It felt to me like I made it more simple. I perhaps did. It was definitely more feasible, but the message was definitely also much more strongly easier to convene as well. So I think that it really helped me to get the message across. I also even more focused on what's important to the funder, because I believe the idea was obviously very good, but that's not a reason for the Dutch Heart Foundation to give that much money, right? They have their own reasons. And I think we all know that it's a little bit of an open door, or perhaps very much an open door, but really focus on what's important to the funder and not just important to you or to the science. And for the Dutch Heart Foundation, that's impact. Impact in particular for the patient, but also for society. And this message of unnecessary ICD implantations was really one that I took to bring across what I think was important to the Dutch Heart Foundation, helping me to do the science behind that I think is actually relevant for many more applications. And then there's a big portion of luck as well, right? I think we all recognize that. So putting this in perspective, I started listing which grants I got. I got some travel grants, small grants, but hugely important to set the stage for getting the other ones, because it gave me international lab experience and really data that was critical for the other grants, like the Veni grant that I got. I also got a Decker Junior postdoc, but it was exactly the same thing, so I couldn't accept that because it was the Veni project as well. And now the Decker Senior Scientist, so if you disregard the travel grants, that's 3. Grants I did not get: CARIM, Postdoctoral Talent Fellowship. The Coachra Talent Fellowship, 3 times I was rejected. The VD until now, a rejection. As I said, the Senior Scientist that I've now gotten first 2 times a rejection. Arts voor Duurzame Zorg, Open Technology Program twice, and another one. So my success rate is 21%, which is actually not that bad. I calculated this yesterday and I expected it to be much lower, but this is a little bit above average, I think. But still, it does highlight how many rejections you have to go through before you actually arrive at a success and you're allowed to talk here. So perseverance, I think, is important here. But also, and now this is a even more reflective part, I think the grant system is perhaps broken. These low success rates mean that a lot of us are writing but not getting that grant, right? And if you're writing, you're not doing science. You're not doing collecting the data or working on the ideas that you have. So we really have to look carefully at that. Another thing, grants beget grants. If you have gotten 1 or 2 big grants, it's really easier to get another one, because you can do the great science, obviously, but also because it gives you, in some cases, some money or time to actually start writing these grants, because grant writing, as I said, is very time-consuming. Non-native speakers have a disadvantage as well, and I think, unfortunately, early career researchers who have the great, fresh ideas benefit or struggle the most, while they should get the support needed. And this system really favors established labs and not the best ideas. And I believe we may be at a turning point here, because AI is really rapidly evolving as an assistant in many cases, and I think in this one as well, and it's an equalizer. There's actually a study that if you're given a task at which you're good at, you will still benefit if you can use generative AI like Copilot or ChatGPT or something like that as an assistant. But if you're not very good at writing, you benefit even more. So AI can really help to, everybody improves, but those who need it the most improve the most. And in that sense, I think we as scientists, not really, selected for grant writing skills, or actually I think we are, but we probably shouldn't. We should benefit from those changes as well, and from those useful applications. I'm sure you guys have tried to use a chatbot for grant writing. If not, do. It's really useful. My tip would be to use Claude, not ChatGPT, because ChatGPT is not very good at writing, but Claude is. And you can just upload grant documents and ideas, and it helps you brainstorm. It's really quite useful. But it also loses its train of thought. And that's why I've designed a website that can help you do that. And my idea is that you can focus on the science and not the form of that particular grant that you're dealing with. So what you do, and you can give it a try yourself, is you upload 2 documents. The first is call for proposals, and the second is the submission form that you need to upload to the grant agency. So this is a screenshot of the CARIM call for the call for CARIM PhDs, of which the outcome is apparently known but not yet shared. I submitted a grant as well, so we'll see how my success rate changes after this. So on one side you see the call, on the other side you see the submission form, so the empty thing that you need to fill in. You just upload it. It really extracts whatever you need to fill in. And you can see a few things here, like the proposed research project. It finds what it should contain, what the limits are in terms of words, etc. And then that's of course not AI. Oh, that's AI, but that's not very interesting. The interesting thing is where you upload your ideas. And I like taking notes, but I also email with collaborators. So I've just uploaded everything in this notes box. It's a mix of Dutch and English, as you can see. You can also make writing mistakes. It doesn't really matter. This is not the writing part. This is really the raw ideas. Upload it as well, and then the interesting thing comes, because then each of these form elements that you need to fill in, you can generate a first draft with AI based on your ideas and based on the requirements of that particular form element and the particular grant that you're submitting for. So it takes a few seconds, but then if you've put in quality ideas, it will try to really write that down in a way that is that's at least as a starting point, as a first draft, pretty useful. So you can see here I'm writing something about embedding in CARIM divisions. I'm curious to see what this is not what is submitted. You do iterate on that yourself, but you don't have that blank page anymore. So give it a try. Let me know what you think. My idea is really that we're not going to submit more grants, but that we're going to spend more time doing science and less time on grant writing, so that we can focus on the science. It's free, by the way, just so you know. All right, so let me wrap up. And again, this was the science that I talked about. I'm even more excited about that part. I'm really grateful for the Dutch Heart Foundation to allow me to tackle this problem and start working on that with a PhD student and a postdoc. And I'm really looking forward to sharing the results later with you. Thank you.
Thank you very much, Mr. Thijs. I cannot imagine that there are no questions. Yes. Frits.
Great work. So first of all, congratulations with finally another grant, and well deserved, and great plans. It's a nice technology, and we like to use that as well, as you know. And actually, by showing how you write a grant, you are a great candidate to join the Cardiac Research Council. So I think Christian Wouters may approach you for that purpose, and that will be of great value to all of us. But concerning your grant application, it's a bit provocative, but you showed that only 3% of patients with an ICD get the treatment, so we know this is. And the big question, even in society now, is aren't we giving too many ICDs? And even during the break, I had discussion about other examples that industry is not really willing to help us here if they are not gaining any money, potentially. And the strong impression for me over many, many years already is that the device companies are holding their horses because they may know better. And so while ejection fraction is used to predict arrhythmia, which is for me the most crazy thing there is because it has nothing to do directly with the mechanism, they like it because it allows them to implant many ICDs. While I have seen over the last 40 years maybe several electrophysiological criteria which are likely much better than ejection fraction. And nevertheless, they never made it. And my suspicion is that the industry is playing a role here. So now imagine you find the magic bullet. How do you think you can convince the industry?
I think I don't need to convince the industry. If I show this is a better way to select patients, they will come to me because they know that either one of their competitors is going to start with something like this. If not a startup, which is just going to take this input and tell the cardiologist which patient does benefit from an ICD. You know, if that makes it into a guideline, they will make less money because less ICDs will implant it. And you better be a industry or a ICD industry than coming to me to be the first to actually provide that as a service yourself, I would say. So I think as soon as we have an idea and a way to show which patient would benefit, I think industry needs to adapt. But at this stage, they're not interested. This is not an industry-sponsored project, simply because of the reason that at the very beginning, there will be less ICDs implanted. It's also, you know, I dumbed it down a little bit, as I said. I made it a little bit more of a focused story, but there's also a big group of people that are currently not getting an ICD, but that would benefit from getting an ICD. Oh. The same approach should work for them as well. So, you know, if we then ultimately find the right people to get an ICD, the numbers may actually be similar or, you know, perhaps even higher in some cases, but not all. But I think, you know, if you don't adapt as industry in that case, you're going to lose to your competition.
Final question.
Thank you. Congratulations as well. I didn't get 6 out of 7 grants that I submitted to Herstichting. And I have a question about the approach that you are going to investigate. What about the histological substrate that actually gives the signal that you are measuring? Because we know it can be mixed fibrosis and fibropathy replacement as well, which is also seen in sudden cardiac death without structural or cardiomyopathy. Sometimes. So do you have a possibility to look into histological specimens and correlate that?
Yeah, so actually last 2 years I submitted the same idea, and then the idea was to also look at structural substrate with imaging. And I had to remove that to follow reviewer feedback, and then I was defending this for the committee, and they asked me why I wouldn't do that. So I told them, you guys told me not to. So obviously, I want to. And in all of these patients, we have MR imaging data as well. The Spanish collaborators take normal MR imaging, but here in Maastricht, obviously, we do the top of the bill imaging, right? So MR-wise, we should have very good data. And I definitely want to work on that as well. And that was actually the proposal to the CARIM, for the CARIM PhD students. So if they also think it's a good idea, well, we may actually start working on that as well.
Thanks. I tried your tool yesterday. Looks really nice.
Thank you.
Final question for Judith, but we need to go. Yeah.
You want it?
So your grantor. So with ChatGPT, we know that all the data gets uploaded to wherever you lose IP, right? And in this case, we don't want the scientists in wherever to take our ideas. So how have you protected the ideas?
Yeah, so in the background, I don't have a large language model developed myself, right? So I'm still using OpenAI and Claude for, it's a lot of prompts chained together. And I did click the button, don't use my data. You know, that's what I did. And that's what I can promise to you that's not happening. Obviously, if you don't feel comfortable, don't use the tool. But I recognize that a lot of people are actually just doing this with ChatGPT anyway. So perhaps better use a dedicated tool for that. But I cannot promise you that nothing will leak out because that's simply not in my hands.
Well, thanks again, Matthijs.
You're welcome.
So our next laureate is my fellow priori member of the executive board from last year, Job Verdonschot. And he has had his first step into the grant creates grant steps because he received a VENI grant this year. Job,
Yes.
Small question, could you properly speak into the microphone so everybody can hear you also in the back?
Yes, I will try. Yes, thank you for the introduction. It's always a great honor to speak in this session, because usually when you speak in this session, you have something to celebrate. And for me, that's indeed the case, because obtaining the VENI grant is a very, very nice achievement for my research. So my topic of research has always been dilated cardiomyopathy. So it's a heart disease where the chambers of the heart dilate and the contractile function of the heart gets less. So if you look at the numbers, it has a 5-year survival rate of about 50%. It's globally the leading cause of heart transplantation. And for me as a geneticist, the most interesting thing is that about 40% of the patients have a genetic etiology. And when we speak about heritability, then you don't only deal with the patient, but also with the family behind the patient. Because for every family member, there's a 50% risk of them having the same genetic etiology for developing dilated cardiomyopathy. If we then take a closer look at the guidelines, what do we have to do with these family members at risk? So these are the guidelines that were published last year. And if you go through the tables, I will summarize it for you. The first thing is that they say, if a healthy family member carries the genetic variant, we should follow them up regularly with cardiac screening. That seems sensible. But later on it says, when the index patient, so the patient with dilated cardiomyopathy, does not have a genetic variant, still the family members should have regular cardiac screening. And that's with the idea that we don't know everything about genetics, so we can't exclude that there is a genetic etiology. But what this means is that the number of family members that need screening is increasing rapidly, because we basically say that every first-degree relative of every patient needs to go to the cardiologist on a regular basis. And the thing what's missing in this guideline is that it's one size fits all. So we know now that from genetic etiology, but also from the etiology of dilated cardiomyopathy, that's very heterogeneous. So also the first degree family members of these patients is a very heterogeneous population, although the guidelines say that we should screen them cardiac screening every year, which is of course a huge burden for the outpatient clinic and cardiology. So coming back to this genetic heterogeneity, so we know more and more about the specific clinical and natural course of genetic mutation underlying dilated cardiomyopathy. For example, one of my favorite genes, filament C, we know now about from large cohort studies that the mean age that this disease develops is around 40-50 years old. There are many arrhythmias, and usually the arrhythmias precede the development of dilated cardiomyopathy. It has a very aggressive clinical course with a high risk of sudden cardiac death, and also much scarring that can be seen with MRI scan. And it's also for this reason that the guidelines say that there are certain genes that should have a lower threshold for ICD implantation, and filament C is one of these genes. But if we then again take a look at the guideline, you see here on the right flow diagram, I circled in red the most important part. That's for family members with a genetic mutation, they should have long-term follow-up. But what is long-term follow-up is not defined. And also what diagnostic should be done is also not defined. But it says that it should be considered for every family member. Instead of echo, they should get an MRI. So now we see more and more relatives, and they should all get MRIs on a regular basis. Well, in practice, what we see is that these family members come in many different clinics, and they all get different recommendations, and also within families, with family members at different hospitals, they get different screening. One is discharged from screening, the other comes yearly with an MRI scan. So we are far from consensus in this. So if we take a look at the imaging, at the echo, so here you can see a patient with dilated cardiomyopathy, so you see a large ventricle and also the contractile function is decreased. Here you can see a healthy heart with a strong pump function, but it was this patient that suddenly died, and it was because it was carrying a filament C mutation, and if an MRI was being performed, you could see that there was a huge scar surrounding the ventricle. So it's meaningful to perform MRI in certain genotypes, but it's impossible and too costly to perform MRI scans on a regular basis in all family members. And this is where my VENI project starts. because together with the Technical University in Eindhoven, I looked at the possibility for an echo alternative for MRI scanning, and that's shear wave elastography. So what shear wave elastography basically is a form of high frame rate imaging echo, and you shoot an acoustic pulse on the septum of the heart. The septum of the heart starts moving, and you measure the movement speed of these pulses on the septum. So this is the idea, that if you shoot a pulse on the tissue, it starts moving, and these vibrations you can measure. So in very slow motion, this is what it looks like. So you shoot the pulse, and then you can see how the shear waves disperse from the source to left and right. And the speed of these shear waves is associated with the stiffness of the tissue. So how more fibrotic the tissue is, the faster the shear waves will move over the tissue. So the idea is to investigate if shear wave elastography is a good alternative for MRI screening. So it was not that long ago, there was a really big echocardiography conference, and this research was presented there. It was more or less my idea for hypertrophic cardiomyopathy. And here you can see in different phases of the contractile phase of the heart, how the shear wave velocity, so the speed of the shear waves, differs among patients. So in red are the hypertrophic cardiomyopathy patients with very high shear wave speed. And then the family members are in green and blue, and the shear wave speed can differentiate between high risk and low risk family members. So this basically shows that for hypertrophic cardiomyopathy family members without a phenotype, with shear wave elastography you can already determine differences in the risk. So, but there are some scientific challenges. We already saw in the presentation of Alam that the heart is moving. And yeah, we don't like that. If we want to shoot a pulse on the heart, it should be steady. So at the Technical University of Eindhoven, we used an ex vivo beating heart, and we tested how the shear wave, in what phase it would be best to shoot an acoustic pulse on the septum. So we now optimized on this porcupine heart or porcine heart how to optimize the pulsation. But the other thing is also not only the heart is moving, also the valves in the heart are moving. And every time a valve closes, there are naturally occurring shear waves going through the septum. So we have to differentiate between the naturally occurring shear waves and the shear waves that we get from the acoustic pulse. And for this, we now use SVD as a more or less an AI method to filter out the naturally occurring shear wave from the shear wave that we induce. So there are three objectives in the study. The first time that one we want to do is to see if shear wave elastography associates with fibrosis on MRI scan. And we will do this in patients with DCM with scarring on MRI. And we will compare the scarring on MRI with the velocities measured with shear wave elastography. The second thing is that we want to investigate the difference between the shear wave speed between healthy family members with a genetic mutation compared to healthy volunteers. Because I do think that only the presence of a genetic mutation will already influence the stiffness of the heart muscle. So that does not necessarily have to be associated with scarring to already have an effect on the stiffness that we measure with SVE. And the last thing is the follow-up of these family members in which we've performed SVE to see who will eventually develop a phenotype. And is the shear wave elastography, so the velocities that we measure, a predictor for phenotype development in these family members? So then back to look at it again in a broader perspective. So basically the problem is that we, at the moment in the guidelines, there is an inefficient screening method for risk prediction of family members. And it has to do that it's a very heterogeneous population with different genetic mutations. So with the DECA grant I got 2 years ago, the focus is to come up with genotype-specific screening recommendations. And we are already quite advanced with that. So I'm now together with Annelien Terile, a cardiologist in Utrecht. We lead a national working group on family care of cardiomyopathy patients. And we're now working, we gathered a lot of experts on this topic. We're now developing a national consensus document with genotype-specific screening recommendations for family members in the Netherlands. In parallel, I was also the lead writer on a similar case and name of the ESC. So we just finalized this ESC clinical consensus statement, which I led together with Professor Pablo Garcia Pavia in Madrid. And we are really happy with this document because it adds more in the individualization to screening recommendations for family members. But where the VENI comes in is that the indication for MRI screening is still there. So hopefully with this research we can look at echocardiography alternatives for it and then translate it back to these genotype-specific recommendations that we are building. So this last slide I basically took from my presentation 2 years ago when I presented my DECA grant here, because most of the key points are still the same. So what we're doing now, the focus has always been on the patient, and that's of course very logical, but there is a really strong shift going towards the healthy family members. And we're now at the point that we are creating large national and international registries of these family members to learn more about the natural course of these family members. Well, we gather also essential information of the pathophysiology of DCM development, because we start from a healthy heart towards a phenotype. And with the SBE, we can get novel insights in myocardial stiffness in this development. It's still very important to create awareness about family screening, because there are still a lot of differences about screening recommendations that family members get from different healthcare professionals. We are building very broad expertise on this topic, but there are also still many possibilities to expand on this topic. So there is now a large clinical trial, the early gene trial, that's looking at early treatment, so starting treating family members before they develop a phenotype. We're getting more and more patients from different routes, so secondary genetic findings from patients without a family history of heart disease, which present with a genetic mutation. And another topic in which Maastricht is really specialized are the reproductive options for those with a genetic predisposition. So this was my last slide.
Thank you very much, Job. Any questions from the audience?
Great presentation as always, and great ideas, and congratulations with this grant. You really deserve this. I have a question about your nice slide. You took the data from Olivier Villemain's group, showing DCM having a high stiffness in the diastolic phase mostly. And one of your goals is to relate fibrosis to that stiffness measure. I guess you know that stiffness can be due to fibrosis, can also have to do with something happening in the contractile apparatus itself. So do you have any plans trying to differentiate, which it's not easy, but in HCM patients, there might be also a higher resting tone of the contractile apparatus causing a stiff behavior besides fibrosis.
Yeah.
So what are your ideas there?
Yeah, definitely. And I think that's exactly what's going on in dilated cardiomyopathy due to genetic mutations. That's why the first work, the first objective is to relate it to patients with scar. So we know that there is scar, so we can shoot the pulse exactly on that point, so we can associate it. In hypertrophic cardiomyopathy, there is an association of 0.9 between LGE and velocity of shear waves. But I do think, and that's in the second objective, I also want to include family members without scar. Because I do think that the genetic mutation of a sarcomeric mutation will have influence on the stiffness of the contractile apparatus independent of scarring. So that's why by excluding scar with MRI, I want to also look at that,
Throw. Thank you, Rob. A really nice presentation. I'm just wondering, so you screen patients and you look for the development of a substrate. So if you turn this around, how many patients do you have to, wouldn't it be easier to just implant ECD in all patients above a certain age, because perhaps developing the substrate might be a bit too late and you might lose some patients on the way while you're waiting?
That's indeed some of the ideas, and I also think that Matthijs's research comes perfectly in there, Because for these very high-risk genotypes with the high arrhythmic risk, and filament C is one of the latest that was only discovered in 2016, so we don't have that much follow-up yet. The tendency is really going towards we should not have any risk with those patients. We should really have a low threshold implanting ICDs in these patients because they have such high arrhythmic risk and such high risk of sudden cardiac death when everything is normal on MRI. So we don't know what the substrate is in these patients. But Matthijs will discover that for us.
Perhaps also make the industry happy again. Other questions?
Thank you. Congratulations, and well presented. I had a question about the septum. You mentioned that you might, provide an impulse of ultrasound, if I understood correctly, on the septum. Is that correct?
Yeah.
But the septum will have different thickness, dimensions, and even within septum there will be basal to apical, differences in diameters. Do you have any ideas whether, how the spread of the signal will change based on that? And have you tested it already? Maybe.
Yeah, indeed, this is something we're still working on. We're still optimizing with the Technical University in Eindhoven how to do this in patients. We're also still working on the ethical approval, but that will be fine. Because the other study in hypertrophic cardiomyopathy I showed, they do it on the septum and on the free wall. The free wall is very, very difficult, and I don't think we have the experience to do that. So what we now did is a sort of an AI tool that shoots the pulse not on one point, but it shoots it at multiple points in different phases. So we're not only taking one shot and then one measurement, we're taking the average of multiple locations of the septum and multiple velocities that we measure. Yeah.
Thank you. And why is this method better than classical echocardiography or ECG? Because to me it seems low resolution, while it can be really quick and cheap. But can you explain where do you position it with pros and cons to ECG and echo?
Yeah, I think with echo we don't get really information about the myocardial tissue itself. So this will really provide tissue information about stiffness of the tissue. And that's something that's not possible with echo at this point. Of course, you have certain surrogates you can measure. That is a measure for diastolic function and stiffness, not really at the tissue level itself. And this will provide that gap in echocardiography.
And maybe better analysis and deeper analysis of ECG. How would you compare it to that?
I think we have to look into that, into the association. Of course, we're also working together with Utrecht with the AI ECG in the same population. So that definitely also ideas to eventually associate what we measure on tissue level with what we see on the EKG. Yeah.
Can go back now.
Very interesting talk. I was also wondering, because I'm under the section of vessels, if this technique, shear waves, could also be applied in bigger vessels, for instance, the aorta. Could that be possible, you think, instead of, or in parallel to pulse wave velocity, for instance? Could this be also applied in this kind of tissue?
It definitely is possible for vessels, because it's originally it comes from liver fibrosis, because liver fibrosis you can measure shear waves very easily, but the first application in cardiovascular was on vessels. And there is one group in Twente who does a lot with shear wave elastography in vessels.
And could that be then also maybe a better reflection also with the issue that was just raised in heterogeneity of the tissue, that this could be a better indication using the bigger vessels and applying this technique than focusing on this part of the heart? That was
that would be a very interesting approach that we could also have a look at.
Makes life maybe a little bit easier.
Yeah, we are really focused on the heart itself, but yeah, it's definitely worth it to look at the alternatives.
Thanks again. Thanks again, Job. Yes, and our final speaker of this session is Gerry Nicolaas, who's going to give us a presentation on sepsis. And it's been in the scope of his Praetorian grant that he received this year.
There we go. Yes.
Thank you so much, and thank you for the invitation. I think it's fair to say that in contrast to the two previous speakers, I'm not presenting any personal project, but I'm here on behalf of a whole consortium for whom I have the honor now to speak to you. And also, it's not in principle a research project, but it's a training grant given by the European Union. It's called the Praetorian Doctoral Network. You may know of these doctoral networks, and the data that I'm going to show you, or the information I'm going to show you, refers to 10 different projects, really. The presentation itself, I'm going to tell a little bit about the background of sepsis and its biology and clinical relevance, and then go more into detail on the network itself and the activities that we are planning. You should know the network activities in the lab have started after summer this year, so there is not much results that you can see so far. But sepsis itself is a very important problem in the world, because as you see in this slide, it strikes almost 50 million people worldwide every year, and 11 million people of these 50 million, they will die. So, and this accounts for 20% of all global deaths. What makes it also really striking is that, particularly in the developing world, there are more than 6 million newborns that are killed every year. So this is to indicate what size this problem has. And it's a global healthcare problem. It's more common, in fact, than heart attack, and claims more lives than cancer. Also in the developed countries. So this was for us a reason to think about sepsis and see what we can do about this problem. And if you think about these numbers, just to illustrate in 1 minute that I'm taking here to tell you about this slide, 21 people will die of sepsis. Yeah? And the reason for that is that it's a very fulminant process. It's a very fast process. The diagnostics that currently are there in an ICU, they are not sufficient, and also the therapeutics, the options that we have, are clearly not sufficient to treat these patients in time and get them back to their normal status. So there is a clear medical need, which also was recognized earlier this year by the World Health Organization, and the conclusion there was also that it's mostly in the diagnostics and in the therapy where we fail to provide better care for these patients. As I am aware that not all of you are dealing with this septic disease every day, this is a definition of sepsis, and it's a life-threatening condition where organs dysfunction, and it's caused by a dysregulated host response to an infection. So we see that there is an overwhelming response to, for instance, a bacterium, and this in the end leads that our own immune system starts to create all these problems for the organs, and this creates tissue damage, the organ can fail, and finally this can lead to death. Does this belong in a cardiovascular research institute? I think the answer to that is yes, because approximately 50% of sepsis patients during their stay in an acute ward, they will experience cardiovascular dysfunction during the illness, and this can be cardiomyopathies, vasodilatory shocks, or also arrhythmias. But what's even more important, and this is data from a recent study, is that in the follow-up, if these people survive and get out of the ICU, then even on the long term, and this was a study that looked for 12 years after the hospital admittance, there is a higher risk for cardiovascular complications, and that includes heart failure and other cardiovascular events. So I think, yes, it is worth our attention. Now, what do we know on the textbook knowledge of this septic disease? And that's shown in this slide over here. And you'll see, and it's rather small here, let me make this bigger. Okay. you'll see that the classical image on this was that there were these PAMPs on top, these were these pathogens, and they could induce all kinds of other systems like the coagulation system or the complement system, endothelial activation, of course immune cell activation, that together would cause a microvascular thrombosis or DIC in the worst cases, tissue ischemia, and other events like immune suppression or systemic events that were directly related to the organs, together causing a multiple organ failure, and that could lead to death. And this is the textbook knowledge on this topic. Can I go further? It's not responding. Yes. Well, all of this sort of changed when in 2004 there was a seminal study by the group of Arthur Siglinski in Berlin who showed that there is something like neutrophil extracellular traps. So this is a different activation pathways for the neutrophils where we all know so well. So it's the most abundant immune cell in our blood. And in this process, the neutrophils do not phagocytize anymore a bacteria, but what they will do is to cause really a net. So this was a very well chosen acronym. And the net you can see, no, I can't point to it, can I? No. Can I? Okay, well, I will use this one, it's easier. So this is actually the net, which is formed by DNA strands, and on these DNA strands, there are the contents that were originally in the neutrophil, and they are toxic, as you know. But now they come out of the cell, and this is very good to catch a bacterium. So that's the net. The problem with this is actually that these nets are not very stable, and they may diffuse into the circulation, and when that happens, they also are toxic to our own cells. And so there came an updated view on sepsis, and what we see that there was this septic stimulus causing the DAMPs, and DAMP stands now for damage-associated molecular patterns, and those are those proteins on the nets. And one of those DAMPs are the histones, which are supposed to be inside the cell, but they turned out to be very toxic to other cells. After an infection, these histones and other proteins coming from the nets then would get into contact with our endothelium, kill the endothelium, and new histones would become available. So this could lead to a waterfall of reactions that had to be stopped. And that was an updated view on what happens in sepsis. And what you see now in the newer textbooks is that indeed we have the PAMPs, but also the DAMPs, and the DAMPs together can then also cause a lot of problems, like for instance the activation of the complement system, but also coagulation, or directly through coagulation factors or through the platelets or other cells involved in thrombosis. A next very important event was the finding in 2009 by the group of Charles Esman in Oklahoma that indeed these histones are mediators of death in sepsis, and by taking away the histones in experimental models, they could reduce the death in septic disease. Okay, and this was a very important finding that got a lot of attention, and that was then a start for many people to think about how can we use this information to come to new treatments or diagnostics in septic disease. And that's also what we did here at Maastricht University. And because there are no sepsis drugs as yet. Something else is needed, just like the WHO is telling us. And this was the start of the Praetorian network, where we will focus on these DAMPs, but also on the nets, these neutrophil extracellular traps. So here we have the nice logo, and I should say that much of this work was also designed together with my colleagues Kanine Wishapong and Tara de Costa, you know, as well, is by now also a very important player in this consortium. The principle of these consortia itself, and you may know it, that it is a doctoral training network. So for the EU, it's not so much important what science you are doing as long as you create a good training network for the people that are going to do the science now and in the future. They want to see new scientists being trained that are able to make the step from the academia also into the industry, and they want to see that you make their connections. And this is how you should set up such a application. Well, the network that we created consists of 5 universities, starting from Uppsala in Sweden. Then we have the University of Münster, Germany, and Paris, France, Barcelona, Spain, and also ourselves here in the Netherlands. And this we combined then to 7 for-profit organizations. So these are the companies that we involved, several coming from the Netherlands, but also from Norway and Switzerland. And this then next we brought together with not-for-profit organizations, because you really have to make the step into society and listen to what the needs in society are. Just like was presented by the previous speaker, that it's really important to listen to society. And by including the patients' organizations here and also some outreach organizations, you can do that. How can we make a difference? One of the main things is, I think the third point, is to create more awareness among academics. That's one of the reasons I'm standing here now. But the other thing is you create the difference by training the new people who can do this work and who can take it further from here. Yeah, and that's exactly what we are trying to do now. We want to try new approaches in patient care by providing novel diagnostics and novel therapeutics. Well, they come from all over the world, and I should say that the number of applications is really huge in such a network. So we're nearly 900 applicants for just 10 positions, which also means that the level of the candidates that you can attract is very high. And as it happens, the candidates actually are now in Maastricht. They should be joining the CARIM meeting soon, because we have organized several courses, one of which is now happening in Maastricht. The programs themselves, they last for 4 years, of which 3 years are financially supported by the EU. And a 4th year has to be come from the institutes where this is being organized. And the work plan that we have taken are following 6 different work packages. One of them is to look into the molecular mechanisms of dams and nets, because not much of that is still known. The second work package will focus on discovery of novel inhibitors using mainly artificial intelligence and computational drug design methods. The work package 3 is going to combine the work packages 1 and 2 into novel sepsis theranostics. And then there is 3 other work packages that are mainly focused on the training, on the outreach, and one for the coordination of the whole consortium itself. Very short, because I'm not sure how much time I have, and I do realize I'm between you and lunch, that the different projects are as such. In the work package 1, we will focus on HMGB1, and this is done in Barcelona. The work package 2 is going to focus on the targeting of nets. How can we neutralize nets? Done in Münster. The package 3 is targeting one of the essential enzymes involved in the initiation of this net formation. The work package 4 is going to happen in Barcelona, and actually Professor Garcia de Frutos is in the audience now, and he's going to focus on the role of gas-6 in netosis. Then we have a 5th focusing on interaction between the dams and receptors, so trying to create molecules that can block the triggering of the immune pathways. And then we have two packages, 6 and 7, which will happen here in Maastricht, where we're going to use computational design to discover new molecules. And an 8th one is going to develop compounds to modulate NETs by looking at Gas6 TAM receptors. Yeah, the 9th and 10th, those are the ones in the work package 3 where everything is going to be combined, and we're going to look in animal models. This is going to be in this consortium both mice, large animals, but also in zebrafish, and there we try to combine the new molecules and see how effective they are. You have to spend a lot of preparation on the training network. As I said, it's not a research network, but a training network. So what we are trying to do is to take all these students and try to bring them up to a same level, knowing that they all have different backgrounds. We have bioinformaticians, we have programmers, we have people with medical backgrounds, and they are very diverse, but still they have to work together and hopefully come to a nice final product. So we provide them with several trainings that will support them in their tasks during the whole network, but also that will allow them to work together. And next to that, there are these transferable skills, because they also need to be able to talk to somebody from industry and be able to translate their new findings into a final product. Important in these networks are secondments. You probably heard of that, and that means that any student at one location will also have to spend research time at one of the other centers, and this of course automatically integrates much of the research that we are doing, and this makes this really into one unit. And as an example, for instance, the molecules that we will find in Maastricht will then next be tested in an inflammation lab in Barcelona, and so on. And this actually brings me to the end of this presentation. So not much data, new data on what we are doing right now, but hopefully there's more to come, and in future years I hope to give you more information on that. Oh, this should go back. If you want to know more about the consortium itself, here is the link to the website, and there's a lot of information, and you can also see the students that we have, and plus on top of that you can meet them here today as well. And I would like to invite you to interact with them, and thank you for your attention.
Thank you very much, and albeit not so much data, impressive nonetheless. Are there any questions from the audience? We do have a little bit of time, I guess. Guess everybody's... Oh yeah, no, there's a question. You go ahead.
Thank you. Impressive project and network. I had a question about the histone part. Did I understand it correctly that this is the histones that are being released from dead cells of the host, right?
Yes.
So have you also considered looking into the histones, like a histone-free DNA or cell-free histones, basically in the blood for biomarkers? And are they released in sepsis? I can imagine.
Yeah, so these are exactly the histones that we're talking about. So as you know, if you have a healthy individual, so as we sit here now, probably nobody of us will have free histones in their blood. So unless you have an extreme exercise, or you are getting ill, or you have net formation, then you will see those histones. But otherwise, they are not there. So it's the same histones.
And this will happen all over the body, and basically those little fragments of histones with DNA on it, basically it's like little pieces of chromosomes, will be on different locations in the DNA. If you, for example, look at troponin I3, this is very highly expressed, for example, in the heart, and you might have other right cell specific. So are you going to be able to distinguish from where, from which organ the release actually happens by the time when you sample the blood?
Yes, we will. So because one of the parts or one of the pillars of this consortium is also diagnostics, and we are going to design, or we already have peptides that can be used as therapeutic, but that can also be labeled to see with in vivo imaging where actually they end up.
Yeah, this is very interesting because this also likely happens, for example, in heart failure, cardiomyopathy in the tissue, because cells are dying and then the DNA content histons is open. So it will be really interesting to...
Yeah. Well, actually, a couple of years ago, we published a study in Nature where we show that these histones, and particularly in isoform H4, are very important in myocardial infarction, and for some reason, they are very toxic to smooth muscle cells in the heart. Yeah, and again, they come from the neutrophils, probably.
Thank you.
Well, thank you very much again, Gerry.
Thank you.
Thank you, Nikes. Thank you, morning speakers. This was a really motivating morning. With lots of different talks, lots of different disciplines. I would like to ask you now to enjoy lunch, interact with the poster presenters. Please stick to the program time schedule and welcome you back at 2:15. I would like to ask the poster judges, Eline Kooi, Steven Meeks, Sabine Dame, Sam Heus, Camilla Saranje, and Matthijs Kluitmans, to remain here and they get their instructions. Thank you and enjoy your in-between. Thank you for adjusting the volume. I hope you all had an enjoyable lunch. We're back to serious business again. Our world, which is changing in lots of ways, but also in climate way. And I'm actually here to introduce the moderator of our guest speaker, but also our guest speaker. Our guest speaker, Professor Bruinings from the University of Antwerp. He's an authority on climate change and especially the effects that it has on health. And I met Professor Bruinings a couple of weeks ago in our chateau near Cannes. And we had inspiring discussions there about how we should address these changes and if we can address these changes. And eventually we came sort of to an agreement that there are good ideas, but they are not too carried out by our population and society. And we decided, it was like later in the evening, that we would need an enlightened dictator to do this. And when we offered him the choice to become enlightened dictator of Belgium or the Netherlands, then he chose for the Netherlands. And this was for me the reason to decide that I would invite him here today to educate you about what we should do about the climate change and the effects, the adverse effects it has on our health. And with that, I would like to introduce our moderator, to introduce our speaker of honor, Joost Lumens.
Thank you, Tilman, and sit back and relax because it's going to be a very lengthy introduction. Professor Bruinings, welcome to Maastricht. And for those of you who don't know him, he is a professor of environmental governance and really an expert in influencing policy to make things happen in the end. And Professor Bruinings, may I welcome you on behalf of the crowd and invite you to the floor to share your thoughts with us on a super important topic. Thank you.
Good afternoon. Thank you for the introduction. I have to say this is a daunting audience for me because I don't know anything about what you are specialists in. I was here early and I walked along the posters and there was one where I could at least understand the title and it immediately got my full attention, Cracking the Code of Aging. I thought, I hope this research goes far and fast because I might need it one day. But anyway, let me dive straight into the heart of the matter. The message I will give here today is that to understand our health, we would be well served by looking at the context in which we live, and that context is increasingly changing under conditions of climate change and other environmental issues. And we understand increasingly well how those two are connected. I would say for the moment this is not very central in many of the specializations in the medical world. It is also not very central in the mainstream thinking about climate or environmental policy, but I think my plea is to bring those two worlds much closer together because I think we would reap great benefits from that. But let me first start with the macro perspective, what we call in our field of study the triple planetary crisis. Yeah? And the first one that we focus on is this one. You may have seen this. This is the average temperature on the planet from 1850, when the Industrial Revolution started, and the more red it becomes, the hotter the planet, average temperature on the planet. This is well known. The other curve that looks very similar is equally important and is not very well known. The grayer it gets here, the less biodiversity and ecosystem qualities we have. And there's much less attention on the lower bar than on the higher bar, although the two are intimately connected. We noticed the last 15 years, especially, that climate change is becoming a driver of biodiversity loss. And we also know that we will need strong ecosystems to deal with climate change because they capture carbon and they deliver us what is called ecosystem services. Now, if you want to understand the broader scope, we of course start our policy framing in Europe more than in other places even from scientific consensus. And there are 4 big panels that bring the type of knowledge to frame this discussion. One is of course the IPCC, the Intergovernmental Panel on Climate Change, which I assume that if you're a specialist in valves and tubes, you also know this, the climate scientists, and they are telling us that we are well on the way to see a temperature increase above 2.5 to 3 degrees. Yeah. Then you have IPBES, that's the panel on ecosystems and ecosystem services. Also a bunch of scientists, they met a couple of weeks ago, and they talk about the 6th great extinction of species and ecosystems. The first one of which we as a species are the driver, and we could potentially become the victim of, yeah, to put it a bit sharply. The third one is even lesser known, I assume. It's the International Resource Panel. It looks at how we use resources on this planet and how it impacts climate, biodiversity, but also what is being discussed in the 4th panel, and that's of course the one that you should all know very well. It's the World Health Organization, which is increasingly framing health issues as environment and climate issues. Now, without going into any detail, all these panels in essence send the same message. First of all, we live in times of urgency. This is a pivotal decade to turn some of these ever-increasing curves around. Yeah? We've been trying this for a couple of decades. For the most part, it hasn't worked. Yeah. Secondly, we are living in times of irreversibilities. And this is a serious message, because you cannot just pretend that we will restore the ice sheet on Greenland. It's not going to happen anytime soon. When species are extinct, it's really difficult to turn that around. When you have intergenerational effects of climate change and pollution on brain and organ development in young infants, you cannot turn that around. I mean, the damage has happened. That's the irreversibility. We also start to see tipping points in natural systems where we lose the relative stability that we've seen the last 7,000 years on this planet. Not by coincidence, the 7,000 years in which humanity developed in the way it developed. You know? We needed that relative stability, but also in social systems. Think of our economic and political systems that are under severe stress. And all of these things are interconnected. Yeah? I'll come to that more elaborately in the rest of my talk. But you could also read these reports through a health lens. I mean, the first IPCC reports on climate didn't mention health. Now health is an autonomous part of this document. The International Resource Panel in its latest report, and I was the chief coordinating author of it, we spend a lot of time on the impact of resource use on human health. So you could read this as a health issue. And that's of course what the global response does. You all know the SDGs, the Sustainable Development Goals, framed in 2015, and SDG number 3 is about health and well-being. And traditionally, we tend to focus on the links with socio-economic drivers and determinants of health, but increasingly we understand that health is also related to these Earth system drivers that surround us. In your language, that is sometimes called part of the exposome understanding of how, as human beings, we live in a broader set of circumstances. I need to say why I added again, yeah, SDGs again. Well, in 1992, and for some of us that is, we remember that, some of you don't, we already had SDGs. It was called Agenda 21 after the Rio conference. And if you update the language a bit and the science, it's exactly the same agenda. But we are less sustainable now than we were then. So we lost a generation there already, which is why the urgency point is so important. Okay, luckily there is a whole field of study that is starting to cover this. I will not go into all of this, but this is starting to be a really critical field also in your part of the scientific community. And of course, the World Health Organization has fully embraced this connection to health and well-being issues on the one hand and nature and climate on the other hand. By the way, if you ever want to listen to one of your community specialists who is absolutely fabulous in driving the point home, Maria Neira. She is the Global Director of Health and Environment of the World Health Organization and a fabulous person to listen to. Okay, so we are living in times now that we define through the lens of planetary boundaries. Scientists have come together in 2008, 2009 to define a set of boundaries on this planet that are essential for life and for Earth systems, and where we are beyond a threshold that we call the safe operating space. And this is true for water, this is true for climate, this is true for biodiversity, it's true for nitrogen and phosphate, a little debate in the Netherlands as well. So these things, we are beyond the thresholds. The latest one, and that's a group that I belong to, is on chemical threats to health and environment. So we are beyond that. And then some have said, well, can we imagine a world where we stay within these planetary boundaries and we link those to the essential outcomes we want in a society, a healthy society for all? And Kate Raworth, economist at Oxford, she has come up with well-being economics, also called donut economics, for obvious reasons, although in your profession you wouldn't recommend eating too many of these vicious pastries. But okay, one of the parts here is health. It's part of the system that we need to organize within these planetary boundaries. Good. What is the European response to this context? It's called the European Green Deal, the chief agenda of the Ursula von der Leyen Commission. And to just give you one anecdote of how different this agenda is from previous commissions, the commission preceding that was the Juncker Commission, Jean-Claude Juncker, the ex-premier of Luxembourg. In his basic policy document, the word environment didn't even appear. Yeah, I'm lying to you, which I shouldn't do to scientists. It appeared a couple of times in business environment. Yeah, but it's a different understanding of environment, of course. So, what is this agenda? First of all, we want to become the first climate-neutral continent. We want a strong biodiversity strategy, a strong circular economy action plan where we keep the value of resources in our economy, a zero pollution strategy that is defined in terms of human health, and a farm-to-fork strategy. And that strategy is embedded in Directorate General Santé, in health, in Brussels. So they look actually at the food system as a key driver of health issues. The first time Europe does that. And if you then look at the connections in all of these previous plans, health is mentioned as a key motivator, driver, and potentially beneficial outcome of having this agenda. But also there, in terms of just transition, distributional aspects matter in health. I don't need to tell you. We need an investment in this type of knowledge and approach to health. And of course, it would be nice that Europe could link this to an industrial strategy, meaning that we could produce the sort of instruments and industrial potential that we will need to make this agenda work. A concept that is used to capture all of this is One Health, where we say that animal health and human health, or if you prefer human health and animal health, both depend on the broader environment. And if you look at the greenish moon, you will see climate change on the top there, and you will see the other elements that I've already mentioned also there. This is a sort of holistic approach. I don't like to use the word holistic because it sounds like wishy-washy stuff. But what I like to do is to make a connection between two main trends in science. One trend is the one that I see on the posters here, and that I'm a big fan of. That is increasingly an inch wide and a mile deep. And if we can, half an inch wide and 2 miles deep. And if I have something in my heart and one of you is going to open me up, I hope I have the best specialist on that particular topic. That's one trend in science. It's everywhere. Yeah? The other trend in science, I think we are not giving enough attention to, and is critical for this debate. It is called systems understanding. System science, which has developed massively in the last 10 to 15 years, and which is not about an inch deep and a mile wide, because if it's only an inch deep, it's not science. Yeah? So systems understanding is a science in and of itself, and is badly needed if we want to understand the human condition in all of its connections to the world that surrounds us, including health issues. And I think it's a broader issue in the healthcare community to look not only at the valve, but what environment has this person been walking around in? What is this person doing, eating, moving, all of these things that you, I know, think are important. This has led in the EU system, I just want to mention this briefly, to a collaboration between 5 EU agencies. The ECDC in Stockholm, which you might know, the Chemicals Agency in Helsinki, which looks at chemicals and their impact on human health and the Environment Agency in Copenhagen, where I was a director for 10 years, the Food and Safety Authority in Parma, which was set up after the bovine crisis, yeah, and the Medicines Agency. We have bundled forces and we have said, let's bring our best knowledge together to have this more systemic approach towards human health. Now, to better understand this nexus, in ecotoxicology and in human biomonitoring as subfields of your discipline, we sometimes say that genes load the gun and the environment pulls the trigger. Yeah? So if we want to better understand how these are connected, we need to set up serious research for this, and we need to go both in the broad direction and look for connections, and we need to go deeper to understand where all of this data should be coming from that we will need. Completely in your alley, up your alley, I think, research done, collaboration between some of these agencies and the World Health Organization, is that in the EU, 90% of the deaths attributed to the environment are non-communicable diseases. And if I, not being in cardiology at all, in my understanding, 4 of those 10 are in your field. Yeah, so that is quite significant. There is this connection there. I'm not sure how central it is in the studies that you make, but there is a serious connection. You have all known also that this is true for other things like cancer, testicular cancer, breast cancer, where you see an increase over the last decades, and this is connected to pollution in the environment. This is sperm concentration, also impacted by the environment and by pollution. I will not go deeper into this. All of this led to the setting up of a data hub where we bring together European environment and health data for all of the countries in Europe, and that's the European Health and Environment Atlas. So you can go online, go to the city where you live, click on the place, and you will get both the socio-demographic and health data, and you will get the environment data, and which is really interesting to start comparing places in Europe, but even in your own country, to look at this type of work. And then you notice things in Europe like premature deaths caused by the environment. The Iron Curtain has come down, but it has not come down when you look at these types of impacts. I'm from Belgium. You can also notice that on the map. Yeah. unfortunately. There is also a drive here in this field of study to connect to citizens much more. Why? Because it's not easy to explain to citizens, and it's especially not very productive in making them reflect about choices. If you involve citizens in creating this knowledge for the place where they live or where their kids go to school, we have noticed that A, they are motivated by the process, B, they create understanding about their own living conditions, and C, that leads to actionable conclusions, and they want to be involved. Yeah. Now, focus on climate change. This is since 1850, the evolution of the average temperature on this planet. You can see that it gets a little bit hotter. That's above the 1.5 degree. These are just some tools to show the evolution of these things. If you look at average temperature on the planet, the top two lines are 23 and 24. This one is still 2 months ago, I think the latest global data. You can see how 24 and 23 are exceptionally hot. Yeah, we talk about climate acceleration in climate science, and people are trying to model and understand what is going on, because this is really taking off and speeding off now, which is extremely concerning from a number of perspectives. This is even more the case when we look at the sea surface temperature, and this is sort of the turbo on the engine of cyclones and hurricanes. Yeah? Sea temperature, if it's warmer, more evaporation, so it supercharges systems that have existed indeed for a longer time. Look at the anomaly that we see here in 23-24. Antarctic sea ice, we see also the result of this evolution rather sharply. In Austria, they just did a report on the glaciers that could vanish by 2050. Switzerland has already done that. There's quite a bit of work on that in the Alpine countries. And you could say, yeah, well, then the skiers look for another place. But this is not about the skiers. Yeah? The Alps is where the Rhine, where the Danube, where the Inn, where the Po rivers emerge. This is critical for the economy, this is critical for society, and even critical for some health-related aspects. Yeah? So this is where we are in Europe now, and then our politicians call this an exceptional and unexpected set of summers with heat waves. There you see the Rhine River in the Netherlands. That's not Sudan, that is Spain that you see, and we have the forest fires in Portugal. And the response to policymakers is, no, 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 no. You have seen these exact pictures 10 and 15 years ago. They looked like this. Yeah? It's called science. It's called climate modeling. We told you 10 and 15 years ago what the effects would be of climate change. And we were pushed aside as cultural pessimists, or as crymongers, or as whatever they want to call us, but this is what we predicted. And by the way, we have the same graphs for 2050 now, and it doesn't look very good. Yeah. So this is then the world that we live in, with Spain, and the burning there is on Hawaii. You see a Chinese city in the summer on the Blue River, and you see a bunch of Chinese people, I would say, going for a relaxing dip in the pool as a mitigating measure. Yeah? But the key message here is that we are going from extreme weather events to extreme societal events. What we see happening in Spain is not an extreme weather event. It's an extreme societal event caused by extreme weather. Yeah? So we need to understand this systemic dimension much better. And then, yeah, this is what we see now in Greenland. That's a dam in Catalonia that is emptying because there is not enough rain in the villages there. That's around Athens. And in Greece, we see an enormous amount of fires. You could, of course, also pretend that all is fine. Carry on, as the British would say. And then if you live in the right place in the US, you can rent a company to spray paint your lawn if you're not allowed to water it anymore. This as a short intermezzo. Yeah. Okay, so now we go to the European climate law. In 2022, the EU decided in its climate law that we would be climate neutral by 2050. And in the climate law, which is primarily about decreasing greenhouse gas emissions, there is actually a mentioning of health. Better understand, anticipate, and minimize the health threats caused by climate change. So you are in the European climate law. I don't think many of you realize that, but that is the case. Yeah? And where are we going? We are going to what is called net zero. We will not cut all emissions, even in the best of all worlds. Why? You can't. So we will have about 10 to 15% emissions left, which we will offset by taking carbon out of the air. And the two ways to do that is either by technology, which until now is expensive and not functioning at scale and at competitive market prices, or you can do it through nature, yeah, where the nature restoration law will come into play. Of that 15% that will be left over, you are part of it, and I will come to that, yeah? Okay. Also in response to this evolving regulatory framing, Europe has set up what is called a Climate and Health Observatory, and that is part of climate adaptation. It's managed by the European Environment Agency, and it brings together policy frameworks. And if I look at your posters, that's not exactly your cup of tea, but that's fine. Others can translate your knowledge into policy framings. It looks at evidence and resources to dive into. So there is a whole set of studies available there, also funded by the EU system. And you can make linkages that might be interesting for some of your cardiological research in the future. Now, the causal chain here is, of course, that climate change has an impact on factors like warming, temperature, humidity, and that leads to air pollution also, to heat waves. And then there are the vulnerability factors that I assume you know very well. And then we start to see linkages with heart conditions, especially in people who already have a heart condition. Yeah? And why is that important? Because increasingly, and this is about 200 million people now above 65 in Europe, are exposed to a heat wave day every year. Yeah? At least one. Why is that important? Because if you ever want to teach a class on statistics and you want to show correlation that is also causality, yeah, this is the best you can show. Yeah, temperature on the one hand, the yellow line, this is in Uccle in Belgium, close to Brussels, and the green line is premature deaths, people passing away. Now look at the correlation between these two. And that's not people like me passing away, at least I hope so. It's people who have weaker conditions like heart conditions, or are older, or have pulmonary diseases or whatever. Yeah? So there are some linkages. That leads then to specific studies of how in countries we deal with this link, done by the EEA, the European Environment Agency, but also by the scientific community. Obviously, we focus, as always in this type of research, from a policy perspective on the social distribution of these risks, but also people's capacities to respond to these risks, and it's rather clear that they are unevenly spread. Yeah? Let me go back 1 second. What is also a part of the research is that increasingly we look at mental health issues. This is really an important part. So your colleagues in psychiatry are looking at these things in some places now. Yeah. The nature restoration law which was hotly contested by a number of countries in Europe, including my own, which is really bizarre because there are so many benefits from healthy nature that it's almost incredible that people would vote against a law that improves nature. What are the benefits, for example, of nature in cities? One of the parts of this law, well, we see immediate health benefits of nature in or close to cities. And I will not take you through all of this, but it also reduces inequalities. If you put nature closer to parts of cities that are underserved in social services and in income distribution, it mitigates some of the health outcomes. And so we've done studies on where in European cities we are prepared for urban heat effects, for example, with blue and green elements in cities. And this is an interesting map because the greener it gets, the more green in your city you have. But look at the Mediterranean. That's where they need it most. And that's where they lack it most. So they've got a massive catching up to do if they want to use natural systems to mitigate heat waves. We call that nature-based solutions in our jargon. And this leads to simple things like we should all see 3 decent trees from where we live, and 30% tree canopy in every neighborhood. Good luck finding that in the low countries, and we should all live 300 meters from a park at most. Can also be a micro park, a small park. You can say, where is this coming from? It's coming from research in your field, This is research done on young adults, 14, 15 years old, teenagers, response time, reaction times in puzzles they need to solve. And look at where the big jump is. It's in tall trees, in big green, not in grass or in small shrubs. It's in trees, hence the 3 trees. So this is translating fundamental science into things that are understood by our policy makers, never underestimating their shortage of understanding complex issues. So you need to bring it in ways that they understand and are motivated to do something about it. If we look at the zero pollution strategy in Europe, the 2 red circles are aiming directly at health issues. 55% health impacts reduction from air pollution. We still have quite a way to go there, especially in Eastern and Southern Europe, but also 30% share of people that are impacted by transport noise. It's one of the underestimated impacts on our health, mental health, but also cardio. We know from studies. So all of these things are related. Behind every slide there is a set of studies and policies, but I just wanted to give you the broad overview. In the chemicals field, we are standing in front of a revolution. The new framing in Europe is now safe and sustainable by design. So let's not retrofit the damage that we've done. Let's not try to prove that something we've designed, some complex molecule, may be just below a threshold of damaging human health. The message is now design chemicals that in their design stage are aiming at being non-toxic and at being safe and sustainable by design. That also means not substituting them by in the case of phthalates, for example, substitutes that are unregulated but have the same negative impact. So those things are mattering. What are some reflections for your sector? At least I take you as part of the healthcare sector. Well, here is the healthcare sector's greenhouse gas emissions as part of the national greenhouse gas emissions. Look at where the Netherlands are. It's the white arrow. So if we want to be climate neutral by 2050, and you don't want to say to everybody else, look guys, we claim 6% of the 15% that are left over. Your farmers would not be happy, and I'm sure some others. I mean, you have a big job to do, in your sector. Yeah. This is in facilities, in hospitals, in the production of what it is you all need to do your job. That's one thing. You could also be a force for good. You are the most trusted professionals in Europe. Yeah? Doctors are the most trusted professionals. So, there is a research that was done on how and why doctors are not speaking more about climate change to their patients. Yeah? And one reason is time constraints. Yeah? Okay, I guess that is true. Time constraints. Yeah. I have a couple of friends who are doctors and they are under severe time constraints. It's also organized shortage in the case of Belgium because we are limiting the number of doctors and now we're behind and now we need to catch up. But I shouldn't be critical of that, it's not my field. Lack of knowledge. Well, by golly, then make sure that your new students and the new generation has the knowledge. And make sure that you use your organizations to spread the knowledge and to talk about the linkages. Yeah? It will not make a difference. It will. It will. Yeah. Why don't you prescribe? I'm not stepping in your shoes. Huh? A nice walk in the park. It lowers blood pressure. We know that from research. It has a big impact on mental health. You stimulate people to move, and you connect people to the environment. So, I mean, there are ways of doing this in a variety of places where health professionals are working. In terms of, this is not very visible. I normally don't do that. Having to say, I know you can't read this slide, then I always think in your place, then don't show it to me. But where the arrow is the Netherlands. 20% of the healthcare facilities in the Netherlands are in spaces that could be flooded. Yeah. So also there, the risk of your facilities being impacted by, so just a couple of elements to show you that this is not far from your sector. It is part of the society in which you operate. So this One Health approach, if we understand the systemic linkages better, they have the potential to deliver better systemic benefits. But we need to do that in a complex world now. Yeah? Climate change, by golly, it's a complex world to deal with solutions. It's volatile, it's uncertain, it's complex and ambiguous. We call it the VUCA world. Yeah? And how is that clear? Well, just look at the last 3-4 years. The world in which we have been living has not been terribly stable, and we are shifting our attention away from some of these major issues that require urgent attention. We also live in political times that are not exactly the right fertile ground to have these sorts of discussions. Yeah? We know from research that populists, whether they are from the left or the right or non-directional, and you have all three in this country, they are. I don't think that Mrs. Van der Plas has a sense of direction. She's a non-directional populist in my language. I'm sorry to be a bit political, but I'm not sorry actually. We are responsible for electing these people. So we live now in times when it's not so obvious for climate change because they are across the board against climate change policies. The other thing is that they abhor complexity. They don't like complexity. Society has problems. We don't understand them because we're too sophisticated and too left-wing. So they understand them. There's one or two big causes, and they know how to deal with them until they have to do it, and then not much happens usually. But this is not a good time to bring this issue to the table. But we have to persevere. That is my opinion. So in closing, because we need some time for some questions, maybe, I think the implications for this type of approach is for you and the rest of society that we need to try to overcome institutional fragmentation, which is pervasive in most disciplines, including the medical field, that we are sometimes driven by organizational myopia, yeah, my thing. If I can secure my budget envelope, we're fine. Or if I can go deeper, we're fine. Yeah. Professional corporatism, where healthcare professionals and researchers are not necessarily very interested in speaking to environment or climate people, let alone policy people, and a number of other things. Short-termism, cost thinking. In climate change, this is pervasive, as if benefits don't exist. Well, that is shifting quickly. And a lack of communication and joint understanding. My field of study and the medical discipline are rarely meeting each other. Yeah? We don't have the same conferences, we don't read the same literature, we don't share data. I mean, we still have many steps to go. What could be some pathways for this? A national strategy on this. I wouldn't hold my breath at this moment here, but let's assume you could have a strategy like that. Then a one government approach to these issues would definitely stimulate the types of discussions and policies that are needed. Of course, a longer term vision, which we need on climate change, but maybe also a bit more on the health and health climate nexus. You need a knowledge strategy for that. There is not a lot out there that makes these macro connections. If you look at research portfolios, I don't know in the Netherlands that well, but not in my country, we would need monitoring and early warning that connects serious impacts from climate change to potential impacts in the health sphere. Think of heat waves, but also other elements. To give you an idea, I have a personal interest in people with intellectual disabilities. I have 2 kids that have intellectual disabilities. We know from research that when a climate disaster hits, that more than 70% of the people who pass away are people with mental disabilities. Why? They don't understand the messages, they don't get out in time, they are not taken into account when we formulate the plans that we need to do something about it. So there are so many things that we could do to link these fields in an intelligent and socially responsible way that it's amazing. That will be my link with your field. I'm setting up, together with a colleague in Brussels, the first European conference on intellectual disability and climate change. It has not happened. Yeah? And we should look at the benefits lens. Yeah? So let me end by saying there is no alternative. Yeah? We will not change the laws of physics. Climate change is happening. The impacts will become harsher also on your patients. And if we don't strive for better understanding and for better policy, both in climate change and in your field, we are going to miss massive opportunities. And we will see the impacts of that in terms of people living in poor health or in passing away. I realize that I have not mentioned anything that is in your field directly, but I hope that by framing the issue in this way, I have stimulated you to place your own field in this type of broader discussion. Thank you, and happy to respond to any questions.
Wow. Thank you very much for this very stimulating, frightening at some times as well talk, and also a call on our responsibility as individuals, as scientists, and a community. I'm sure there are lots of questions, thoughts, comments for Professor Bruinings.
Well, thank you for transferring this really important message to us as an academic community with all our responsibilities. So changes come by the people, like a revolution, but that needs a lot of commitment. And we Dutch, we do not like to look into the mirror, but we start pointing at Shell, starting lawsuits. But yet you
told us just now that like in the early 90s, the sustainable or the global sustainability goals were already there, albeit under other names. And yet we lost a generation of time in maintaining a stable environment and biodiversity. But at the same time, we managed as a global community to dodge this ozone crisis, as you displayed it in your planetary boundaries slide with the stratospheric ozone depletion. Maybe because it was easy, just like lose the CFK spray cans. But then again, we managed to do it. So what changed then? So why? Because I mean, it's all about fossil fuel, about food, meat especially, and all these kind of things, which act on you personally. But so did, in a way, the DO sprays that we had to abandon at those times. So what is the difference? Is there a generation difference, or is it more self-centered individualism? Or?
Okay, that's card number 12 that I hand to my students if I give the exam in global environmental politics. Why was ozone layer depletion an easy case, and why can we not take that as a model for climate change? First of all, a very limited set of chemicals, ozone depleting substances. Secondly, hardcore evidence that was there. A Dutch chemist won the Nobel Prize for that, Crutzen. Thirdly, if you wanted to solve the problem, you could put the CEOs of 90% of the producers around these chairs here. So a very limited number of key actors, and they had replacement chemicals. They had alternatives. So we pretty much phased it out, and it went extremely fast. So this is a global agreement, the Vienna Convention from 1983. By 1985-86, we had the Montreal Protocol, and it went down immediately. But it had very little impact on society as a whole. I mean, we needed different coolants. We needed a couple of other things in spray cans. So what? When we talk about fossil fuels, we talk about the whole of society in all sectors, in all of its elements. And we need every country, like at the COP. I came back from last week's COP in Baku. You need the whole world to do this, and you pretty much need all sectors to be involved. So very different case.
So this is actually a kind of really rare, successful top-down decision, because it had nothing to do with the responsibility of the users. They didn't abandon; it was like abandoned from top-down.
Yeah,
which will not happen with fossil fuel or with food or meat or those kind of things.
No, but we have a couple of other cases. Acid rain in the 1970s, SO2. I mean, we tackled that. Why? That was an end-of-the-pipe solution. Rather simple technology that was payable. We put it on top of stacks. I simplified things, and we dealt with it. In the 1970s in Germany, we talked about Waldsterben, the dying of forests. And when we put a German word on something, we know it's serious stuff. So, voilà, the Waldsterben, we dealt with that, but it was rather easy. Another good case is lead. Lead in fuels, we just took it out. And we know what impact lead had on brain development, on cognitive development. I mean, so we tackled those things. Where we are now is a completely different set of challenges.
Right, very interesting talk. Thank you very much about that. Maybe I want to pick up on chemical pollution very briefly. And more specifically, like, we know we're falling behind when it comes to trying to understand the effect of all these chemicals that at the moment are currently in our environment. Take a look at PFAS, for example. Asbestos was like another case. So even when we catch up and try to understand what kind of effects they have on the body, I can imagine companies and factories, they will keep on producing other similars, like the phthalates, for example, right? And this is just one example out of many. So out of a policy-making kind of view, how can you really tackle a problem like that, where companies will continuously keep on pushing their chemical boundaries?
Okay, great question. It has several components, and also, I mean, very hot policy topic for the next couple of years. First of all, we're not catching up. Europe has the best system to look at potential impact of chemicals on our health and on environment. It's called REACH. The agency that does that is in Helsinki. It's the chemicals agency. And what we do is every single substance needs to be evaluated. Yeah? Every single substance. Now, if you're a good chemist, which I'm obviously not, you can take a really complex molecule, you change one of these little connections, you have a new molecule, it needs to be studied again. Yeah? First message there is we will not do that anymore. We know that PFAS, PFOS, PFOA is one group of 4,000 to 5,000 chemicals. They have broadly the same characteristics. We will look at this group as a group and make a decision as a group on these chemicals. And so we step away from having to understand 100,000 chemicals which are used in the European economy broadly. There are more, but that's sort of the big mass. We can't catch up. Yeah, that's one thing. Secondly, it's this idea of safe and sustainable by design. So we are pleading for a different type of molecules and for green chemistry. Paul Anastas, professor at Yale University, is the grandfather of green chemistry, and he has set principles out for what that means and how that is critical to contributing to sustainability objectives, climate change, biodiversity, circularity of the economy, all of that. So we are pushing in that direction. This is on the agenda of the next commission. I can tell you this will be a battle from hell, yeah? Because it's a hugely important sector for the European economy. We need to recognize that. Also here in Limburg, by the way, and in Rotterdam, in the Europort and other places. So we shouldn't underestimate that. We all want a decent job, also the people in that sector, yeah? But it's also a sector that is lobbying like hell, especially in some of the old crocodiles in that sector, to hold back, because it's also incredibly innovative in a number of spheres. Young entrepreneurs coming from this university and others doing this green chemistry, but being held back. And it's also a sector that faces outrageous external competition from China and other Brazils and Indias. So it's a difficult exercise, but it's clear we are going in that direction. The model is out there, the science is out there, the direction of travel is clear. We need to get over hurdles, and what is holding us back? That's now the main question, not where should we go.
Can I follow this up a little bit? Because what you pictured is going to take a long time. What we can do now, I'm a pharmacologist, I tell the doctors, do not prescribe drugs that have a CF3 group, so because that will be trifluoric acid in the environment. So I could choose, as I educate, well, not dutasteride, not fluoxetine, not lansoprazole, all the common ones that we prescribe, say, oi, cut with that. But how can we regulate this on a European level? Because that's a very specific issue that can be done now, and we don't have to wait for years and years and years.
I fully agree, and it's in line with the general thinking that this message, which is the end of every PhD or paper, is we need more research. Yeah, that's true. You know, I'm an academic myself, but there is more than enough knowledge out there to act now, as you suggest. Well, there is a European association in your field, for sure, because everybody who can read and write and has a job has a European association of that job, so also your field, yeah. So this is something to be brought to the table in these discussions, and maybe brought to the table in the Netherlands here in discussions when there is a fertile discussion possible. So yeah, I fully agree with the direction that you indicate. Then you need to bring it to Brussels at the right time, to the right people in the right form. And the right form is not complex histograms, I'm telling you. They're not interested in that. The right time means that you need to hook up with your federation or with others who understand the policy cycle, because knowledge plays a role in European policy formulation more than in most member states, especially when it comes from the Commission, the proposal. It has the right of initiative in Europe. That's when you need to be there. You have your national representatives there, you have your lobby group, can be a very positive lobby group for this. That's when you need to be there. And then you need to bring it in a form that speaks. That's how it works.
Thank you very much for this impressive talk. I have a question about digital twins. Are you familiar with the concept of digital twins? Imagine an app where, it's used a lot in cardiovascular research now, where you will have a patient that looks just like you, has the same BMI, age, risk factors, and maybe treatment, and you'll be advised to exercise or lose 5 kilograms of your weight, and you will move as a dot on a graph somewhere else. So it's a very sort of, we hope that it's a user-friendly app or a game to convince patients, if you do something, if you act, this is the outcome, and you can compare yourself with others. So there is a lot of, let's say, me, and jealousy involved. Is it something you think that will work also in changing the habits regarding climate change? That if you plant more trees, or if you see more than 3 trees out of your window, you might have that less damage in euro because of climate change?
Well, yeah, of course I believe in the power of digital imaging. In fact, I'm not here. You've been looking at a hologram the whole time. No. What you're asking, honestly, is well out of my ballpark. What I can say is that there is really serious work done within the field of climate change and climate change policy on what the contribution could be of the digital revolution, of data analytics, of AI in the field that I work in, and that includes imaging other futures through, whatever these big goggles are. I'm not into that field. It's rather far removed from what I do, not because I'm a skeptic, but it's not my world. I still believe we have a lot of space above our own heads to use our own intelligence before we think that artificial intelligence will be the solution. I'm not saying that I'm not a big believer in the potential power of artificial intelligence, but then Europe will need to make this its own terrain. Because I'll be ridiculing maybe a bit, but it's a field dominated by the US and China. The US pushing consumption, China pushing control. Is there no space in Europe for a digital revolution that serves the broader public interest, and where Europe is really investing in that? I wonder sometimes, and maybe this can be part of that. And I see some people looking like we need to move on in the program, so I assume that was the last question.
No, well, yeah.
Yes. Yes. Thank you.
But it's so much fun, and there is so much to learn from you. So I don't know if there are any final questions. If not, then I want to ask a little one at the end about AI, because we are actually promoting everyone to use it for different. But it has a carbon footprint that is quite a bit. So Europe could take the technology position and make it more sustainable, maybe.
Yeah, of course. I use AI as well. I encourage my students to use it. I mean, we would be stupid to tell them not to use it. It's part of the world. They will use it. The thing is, for what? Yeah? And the German presidency of the EU had digital and sustainable development as a combined sort of undertaking. What can one mean for the other? So there's quite a bit of policy-oriented research on that, and out of that came a global initiative where top people in both fields are now finding each other under UN flag to look at exactly the type of issues that you were mentioning. And in the interest of time, I will not dwell deeper into this.
Well, thank you once again, and a big applause for Professor Hans. Okay, great. So there is a slight change in the program now, because I was just asked by Professor Harry Krijns to do the Harry Krijns Research Grant first. And then it's Vanessa's turn to finish this session.
I'm so grateful, Joost, that you allow me to go first. And well, it's time now to announce the winner of the Harry Krijns Research Grant. And that's a grant which is supported by the Health Foundation Limburg, what we call Hart- en Vaat-onderzoeksfonds, but also by Amgen and Bayer. I stopped counting, but I guess it's the third round we have now. And I must tell you, there's a lot of talent in this university. The grant is focusing on people who are at the beginning of their research career, and there's a lot of talent, and I can tell you a lot of applications, and a very hard time choosing the right candidate. And we ended up granting 3 awards. So the awards we gave were to Marie-Julie Lemmens and Zeb van Helden. So they didn't win the Harry Krijns Research Grant, but they get 5,000 euros to support them in starting their research. The winner is Yassim Kaya, and she's going to present, right? The work she's going to. I was missing you. I was a bit nervous, but there you are. Because, well, how do we do this? The selection of the candidate is by them having them present their work, and we were very much impressed by what you did there. I wasn't there, but they told me how you did this and why they choose you. And I'm very happy to now hand you over the certificate and give you the opportunity to present your work. So please come forward. Yassim. Congratulations. Where is this thing? Maggie. The certificate. It's not, it's... Sorry, Tara. Ligt onder. Somewhere. Dus je gaat het echt krijgen, hoor. Kijk. Oké. Nou. Gaan we een foto maken. Proficiat. Ja. Okay, so here it is. Open it up and we show it. Okay. That's it. And you're going to present, right, your work? Enjoy, and so we will enjoy. So please take the floor. Yassim.
Nee, met de PowerPoint. Ja, aan de linkerkant. we can start. Very good afternoon, everyone. My name is Shivkumar. I'm a researcher under the guidance of Professor Volders and Dr. Tebeke. Really, thank you for having me, and obviously, very much thank you for the grant. Using the Hardy Kleins Research Grant, we will fund our study, which is named the 3D Precision Radioablation for Ventricular Tachycardia. And I'll first give you some background information about this disease. So ventricular tachycardia is a life-threatening heart rhythm disorder which originates from the arrhythmogenic substrate of the heart. This substrate is basically the diseased myocardium, which consists out of complex structural and electrical components. And I've tried to visualize this in a very easy manner right here. So we have a patient who had an infarct. And if we zoom in on the area of infarction, you can already see some structural components. And then I'm talking about the border zone, the non-infarcted myocardium, and the scar core. And using the very colorful arrows, I try to show you how the electrical conduction is in these patients. Now, as I said before, this is really a simplified manner of showing this. In reality, this substrate is very complex, and it is also unique for each patient that has VT. But the problem with the substrate is that we do not quite understand it well enough. If I would have two patients who both have a heart attack, I could not predict which patient would get VT in 2 years and which one would not. And this is shown and reflected in the fact that we have a very difficulty with treating some of these patients. So remember this, arrhythmogenic substrate, complex, structural and electrical components. And now let's dive into the treatment modalities that we do have to offer for now. Obviously, we have the antiarrhythmica that we can give, but they have a lot of side effects, as you can see on the slide, and they are also not always successful. Then we have the invasive catheter ablations, which are unfortunately in 30% also not successful. And we have the possibility of implanting a cardiac defibrillator, which gives a shock when there is an abnormal heart rhythm. But unfortunately, there are also shocks that are inappropriate, and obviously this does not treat the underlying cause of VT. So there are quite some patients who are not treated properly and need something else, and that is where radiotherapy comes in. So radiotherapy is a non-invasive technique where we give radiation beams to a certain part of the heart, basically the arrhythmogenic substrate. And in this case, we call this substrate the target volume because it is what we target. And we do this together with a multidisciplinary team existing out of radiologists, cardiologists, and radiation oncologists. And we decide on this target volume all together. And now I'm sure you're all very curious if it works, and it does. I think a very important paper is the one from Professor Kukulic. It was published in 2017, and you can see in the figure that after treatment with radiotherapy in 5 patients, as shown with the red arrow, the number of ICD shocks and VT episodes went down drastically. So it does work. Now, looking a little bit deeper at this target volume, basically what we need to do within our group is that we have to look at all the components of the arrhythmogenic substrate that I just talked about, using all the modalities that we have at hand. For example, the CT scan showing the scar architecture, or the invasive catheter ablations showing how the ventricular tachycardia goes through the tissue or where it exits from. Based on all this information, we finally have the target volume, so we decide, okay, this is the area of the heart that needs to be ablated. Now, if we have decided that all together, usually within the cardiologist group themselves, we now have to transfer this information to the radiation oncologist, so they can then develop a treatment plan, as you can see on the right side. This is the planning CT of the radiation oncologist, with again the target volume being the purple one, and then several margins surrounding it to make sure that all the treatment is properly given to the area that needs to have it. Well, you can already imagine that this is quite difficult to do, and there are actually 2 challenges that we are facing in this. First of all, how do you go from all those different modalities, which are often also in 2D, to an eventual 3D target volume? That's challenge number 1. Then the second one is, how do I make sure that the radiation oncologist knows exactly where to be? How do I make sure that there is no miscommunication? Now, to challenge those, to tackle those challenges, we created our own workflow for these patients, and we called it the 3D precision technique. So the first step is to have a 3D visualization of the heart, where we can solve the problem from 2D to 3D. And we do that by integrating all the available modalities in a special software, which is called ADOS 3D. And it is able, using AI, which we just talked about, to create 3D models of the heart. So for example, I can visualize the structural components using the CT and some parts of the invasive mapping. I can look at the electrical components, again with the invasive mapping, or with ECG imaging, as my colleagues also talked about. The special part about this program is that I can co-register all those elements with each other, allowing me to have a 3D model that shows all the areas of interest that I want to ablate on top of each other. And that's very handy because using those models, I can immediately show the area that needs to be treated. So you can see here on the left and the right side, you have the electrical areas of interest, which I drew in. And on the right side, you see the structural areas of interest, and they all come together eventually in the final target area. Okay, so now we solved that problem already, how to go from 2D to 3D. So now for our next problem, how do I make sure there is no miscommunication? And the fun part about this workflow is that there is not really a communication here, because I just transfer this target area that I made on a 3D model together with the CT scan to the radiation oncologist. And they are immediately able to produce that in their treatment plan. So I don't need to explain you have to fold the heart like this and then only use this area. I can just show her the area that needs to be ablated. Now, obviously, I think this is the best way to approach this because I am the one researching it. And we have been very successful so far in the 4 treated patients, but I also need to prove it. And that's why I decided to apply for this grant. Because what do we want to do? We want to look at different tactics that are being used to determine this target volume. And to do that, I approached the Stopstrom Consortium, which is a group of centers in Europe that all use radiotherapy. And I was able to include 25 patients for this trial, where I will use different methods to eventually delineate the target volume. One of the most used methods is, for example, the 17-segmental approach, where the heart is delineated in 17 segments, and then the cardiologist just says, okay, we need to ablate all of those segments. But it is way less precise as what we are doing. Then you have the 2D to 3D methods, where you use different screenshots and then use AI to eventually make a 3D volume. And you have our own method. So what are we going to do? For each patient, I will retrospectively make a target volume based on those 3 methods, which would then, for example, look like this. And then all the different target volumes will be compared with each other on their volume, the location, and also the overlap. I will do the same for the margins that I talked about earlier. And maybe most important, I will also look at the effects on the organs at risk. Can I prove that if we use our method, we have less dosage exposure to the organs at risk as compared to other methods? I think that might be one of the most important ones. Last but not least, I want to show which method is the most accurate in the transfer between the cardiac CT, so the original target volume delineated by the cardiologist, and the planning CT, so what is eventually used by the radiation oncologist. So what will this eventually lead to? Hopefully, and I think we will, show the most accurate and safe manner of determining the target volume, which will have a big impact on the quality of care for VT patients with radiotherapy. But I think we can also look beyond that. As I said before, the arrhythmogenic substrate is unique for each patient, and with our workflow, we really make a personalized treatment plan, which I think is the future of healthcare. And we also understand the development of arrhythmias better. Without further ado, I would like to thank my team. There are way more colleagues, but those are the key players. And I also want to thank the whole committee of the Harry Kreins Research Grant once more. Thank you.
Thank you very much, and congratulations. also
Thank you.
on behalf of me. And we have some time for questions. Fritz?
Well, thank you. Very nice project. I had one question. Obviously, you measure activation of the heart, which is during the QRS complex, of course. But radiation is going on, and you know that the heart is moving.
Yeah.
So you may define the target area in a systolic phase, but if you radiate either during diastole only or throughout the cardiac cycle, you create a much larger damage maybe than when you were specifically during systole. So how is that radiation going? How do you take that motion into account?
That's a really good question. So there are different tactics to regulate that. First of all, you have the respiratory gated. So you make sure that you only do it at certain phases of breathing, but you also have ECG gated different techniques. And as I said before, we also have the margins. And so we create a target volume based on the arrhythmogenic substrate, but the radiation oncologist also has the margins surrounding it to make sure that if there is some dispositioning or some movements, there is still enough treatment administered to the arrhythmogenic substrate.
Which means that you only radiate during systole?
Sorry, what?
That radiation is only occurring during the QRS complex? Because that's where you have your activation map.
No, sorry. No, that's not true. If you have ECG gated, then indeed you can do it during diastole or systole, but it is currently in our center only respiratory gated.
Okay, so there's a way to go.
Yes.
Still, yeah.
Anyone else? More questions? If not, I have one. So you're integrating this electrical, structural. It's not always overlapping, I guess. It's the interaction between the two. So the determination of the target area is still a human decision so far. Do you see any opportunities there to make that less objective, maybe?
Yes, I think that would definitely be a very good idea because indeed determining the target area is based upon what the clinicians think is best. And you can also see a difference in the results, the outcomes, based on which center you look at. Yeah. So yes, I do think there is human error in this and there should be room for improvement, for sure.
Okay. Then we wish you a lot of success with this research. Congratulations again. And Professor Kreins will be watching you on your way, I'm sure.
Yippee!
With that, I would like to move to Vanessa van Empel. She will be presenting a project I'm also involved in, and a lot of people have been involved in, and that's also expressed by the title. It's about pacing in HFpEF. It's quite a... the connector.
Oh, here.
Oh, it's there.
Yeah, thank you.
Pacing in HFpEF, which is quite a controversial topic, a hot topic in cardiology. It combines two fields in cardiology, the electrophysiology, the device treatment, and the heart failure field. And Vanessa, when you're ready.
Just a minute, starting up.
Our IT specialist will help you.
Don't worry. No, I just have to... I'm fine, I think.
Yeah, it's coming up.
Oh.
Okay. Yes. Pacing in HFpEF, CARIM, HVC, Team Science.
Yeah.
Thank you.
So thank you for the introduction, and I'm really glad to be the one standing here today to present our work on pacing HFpEF. And I think this work is really a true example of the team science. And I think what's really good about team science is the CARIM and HVC also work together as a team. And we can be really proud of being a part of this team that has been recently merged as one department. So I think CARIM plus the Heart and Vascular Center is really the key for successful cardiovascular, clinical and preclinical research. And I think this research is really a good example that the close connections that we have between CARIM and the Heart and Vascular Center is really good for developing these two things. And the cardiovascular clinical care and science and combining those was essential for this project. So our team of EP, heart failure and biomedical engineering were all necessary to make this project really successful. And it was successful because we recently published in the European Heart Journal, and it was even picked up yesterday at the national news site of nu.nl. So I think Maastricht, again, is in the news with really enthusiastic and good results. But back to the science and back to HFpEF. I think a lot of you already know HFpEF is a disease of the left ventricle, about a stiff left ventricle with also a reduced relaxation. And these features make sure that your left ventricular filling pressures, your left atrial pressures are increased. And due to that, you get some congestion and people get shortness of breath. And it's really typical for HFpEF patients to be short of breath already by minimal exertion. And a lot of you probably know the pressure volume loops. It's something that we all learned at some point during our physiology classes. But I really want to take a few minutes to get into that for this project, because the pressure volume relationship is really the key to our research and was really the key in designing our research. So with a normal heart, you have a pressure volume loop that looks a bit like this. And then if you have heart failure, if you have HFpEF especially, the left ventricle, of course, is stiffer. And then you see that the pressure volume relationship shifts up a little bit towards the higher up. And then the pressures, of course, are increased. And for a long time, we thought that beta blockers were beneficial in heart failure and in HFpEF as well. It was thought that because a beta blocker reduces the heart rate, you would increase the filling time, and that would be beneficial for the filling of the heart. But not that long ago, there were several papers saying if we stop beta blockers, maybe these patients have less exertion and a better improvement of quality of life. And then if we take into account the pressure volume loops, we should have known that it was the case already, because what happens if you decrease the heart rate to say the same, to regain the same cardiac output? Of course, you have to increase your stroke volume, and then you have to increase your left ventricular and diastolic volumes. So if you already have a curve that's up, then if you add beta blockers, it shifts even more upwards and to the right, and the pressures go up even more. So with this knowledge and this hypothesis in mind, we thought maybe we can even go an extra step and say it's not even the beta blockers who worsen heart failure or HFpEF, but maybe accelerated heart rate is better in HFpEF as well. And although I think the lower heart rate is definitely not better in HFpEF is widely accepted now, increased filling pressures or increased heart rates that it will reduce filling pressures, that is quite an hypothesis that was quite new and innovative. But with this knowledge, we thought we could really see how that would go in our HFpEF cohort. And at the same time that we were thinking about developing a study to study that, the MyPace clinical trial came out. And I think this really strengthened our hypothesis. The MyPace trial is about HFpEF patients who were already receiving a pacemaker. So these HFpEF patients had either a sinus node dysfunction or V node dysfunction or some other indication to receive a pacemaker. And then this group was divided into two groups. One of them got the usual care, the usual pacemaker parameters, and the other group had a pacemaker instellingen that were a bit higher, with a higher lower rate. And so accelerated pacing. And then they evaluated the exercise capacity, quality of life, and NT-proBNP. And you can see here on the graphs that in the light blue is the group with the accelerated pacing, that you see that after a month, but even also after a year, they have an increased quality of life. They have a lower NT-proBNP, but this group also had a change in patient activity. So this group was much more active than the group that had a standard pacemaker. Another thing was, because they had a pacemaker, they could also evaluate the AF burden, and this was also decreased in the patients with an accelerated pacemaker. So, although I think this study really emphasizes and strengthens our theory that patients with HFpEF and accelerated heart rate is better, it didn't really explain the mechanism of why the accelerated pacing was better. And we already hypothesized that with our pressure volume loops. So we thought, how can we investigate this further and see if it's really the case that the filling pressures of the heart are decreased. So together with Joost Lumens and his group, we used the CircuitUp model. And I think that's quite known for the group that you said there, but it can really simulate different conditions, beat to beat in real life, and evaluate the hemodynamics. And Tim van Loon already worked with me on simulating HFpEF in the CircuitUp model. This is published a few years ago. And in the CircuitUp model, we changed two parameters. We changed the LV relaxation and we changed the LV stiffness. And if we did that, we really saw our typical HFpEF model with echocardiography that we see in all the HFpEF patients as well. So we used this HFpEF model to evaluate what does accelerated pacing do in HFpEF. And if we did an increased atrial pacing rate, the model really predicts a reduction of left atrial pressures. But then if we increase the rate even further, we saw that the beneficial effects diminished and will even detrimental. So the high pacing rates are definitely not better in HFpEF, but maybe pacing rates between 80 and 90 were beneficial. At least that's what the model predicts. But what about the patients? So again, together with the EP and of course the heart failure unit, we decided to do a clinical study. And we used atrial fibrillation patients who underwent a pulmonary vein ablation. And of course you can think atrial fibrillation patients not the same as HFpEF, but there's really a big overlap between the two groups. A lot of the patients with HFpEF develop atrial fibrillation due to increased filling pressures and vice versa. So we decided this was a good group to test this theory. We excluded the patients with a reduced ejection fraction. And the nice thing was patients who underwent a pulmonary vein ablation, they already have a transseptal catheter in place. So the transseptal catheter is placed in the left atrial, so it's really easy to measure your left atrial pressures. We also inserted an external pacemaker so we can increase the rates of pacing. So this is just a patient example. You can see on the left a sinus rhythm of 52 beats per minute. You can see the ECG, and then in the lower bar you can see in blue the left atrial curve. And you see that in rest, sinus rhythm of 52 patients has a mean left atrial pressure of 10.8. You might think that's a bit low, but these are all patients under sedation, so this is actually quite normal for that state. And then you can see when we start pacing, 60 beats per minute, 70 beats per minute, all the way up to 100 beats per minute, that we really see a decrease in left atrial pressure from 10.8 to 5.6 in that one patient. So that's a decrease of 5.2 millimeters of mercury. And that's really a significant difference. Again, if we start pacing higher, this effect was already diminished. And at the really high rate, you even see that the left atrial pressure is increased. So this patient example really is in line with everything that we simulated in the model. And we did that 75 times. We did 75 patients of measurements. And with all the the individual patients, we decided the optimal point in which pacing rate was the maximal decrease of left atrial pressure. And you can see that in the middle bar. On the left of that, you see sinus rhythm, in the middle, the optimum, and on the right, you can see the maximum rate. And what you can see there is that on average, about 100 beats per minute was the spot where most people had the optimal of the lowest left atrial pressure. But of course, you see a big variation. On the left side, you also see how much the LA pressure reduced in this whole group of patients. And on average, it was between 3 or 4 millimeters of mercury. And that might not seem a lot, but actually, if you look at the pressures and how much it increases during exercise, this is actually quite significant. And you really expect, if a patient has a decrease of a few millimeters of mercury, that you really have a significant effect on the exercise capacity. The other thing that we saw as well, that the PR interval was increased if the rate of pacing was increased, which was not so surprising. So I think this study taught us 3 important things. Like the moderate accelerating pacing was reduced, the LA pressure in AF patients, high pacing rates are not a good idea, and interestingly enough, the PR interval really lengthens in response to accelerated pacing. And that led us also to discussion whether we can use the PR interval to also influence the reaction even more. So optimize it even more. So not just the pacing rate, but also the PR interval are probably both very important parameters by which you can unload the left atrium the best. So to study that again, we went back to computer modeling. Because in our patients, we only did atrial pacing, so we couldn't influence the PR interval. So this is a bit of a difficult graph, but I'll talk you through it. At a constant PR interval, then on the x-axis you see the pacing rate, and on the y-axis you see the PR intervals. So at a constant PR interval, like 150, with increased pacing rates, you see a certain level of left atrial pressure. And that's the color that you see in the graph on the right. So blue is really good, and the red is really an increase in left atrial pressure. So we really want to aim for as blue or as purple as possible. And then, if we increase PR interval, like we normally do at pacing, you see that really affects your LE pressures. You can see that with an increase of PR interval, an increase in pacing rates, the increase also develops from the left atrial pressure. The white bars that you see is our patient population. So with normal atrial pacing, you see that it increases. Increases the PR interval, and then at some point you start being in the red zone where we don't want to be for these patients. But what if we could decrease the PR interval? Of course, we couldn't do that in our patients, but we could simulate that. And then if we decrease the PR interval a little bit, you see that with increased pacing rates, you still see a really big decrease in left atrial pressure. So you see the sweet spot, the blue spot is quite big, and that's where you want to be. So the highest benefit is between 100 and 120 pacing rates with PR intervals just a little bit over 100 milliseconds. And I think that's important to realize that not just atrial pacing will be beneficial, but probably patients will benefit more if we can also do atrial ventricular pacing, where we can influence your PR interval. And then this was just done in the HFpEF model, and we also modeled one with also atrial dysfunction, because we think atrial dysfunction probably also influences your left atrial pressure. And there you see similar patterns. So on the left is the HFpEF phenotype, on the right is the HFpEF phenotype with additional atrial contractile dysfunction. And you see similar patterns, but of course the blue is not reached, and you see that really atrial myopathy attenuates your response to pacing and the decrease in left atrial pressure. So these two things together, we see AV delay shortening is important in accelerated pacing, and the atrial dysfunction attenuates the unloading response of our pacing. And with that in mind, we decided to do again a clinical trial, because this is the simulation, but what is really happening in a patient. Does accelerated DDD, atrial ventricular pacing, improve quality of life? Does it really improve our left atrial pressures in patients with HFpEF? And that is the next step that we will take. We have not started this trial yet, but we want to do a clinical trial, the rapid pace HFpEF study, in which we really implant pacemakers in HFpEF patients. And we decided to do a two-step approach of this study. So first, we will see in the individual patient, is it really beneficial to do pacing? And for that, we do have to do an external pacemaker and measure the wedge pressure and do a pacing protocol. And it's just step one to make sure before we implant a permanent pacemaker that this does not have a detrimental effect in this specific patient. Step two, in the same session, we hope to implant a DDD pacemaker. So atrial ventricular pacemaker, we decided to do left bundle branch area pacing, and then what we do afterwards, 45-day pacing off period, 45-day pacing on period, and then evaluate quality of life, a 6-minute walk test, atrial fibrillation burden, and the symptom score. And I think with that, we can really see whether our hypothesis from the model, which is really confirmed that the patients or not. And we will start this trial hopefully the beginning of next year. And as I said before, this is a team science. I want to thank the whole team, and especially also our collaborating partners from Vermont and Minnesota, the group that did the MyPace study. But I think we need to thank two persons specifically, and it's Tim van Loon. I think he did most, if not all, the simulation work that I presented here today. But also Johan van Gol. The last study that I just put in 2 slides has cost us a lot of time with all the legislation, all the ethics committee, all the finance problems, and Johan has done all the work for that. So I think those two are really the two faces of the team that maybe should have been up here, and hopefully we can present all the data from the patient trial next year. Thank you.
Thank you, Vanessa. Great. And indeed, I can express that as well. Also, Tim is sitting here in the middle. Actually, we have to admit, he basically...
Johan's sitting...
And Johan, where is Johan?
Yeah, there.
Johan and Tim are sitting there. Tim made all the slides.
Yeah.
So if people are interested in nice visuals, go to Tim. He will help you. I can provide you the budget number to pay. And I'm sure there are lots of questions for this new idea.
Thanks. Very nice presentation, a nice project. So going back to these physiology classes, when you are to increase artificially the heart rate, what happens to cardiac output, blood pressure, and what would you expect?
So, well, of course, you have an acute effect and then a more chronic effect, but also would induce, of course, the volume, your blood volume, and all that. But what we've seen so far is with moderate increased pacing that actually that really decreases your pressures, left atrial pressure. So what we see in the pressure volume loops, what we did not do, but really same as we see in the simulation, that really does shift to the left a little bit. And what maybe not so clear for everyone, but in HFpEF, what the real problem is that people exercise just a little bit, and when we exercise as healthy individuals, our filling pressures will increase as well at some point. But what happens with HFpEF? These filling pressures increase rapidly. So that's the problem, that it's such a rapid increase that they immediately have dyspnea complaints, even with little bit of movement. So I think if we can lower it at rest and then it takes a little bit longer for the left ventricular filling pressures to increase, that you can give these people a lot more quality of life and a more exercise capacity. And it's also, it's actually a bit of a discussion on pacemakers in HFpEF, but this biggest discussion is that we don't use the same endpoints at some studies. There's this one study that used chronotopic incompetence as an endpoint, maximum exercise test, and how high can the heart rate go. And of course, that is something completely different than what we do in everyday life. In everyday life, we don't reach our high heart rates, hardly ever, sadly. But it's much more important to do little things and have a slight increase in your heart rate. So to have chronotopic incompetence, where you cannot reach the maximum heart rate, pacemakers will not help you there at all. So there's this big study from a group in Boston, and they said, oh, you should not implant pacemakers in HFpEF. But it was a completely different reason for implanting pacemakers.
Mm-hmm. And we, from the modeling, we are, well, if we base our opinion on the predictions of the simulations, in all those simulations, cardiac output acutely goes up. And it might even be, well, we don't know whether this is in the patients, but in the new study, if I recall right, we decided to have an arterial line in, mm-hmm. to have a direct measurement on blood pressure. Okay. And it might be that the lengthening of the PR interval, pacing induced, has to do with autonomic nervous system due to a pressure change. But that's one component. There are several other potential mechanisms there. Yeah.
In the back.
Peter van Dam.
This is all mechanical, of course, and I have to bring in the ECG because recently published a paper that the repolarization gradient predicts CRT outcome. So as you already record ECGs, maybe you can take that into account and we finally can get to work together.
Might be a good reason not to do. No, sorry. Any thoughts, Vanessa?
Yeah, I think that's easy to do. We definitely didn't think about adding additional ECG recordings, but that's not.
We have the monitor
to
ECG data. Yeah.
We have that. Yeah.
Anyone else? No.
Then you can decide how long a break you want.
Exactly. We stole some break time again. Tilman, what are we? 15 past. Yeah, and Tilman says that Constance Baten is supposed to be here to to set up, I think, or discuss things. Yeah. Thank you. And thanks to the speakers.
Ladies and gentlemen, may I have your attention, please? It's a great honor. It's really a great honor for me, on behalf of all of you, to introduce the next speaker. He is the keynote lecturer of today, or the Reneman lecturer. His name, Dr. Kalyanam Shivkumar. It took me some time, Shiv, to spell this out correctly in the past, and I'm very happy that we can all say Shiv, which makes communication easier. Dr. Shivkumar is a very eloquent speaker. He received his medical degree at the University of Madras in India in 1991, and then went for his PhD to UCLA, where he graduated in 2000. He completed his cardiology fellowship training at UCLA and then joined the University of Iowa as faculty, where he also served as the associate director of cardiac electrophysiology. And then they recruited him back from UCLA in 2002 to then direct the newly created UCLA Cardiac Arrhythmia Center. His field of specialization is very broad, but in essence starts with interventional cardiac electrophysiology, but he's also professor of medicine, radiology, and bioengineering in one person at UCLA. He holds memberships in many professional organizations, and he is the editor-in-chief of the Journal of the American College of Cardiology, Clinical Electrophysiology. Dr. Shivkumar has contributed significantly to the postgraduate program run here in Maastricht, Diploma of Advanced Studies in Cardiac Arrhythmia Management, that we organized together with the European Society of Cardiology. And I can tell you already, his lectures are breathtaking. He masters the art of providing multidisciplinary solutions for complex questions on the regulation, call it neuroregulation of the heart and the cardiovascular system, and his in-depth insights into these mechanisms and treatment of arrhythmias, but also beyond of the cardiovascular diseases that he studies are translated into vivid, artful illustrations and slides. And always with a flavor of ontology or a flavor of evolutionary background. This multicultural background adds to the greatness, as it exemplifies how an individual can make a successful life journey, inspires many on his way, and continues to seek for new connections with people and places. Dr. Shivkumar is very aware of the European landscape of cardiovascular science and its history, and in particular, he is a connoisseur of the Dutch School of Cardiology, with many colleagues from the past and now alive, or those who have passed away, with whom he acquainted personally. In the last years, he has regularly hosted in UCLA a group of Dutch colleagues, led by Emeritus Professor Giel Jansen from Amsterdam, and among the group, our own Dr. Bas Boukens, who is in the audience, to come to Los Angeles and do joint experiments. The title of his presentation is "The Issue is the Tissue." Why? Well, buckle up and enjoy. Chief.
Thank you so much for that very kind introduction, Professor Walters. So, I mean, you people have a language very close to German. So if my parents were alive, they would schep Nakas. Of course, my wife, who just called me a few seconds ago, still wouldn't believe a word you said. That's because of two reasons. She's actually a professor, but a professor of endocrinology. And as all the cardiologists in the audience know, they are a group of people who know for a fact that they are far superior to us because they're a cognitive field. But I'm hoping to actually at least tell you that we have spent a little more time, and the science part of our field is now becoming more relevant, because one day we're going to be able to actually diagnose future incidents of diabetes actually using the ECG. And that's not a joke, it's actually true. For this particular audience, I'd like to again highlight the fact that it's worth, sort of tipping our hat to this gentleman from your country who gave us perhaps the single most important test in all of cardiology. So let's actually dive into this. The Arrhytmia Center itself was from 2002. I've had the great privilege of seeing many young people, especially as you see in this audience, who have been through our program, and we are hoping to actually have a link with your university in the coming years. I'm also going to later be alluding to some of these funding sources, because in the end, it's public funds that ends up resulting in very good science. And again, I was very impressed looking at the presentations today, the posters, and also all the grants that your institution has received, which is an extremely young institution if you actually think about it. So congratulations, and all of you should sort of rejoice that moment. The Cardiac Arrhythmia Center is a part of a bigger group at UCLA, which is the Center for Interventional Programs. And we intentionally organized this at UCLA. It's first of its kind in the world, where people who do interventions in all part of the human body, we actually function as one group, just because the future interventions we use doesn't have to just be limited to one organ. And we really have to be looking at the whole human body as an opportunity to intervene early in disease. And I think even for the science we do, we shouldn't just be very narrowly focused on one area and be able to look at the big picture. So we started off with the mission, and I'm saying this for the young people in the audience. If you're going to be in medicine, in any part of medicine, ask yourself, there are 5 missions: patient care, education, research, biomed innovation, and international engagement. Patient care is, doctors in the audience, you're going to take care of several thousand patients in your career. By educating people, and in fact, I was just telling the professors here in Maastricht, when we see students, that is the greatest feedback that we get, because through you, we're going to be able to positively influence the life of many other patients. Research, of course, when you make advances, it can help thousands of people. And in fact, over 100 years ago, the research done in this country is now helping millions of people, right? That's the ECG being one such example. And interestingly, biomed innovation is how you help millions of people, because the research done by Professor Einthoven resulted in a technology which is used everywhere, all over the world. It's used in the space station, wherever you go, it's become so ubiquitous. So keep that in mind. I think this is the way to look at it. The magic of universities anywhere in the world is to be able to help patients you never get to see in your life. That is an even greater privilege than the patient who's in front of you. I actually put this slide up because when I was hearing the other people present, I can actually stand here, and perhaps other than 1 or 2 senior professors over here, I've had more grants rejected than many of you. In fact, most of you. So take that as a badge of honor, because if your grant is not rejected, it's too easy. It means nobody even read your grant seriously enough to actually reject it. All right? So take that as a badge of honor that someone took the time to read it, even if they were really pissed and mad, to just reject it. So these are all the schools where I studied, starting with my high school education. And Henry Ford, I went to medical school in India. I was a resident and chief resident at Henry Ford, went to UCLA to do cardiology and EP, and I did my PhD at UCLA. So why am I telling you this story? Because my link to your beautiful country started very, very early on. This is my doctoral dissertation, which I did as a part of cardiology fellowship. What is very natural for your country is uncommon for us. Doing a PhD and having an opportunity to do a PhD during clinical training is not common in the US. You could do it when you're a medical student, but later on, to be able to do it is actually very hard. UCLA did an experimental program, and this is my doctoral dissertation, and it's years of hard work that appeared in the cover of the journal. But probably the most important part of my dissertation, which I wanted to link to your country, is the beautiful words of Professor Heel Janse. And Andy Witt and Janse have written a book on arrhythmias of acute ischemia and infarction. And this, of course, is how I got to meet this wonderful gentleman. I love these images because if you look at Professor Janse over there, and I think all these professors here, and even Professor Reneman, for whom this lectureship is named, they're all good friends. They're a generation of professors who shaped your country. And I like this because Hill is over there with a personalized jacket of UCLA. And of course, you can see the team from Netherlands. We've had a very tight link, and they do research with us. And Dr. Bukens is on the audience here too. So let's kick this off. When you look at the world statistics of diseases, heart disease, which is slightly declining over the years, sadly in the past 2 years is sort of, we thought had leveled off, is actually going back up. It's estimated there are 19.4 million cardiovascular deaths every year. And this is, this completely, sort of shadows and exceeds all other causes of death, especially all cancers combined. And there's one interesting statistic over here, or the way to look at this data set, and that is, if you look at this, the graphic that I have over here, if you model the entire population at risk for sudden death, and you look at sort of 2 additional concentric circles within it, the inner circle is people who have some evidence of heart disease, and the smaller circle is people who have significant heart disease, in this case defined as an EF less than 35%, roughly the number we would use for patients in whom you would implant an ICD. The shaded oval you see over here is the actual people dying suddenly. Now that becomes very interesting. If you look at the very, very tip of that oval over here, which is intersecting the smaller circle, that is a substantial part of that tiny circle. But it's overall a small number. But the actual number of people dying suddenly, there are more people dying suddenly who have minimal heart disease or no heart disease. And that is a tragedy of cardiology and the challenge of cardiology. And how do they die? They die suddenly. Here is a painting that comes from a literary work from this continent. This is a count who comes back after a hunt, and his servants come running up to him to give him a bowl of cold water to wash his hands. And what happens to the count? He puts his hand immersion in cold water, and he drops dead. His face turns white, his heart throbbed violently, his legs failed him. He fell back to the chair exclaiming, "I'm dying, Lord God have mercy." And of course, the French people tell me that apparently the subsequent sentence says, "Please take me into your hands." That's what Michel Hesseguer told me, that's the actual words in French. But either way, you can sort of look at how dramatic this is. And of course, you can see all the physiology behind this, right? Hand immersion in cold water is one of the remarkable ways in which you can get sympathetic activation. Now, as it turns out, this is a significant issue. 22 people die suddenly every minute in this world. 12 million deaths a year, all right? So to put that in perspective, it's tragic. Vast majority of these deaths are thought to be tachyarrhythmic, but some of them may also be bradyarrhythmic, PEA asystole. And the color maps that you see in this particular image are the examples of repolarization gradients measured in the myocardium, which is driven by neurotransmitters and metabolic changes, things that had interested us and many other groups around the world. But looking at the big picture, if you were to sort of look at the, one of the challenges, I call this, Heel Janse's challenge. This is a very beautiful paper. I strongly urge the young people in the audience to go read this, 1992 Cardiovascular Research. Many of you may know that he was also the editor-in-chief of Cardiovascular Research. This particular article, it was very intriguing. I was an intern in medicine at that time, and I read it over 30 years ago. But it's interesting. We do not understand even a single premature beat. And if you were to actually look at a premature beat and look at the physiology behind it and the pathophysiology, there is a baseline risk. You get the extra beat, and there is a coupling interval after the previous sinus beat when you get the abnormal beat. And subsequently, there are many things that can happen after a beat. You can get sustained tachycardia, fibrillation, or if you just only get single PVCs, and if it lasts long enough, you can actually get cardiomyopathy. And then, of course, you have symptoms and so forth. So the questions that come up is, who does this happen to? Why? Where does it come from? When? And what time of the day? What are the other influences? And after that happens, how does that even capture the rest of the myocardium? And subsequent things that happen, why does it happen? So if you were to ask these questions, one way to look at that would be to pull up some cases and we can look at it. And later we have to sort of integrate these concepts. And as you heard, based on many presentations today, you can start from a cell, you can go to the tissue, you can go to an organ level, look at it at the level of a population. But all of this is being governed by system issues. And that's where things like neuroscience, inflammation, which is systemic in its nature, these kind of influences very powerfully regulate what happens to the heart and other organs. So keep that concept in mind, and let's dive into a little bit of history. So those of you who are art buffs in the audience may recognize that this is a mural that is painted in the Institute of Cardiology in Mexico City. If any of you visit Mexico City, I strongly urge you to go look at this mural. Of course, the city is full of so many other remarkable art museums and murals, but Diego Rivera's mural on the history of cardiology, which is shown over here, is a must-see. This particular mural, of course, depicts right from the Middle Ages, all the people who made important discoveries of the heart. This, of course, starts with a lot of European history. This is people in this continent. This is Calvinists burned Miguel Servet at the stake because Diego Rivera was he always had a protest message in his paintings. In this case, this is the church-state conflicts of those days. And of course, this is the gentleman who discovered or described the pulmonary circulation. Then you also have the scientists, the physiologists, the anatomists, and of course, it's a nice kickoff to how cardiology was born. So in the early days, pre-Einthoven, the only way we could diagnose heart disease was by percussion and auscultation. And it may interest some of the students in the audience that some of the most classic arrhythmias that we talk about on rounds, like atrioventricular conduction delays, the Wenckebach phenomenon, was actually described even before the ECG was invented and came into clinical practice. It came by physical exam, looking at the neck veins and feeling pulses and so forth. Of course, the introduction of electrocardiography into clinical practice completely revolutionized cardiology because you could now take an objective, reproducible measure and you can sort of widely apply it and integrate that into any other type of sort of cardiologic observation you make. And subsequently, when the group in France and Ben Sharlag and the team in the US and New York went on to actually be able to record the His signal in the heart, that of course started a completely new era for electrophysiology. So we were now able to place catheters in the heart and get spatial information and pretty much deduce arrhythmia mechanisms. Of course, that is the birth of electrophysiology, and again, this is one of those moments where yet another remarkable gentleman who I still can't believe he's passed away, Hein Wellens, from your own university, Durham, who came up with the technology and popularized it, and of course, Hein Wellens, who did remarkable international outreach, right? In fact, my mentor, Jim Wise, and subsequently the first director of EP at UCLA, Bill Stevenson, was trained here in this city by your institution. So that shows the sort of the tight links that we've had. So that is the birth of EP. Now, let's actually take the whole cardiac structure function and look at it through cases. So here's a 63-year-old patient, ischemic cardiomyopathy, has had previous MIs, low EF, presence with VT storm. So this is like the classic patient, we do 8 or 10 VTs a week sometimes at UCLA. It's becoming, it's a massive program. And what do you do for patients like this, right? So this is the kind of patients in whom interventions have had a huge impact. So here is a image. This is, you'll be seeing what this project is, the Arrhytmia project. I'll allude to it at the end of this talk. Here is an explanted heart, and we are transilluminating this heart, and you can see that this shows evidence of MI. And now when you transilluminate the heart, you can actually see the thinned out scar in the LAD territory over here, which you can see right here, this entire area that is thinned out, and it's fibrotic. So if you look deep inside that scar, that's where you actually see electrical circuits that result in slow conduction, which can be mapped. You can do epi-endo mapping. It's another area that we've specialized a lot in. Or sometimes you go to the border zone of these scars. Sometimes you get PBCs. So you can get monomorphic VT, PBCs, and everything in between when you actually have a mixture of fibrotic structures and strands of viable myocardium that go through the scar. And again, many of you may have met Professor DeBacker and so forth. These studies is the sort of the foundational basis of clinical electrophysiology. Looking at these scars a little more closely, if you place catheters in the heart and map it, and sometimes when you have explanted hearts, when a patient has a transplant, and you study these scars, this is roughly what you would find. And in this case, you can see I've overlaid an electroanatomic map on to the heart. And what you see in the scar border zone over here, in the movie that's playing over here, this is a technique called iDisco, which is tissue clearing. And what you see in the scar border zones is not just the admixture of myocytes and fibrous tissue, but you also see nerve sprouts. So these areas are actually a new substrate where there is abnormal electrical propagation of impulses, but also nerve sprouting adds an environment where neurotransmitters being released, and also in a sort of a non-uniform way, is highly arrhythmogenic. So that may be one reason why scar border zones are very arrhythmogenic. And it turns out sometimes when the substrate is very complicated, one approach that you could use for treating this is actually neuromodulation. Although that is not the focus of our talk, you can probably look through this Arrhytmia dissection that we've shown you over here in a human cadaver. You can see the complexity and the beauty of nerves that control the heart. And again, we've neglected the system in autonomic nervous system, partly because people said, oh, you do heart transplantation, the heart can just be taken out of the chest and put to another person. The nerves are disconnected, so nerves don't mean anything. That nothing could be farther from the truth. The heart has its own intrinsic nervous system, which is 20 to 30,000 neurons in the surface of the heart. That is like a little brain. That is the reason why the heart functions. Yes, when you transplant a heart, it's de-linked from the central nervous system, but the heart's own reflex circuits shown in this image play a very, very important role in its physiology. And it turns out you can actually hack into the nervous system and you can modulate this at so many levels. You can inject Botox or do cardioneural ablation for neurons in the heart. You can do cardiac sympathetic denervation, thoracic epidural anesthesia, spinal cord stimulation, vagal neuromodulation, and even the higher centers, right? If you sedate and anesthetize someone, or if you're doing the good things like what you do in your country, which is to ride your bicycle and meditate and get a good night's sleep, you're controlling your higher nervous parts of the nervous system, all of which is good. So neuromodulation and cardiac sympathectomy has had a huge impact in sort of, in our journey. And of course, all other centers have now reproduced this. And this is an established treatment, not just for channelopathies, which again has a nice angle from work done in this country, where people like Arthur Wilder have used this for patients with CPVT. but it's now established for structural heart disease, which is kind of an area that our group had specialized in. Now, let's take another patient who has just PVCs, and this patient presents with a cardiomyopathy. So if this type of a patient is the kind of a patient in whom we have exceptional interventional techniques, and look here, this is a passion for many of us who do catheter ablation. And this, those of you who capture this QR code, you'll see this coming through the talk. Just capture that. You can download open access books that we've published. So this type of structure function allows you to map and get to a source of a PVC. Now, we know how to fix this problem. We know how to prevent a cardiomyopathy. But the question to be asked is, why do some people with PVCs have only a PVC and nothing more beyond that? And why do other people who have PVCs go on to actually have non-sustained VT or sustained VT? That is not fully understood, all right? The extreme case which I showed you in the first patient, where you have an infarct and a mega scar with channels, that may be a subset. Now, when you look at patients with PVCs, all of these things are now things related to the tissue, all right? These issues are the ones we are actually beginning to understand. We look at morphology, and the morphology of a PVC is, to a large extent, determined by where it comes from, but also the lands through which the river flows, so to say. So the pathway of cardiac depolarization after the origin of the PVC determines the shape of the PVC. So that sometimes gives you a clue. And based on the morphology of the PVC, sometimes you may suspect ongoing cardiac inflammation, things like sarcoidosis. So these are all the things in the back of your mind. You should be thinking of Hein Wellens' teaching. When you look at a PVC, you should be able to tell, oh, this is not just a PVC, it's a fascicular beat. So those kinds of interpretations come from the ECG. Similarly, ARVC sarcoidosis, it goes through a very diseased myocardium. Pattern, morning, morning, nights, it tells you something about functional nature. The burden of PVCs tells you something about cardiomyopathy, right? So that's worth keeping in mind. The other advanced things is the coupling interval of a PVC actually seems to predict sudden death. Why is that? That is another big mystery in our field. So if you get varying coupling interval PVCs, that seems to actually portend a worse prognosis. And then, of course, coexistent structural heart disease, such as specific conditions like mitral valve prolapse. So here's an example of a PVC where you see a lot of oscillation in the coupling interval. Now, this is the kind of a PVC, if we see in the world of EP, we get worried about it. Why? So this is now the coupling interval of a PVC telling you something about the tissue, where it originates. So when we see varying coupling PVCs, one of the findings that came out of a study, this was done by my colleague Jason Bradfield, was, and this is a collaborative work done with John Miller, which actually showed that PVCs that originate from the sinus of Valsalva, and I think our surgeons would know about it because there are myocardial crescents and sleeves in that area, and that is a sort of a marker for an anatomic location, and it tells us something about functional nature of those PVCs. Whereas PVCs that come from compact myocardium in the right ventricle and the left ventricle typically don't have varying coupling intervals. So this is the two subgroups of coupling intervals of a PVC. Look at how subtle that is, right? And in this particular study, of course, the other disturbing finding was people who had varying coupling PVCs also had a higher risk of sudden death. So that's worth filing away. So there is something happening to myocardial control in these patients, right? Now let's take a 20-year-old student who has malignant mitral valve prolapse. Now this is an extremely fascinating condition. This is a 4D CT, and you can actually see malignant mitral prolapse over here, and you can see you can almost see where the papillary muscle is being, violently pulled by the prolapsing mitral leaflet. These patients actually have a problem with their tissue. Why do we know that? That's because if you look at the inferior leads, you see T-wave inversions. That is something very worrisome because it tells you that also you have mitral valve prolapse. You're seeing some effect on cardiac repolarization. And it turns out that if you look at the data a little more closely, this actually ended up being a portender of why someone actually has a risk of sudden death. So a subset of patients with malignant mitral valve prolapse, otherwise, sometimes some of them don't even have such severe mitral regurgitation, but are at risk for sudden death. So this tells you that this is one subset of a structural problem that impacts myocardial physiology such that it's able to sort of sustain very serious rhythms. Now let's look at another patient here. This is a 60-something-year-old with idiopathic non-ischemic cardiomyopathy, has an EF that is abnormal, and this is a patient who's had previous ablated VT but has recurrent VF. And this is a very interesting set of patients that you'll see. Now you're seeing PVCs which actually meet the criteria or categorization called parasystole. These kinds of PVCs are very worrisome because what they do is they have a higher likelihood of inducing VF. And in this particular study done by my colleague Duke Doe, who looked through these cases very carefully, he was able to actually prove that some of these PVCs were the ones that initiated VF. And how do you tell where they are? They have parasystolic rhythms are rhythms that almost is completely oblivious to ongoing rhythm of the heart. And the PVC sometimes are not seen if the sinus rhythm overtakes it. But in the background, you can see that the rhythm is always continuing. And if it occurs at the exact right time, it can actually cause VF. And in this particular study, we were able to follow some patients for many years, and a handful of these patients actually got transplanted. And when you looked at the explanted hearts, what we were able to see was microfibrosis of the His-Purkinje system. Now, that is a very interesting finding. And when you looked at some of these ECGs chronologically over a long period of time, you can find that there are subtle changes in the QRS complex. Sometimes they are non-specific interventricular conduction defects. And many a times, this is actually a marker of ongoing myocardial focal inflammation or fibrosis. So when the His-Purkinje system actually has damage, watch out for it, because that may actually be something very important there to be aware of about the tissue. And this is another group where there is a higher risk of sudden death. Now, last but not the least, I'll present a case to you. Here is a 28-year-old completely asymptomatic patient, all right? Comes to see you in the clinic, and this patient's only sort of remarkable history is there's a family history of a sister dying suddenly. Absolutely tragic, right? This is the kind of a patient, and this is the ECG that is shown over here. Any cardiologist looking at this ECG, if they're asked to predict what the EF is, nobody is going to be able to predict this. But now you put this into a computer and using the AI algorithms for this, the AI algorithm predicted 76% probability that the EF was going to be low. Echocardiogram showed the patient has an EF of 18%. The initial times when these kinds of results came out, I simply didn't believe it because, much like other cardiologists, I felt, how can an ECG tell you anything about cardiac function? And I'm sort of very humbled to tell all, especially the students in the audience, I could not have been more wrong. Study after study after study, they come back and the result is like exactly what I thought it wouldn't be. So I can stand in front of you and tell you, much like how we deal with patients and when we operate, it's better to leave our ego outside at the door, check your ego at the door, and come back to deal with both science and patient care. Because I think this is where our own biases completely blind us. So in 2024, as the year comes to an end, ECG AI guided reading can give you the biological age of a patient, sex, EF, hyperkalemia, risk of AF, including a study that comes out of Maastricht today. There's a poster from Professor Shorten's group. A risk of hypertrophic cardiomyopathy, future hypertensive heart disease, arrhythmogenic RV cardiomyopathy. All of this can be predicted way, way before what you can pick up, even an experienced ECG reader. And in fact, if Hein Wellens were alive today, he would be even more amazed by how powerful AI-powered ECG reading is. The reason it works is because it's able to sort of refer to millions of ECGs. You know, the training sets for some of these AI systems is we can generate a hypothesis with several hundred or a couple of thousand, but really these algorithms have come from millions of ECGs. You know, that's just a mind-boggling number. But that again tells you the power of computing and the fact that this is becoming cheaper with more powerful computers, better computer chips. And going back to the problem that we had, why do some people with PVCs develop cardiomyopathy? Once again, deep learning. Look at this data set. Have you ever seen a study that shows you a hazard ratio of 300? Hazard ratio of 300. Okay, it's like unbelievable. It's not even a calculatable number. It's 3 digits, 300. It's not a hazard of 5 or 6 or 10. It's 300. So this is patients who have PVCs. And look at what the GradCam of the system shows. It's been able to pick up something in the Curas complex over here of the sinus beats. It's not the PVC beats, but it's concentrated on the sinus beats. And the sinus beat, much like how the EF algorithm has identified something that has told the computer that this is the reason why it's classifying this as likely to develop cardiomyopathy. So that's a fascinating finding, isn't it? So what are the scientific insights? I think AI-powered ECG is now going to assist us in coming up with credible hypotheses, exclude certain things, or at least focus more of our time in trying to interpret and understand what it is that such a test that's been around for 100 years, 100 plus years, is now helping us actually think through what we all see, but think new things and trying to interpret what the ECG says. So the tissue aspects of what an ECG can tell us is about electrical substrate, metabolic substrate, inflammation, and also its regulatory, which is neural control. Therefore, in 2024, if you look at the surface ECG, the big questions now is, how to look at structure function. To do this, I would say that, our aim is to take things from cell to bedside. And this is an area of science where AI, millions of patients, bedside, obtained data from big data is now driving us to actually try to do some truth verification and tethering AI-based results to reality. So now let's dive into the world of how to look at it from the smallest unit in the myocardium, which is a myocyte, and try to understand how the cardiac impulse propagates and how a ECG is generated. So if you now look back at all the studies now from the 1950s and 60s, a lot of EM studies were done. And this whole story of AI ECG has made us go back and rethink this entire story behind how the myocardium actually electrically is activated. So we now know that cardiac muscles is very specific, especially mammalian heart myocardium. It has unique branching patterns, very complex, 3D matrices in terms of how the cells are packed. But when it comes to the actual cells, the key, links between myocytes ends up being the intercalated discs, which is seen here sort of en face. And these regions become very important because they are kind of very important electrical junctions. I want especially the students in the audience to now, when I use the term intercalated discs, think of them as a functional version of a node of Ranvier, right? In neurophysiology, neuroscience class, people teach you about electrical propagation in nerves, and we use the term saltatory conduction. Of course, all these terms are unnecessarily, they're used in one context, but then we completely, don't think about it when we are looking at a different organ. So it turns out electrical propagation in the myocardium has more in common with what you would see with neural propagation, because the entire heart has to be activated within 80 milliseconds or so, and then then you actually have to have a coordinated contraction, and that contraction is actually a twitch. All right, the heart cannot contract like a skeletal muscle. It can't contract elegantly and beautifully. It has to twitch. It has to contract very quickly and eject blood. If the heart decides to do a slow motion contraction, the aortic valve will not open. So think about this. So there is a physiologic requirement, yes, within a range of diastolic volumes, the heart's contractility changes and so forth, it increases, but its fundamental function is to twitch from 4 weeks of life to the very last heartbeat when a patient is alive. So if you now look at this organization of myocardial cells, one of the most important findings and things that we are not stressing as much as we should is the fact that the originating channel of the phase 0 of the action potential, which is the sodium channels, NAV 1.5 in this case, is very polarized. It's not uniformly distributed in the cell. So if you look at this particular image, you can see that NAV 1.5 is very, it has very unique distributions. It's very near intercalated discs. And then you have a set of channels that are distributed for EC coupling. And these junctions between myocytes over here actually has small extracellular spaces. And we'll talk a little bit more about it. That region is called the perinexus. That actually is incredibly important for electrical propagation in the myocardium. Now, all of you have heard a lot about connexins, and of course, Walmart, De Mello, Janssen, and there's been so much great work that has come out of Netherlands and Europe, and the key investigators, in the US and worldwide have studied the intercalated discs, which are now receiving a lot of attention because it has a big role in inflammation, right? Now, to sort of put the whole connexin story in context, the presence of these junctions, when you look at the distribution of connexins, it tells you a little bit about how the cells get macro-arranged. Now, it turns out that the intercalated disc is a very, very, very specialized structure that the connexins set the stage. They almost, if you were to look at tiles, they help arrange the tiles and keep them close enough. And it turns out that subsequently, when sodium channels go co-localize in that region, together they form a very, very interesting, people have used the term couplon and so forth. That is an important sort of think of it as electrical igniting switches that connect myocytes. Once a myocyte is activated, then you actually have the T-tubular system so that you get activation of a single myocyte. So within a myocyte, activation follows almost like a second wave. So, and what is kind of very interesting, and we don't teach this in physiology, a given myocyte is completely agnostic to how the electrical wave is propagating through a given region of the myocardium. Because a myocyte has only one function, which is to contract, and it contracts along its longitudinal axis. So that is an important concept to keep in mind. And the so-called transverse propagation in myocytes is because of actually longitudinal conduction, but the zigzag arrangement of myocytes and intercalated discs. Why is this important? I think this is very important because it now tells us that when you read the literature, many groups have focused on one area, if you will, on electrical propagation, and a little bit of reductionism in biology has sort of, people have missed the main concept, which is you could do one set of experiments and look at a result in science, but in nature, they all occur together. And a classic example of this, of course, is ARVCs and all these, sort of desmoplakin, and intercalated disc arrhythmogenic cardiomyopathies, most of them seem to localize to this region of the myocyte. And now when you look back at the literature that has accumulated over the past 20, 25 years, it becomes very obvious that the location of sodium channels, the location of these intercalated discs actually plays a very important role in electrical propagation of the heart. And it turns out you'll also hear this term apoptic coupling, complex term. It was used by Nick Sperlakis, who's a physiologist. Again, a lot of drama in the literature. They spend a lot of time arguing with each other, but the concept being electrical propagation in the myocardium actually occurs much like neural propagation. It jumps these junctions, and it's able to activate a huge amount of myocardium fairly almost instantaneously. And then the magic of EC coupling occurs, and the way the bundles are organized in 3D results in the heart being able to very quickly contract and inject blood. And it also follows that when you actually have myocardial disease, which is shown over here, and by the way, these are figures that I've taken from a paper that is just, it's in press in Journal of Physiology, which we have done, both our experimental group and the modeling groups together, put this together, this manuscript. And what you see over here is electrical propagation, the top panel, a cartoon version of it in health. And when you have disease, you can see that the T-tubular system here has a lot of changes. There's a huge amount of experimental evidence for this. That sort of sets the stage where this is sort of the physiologic basis of an increase in the QRS duration. It can be any different pattern, but this actually tells you that T-tubular structure and its disorganization is reflected on the surface ECG, and it alters the QRS complex. It may be increase in duration, it may be increase in certain characteristics of the QRS complex, but that is something which is very likely the reason why AI is able to so sharply focus on an area which may be tremendously important from a physiologic perspective. Now, if you overlay neural control on top of it, right, that is the magic. So think of nerves as if electrical impulses were cars going on a road. The traction of the car's tires on the road is controlled by the nervous system. So the nervous system really works so beautifully as a regulatory system. So its electrical propagation in the heart is the tissue effects are controlled by factors beyond just what you can understand from ion channels or understanding a single cell. Let me give you a clinical case now. Here is a case of a patient who had a 62-year-old idiopathic cardiomyopathy, had VT, originally monomorphic VT that was successfully ablated, but still was getting shocks, was having PVC. So we did a cardiac sympathectomy. The patients did extremely well. And subsequently, the patient had done well for 7 years. With no shocks after cardiac sympathectomy, but still in the device clinic, we found PVCs. And when we went back and looked at the chart, sometimes some of the VF episodes the patient had was because of those PVCs. Now it's the exact same patient. It turns out that the PVCs were because of a very complex intra-device interaction where after a pause, there was a paced beat which was occurring because of cross-chamber blanking. Be as it may, the PVC that was initiating VF before was still there, but the only reason patient was not getting VF was because we had done a cardiac sympathectomy. Now this is pretty mind-blowing, right? The patient is their own control, and the only difference pre and post for the PVCs that were causing VF before is now the tissue does not have the extra catechols that is generally, if you have a PVC, the reflex will make more catecholamine released into your myocardium. So this was a pretty, these are amazing cases just for you to sort of be amused by the physiology. So again, you may have a spark, but if you have a very flammable myocardium, that's what causes arrhythmia. So you have to keep all these concepts in mind and not lose yourself in the world of reductionism. Now, all the stuff that I say, does it have any further relevance? Here's a great study. This was a Young Investigator Award paper published in JACC EP, comes from Ohio State. Heather Struckman, she did this beautiful study. She comes in Sai Rangasai's lab. And they've done this amazing study. I would encourage those of you interested in it to read through this. I don't have time to explain this in great detail. But this particular study actually looks at atrial myocytes, the electron microscopy. They looked at intercalated disc structure. And basically, it gives for the first time an amazing explanation as to why AFib is commoner than VFib, and why when you have ongoing inflammation, you have a viral illness, or you have a postoperative state like we heard from the surgeon today, post extracorporeal circulation, if there's a change in how fluid in the extracellular space is handled, that sets the stage for atrial fibrillation because it affects this particular process of electrical propagation in the myocardium. And superadd neural control. Here's a study. This is a study that was done by Pradeep Rajendran, who did his PhD with our group. Pradeep did this experiment where he expressed channel rhodopsin in mice, and he was able to actually specifically target, in this case, cholinergic nerves. And look at the power of what the nervous system does. This is in the lower panel. What you see over here is the P wave. I've highlighted it over here, and you can see the P wave duration. You can see how dramatically the duration of the P wave gets stretched out by release of acetylcholine in the myocardium. So that is the power of what happens when impulses propagate through the tissue, and you can modulate that. So you can modulate it by changes in extracellular fluid. You can modulate it by neurotransmitters. So it's very interesting. So you can't just limit your knowledge to knowing just everything about a cell. You have to put excitable cells in the context of an organ. And remember, only 40% of your myocardium is myocytes. So the majority of the cells in the heart are not myocytes, right? So you have to think about all the other cell types and how regulation works. So if you were to keep these concepts in mind, and also take another important concept, and that is fibrosis. What happens with disease, the complexity of muscle bundles and how they are arranged. These are all things that together collude to set the stage for arrhythmias. And so this is the point where I would tell you that, coming back to the slide which I showed at the start of the talk, cell, tissue, organ, if you want to put it in the context of population, you have the other aspect, which is the systems, which is neural control, inflammation, metabolic state. That has to be factored into the big picture, because that is the only way in which sort of we can bridge the two worlds. And I would often tell you that start looking at the bedside and then go back to the bench. Don't always look at one particular protein or one particular channel, because it may or may not have an impact in the context of what happens in the big picture in biology. I'd like to sort of show you one or two little images. This is a study that we are very fond of. This comes from Bas Boekens and our team from Netherlands in their collaborative work when they come to UCLA to these experiments. So our end game, of course, is to go back and understand why that PVC, in this case, in a perfectly normal heart, results in fibrillation. Now, this is the work that has come by the work that Boekens, Veronique, and Ruben, and Hill Jansa have shown us is because of steep repolarization gradients. And this, of course, is reflected in the ECG in aspects of the T wave, in fact, parts of the QRS complex. And I think these are things where, again, there is a lot of hope that we may be able to identify people who are likely to fibrillate, who have a higher risk of sudden death, which may very well come from long series of ECG recordings over longer temporal scales. So very exciting times. And also technology is getting better all the time. We can actually now directly intramyocardially measure neurotransmitters in a beating heart. And not just that, we can direct assessment of substrate is going to have a very high likelihood in us understanding the actual origin of arrhythmias and functional control of VT circuits and functional control of the myocardium. So that's where the tissue becomes important. And the kind of technologies that are coming into clinical practice is shown in these two images. If I can play these videos, you can take a look at this. This is part of our Leduc effort, stretchable electronics. In the left panel, what you see is, think of this, these are plunge electrodes. You can see that we can actually get intramural recordings. And the lower panel over here actually shows you recordings across the myocardial wall. Along with the electrical recordings, you can actually get regional neurotransmitter measurements. So in other words, structure, function, and functional control. And later, of course, you can also do things like tissue clearing. The aim is, in the rightmost panel, you see the electrical maps when your patient is being mapped in the EP lab. So we'll be able to bridge research on all these scales and be able to come up with mechanisms. So the future is already showing a lot of hope that this is what it's going to look like. Pre-arrhythmia, we're going to be able to answer who, why, when, and where. But the how is where we're going to focus using the power of AI so that we can actually go do much more thoughtful experiments, because we have only a finite amount of time and money to invest. We can't be testing 20 possibilities. Thankfully, the clinical phenotype is how data sciences helps us identify patients to study. Now, the fun aspect of science is to really understand coupling interval. Why does that PVC subsequently cause the other bad stuff it does? Again, if you have long time series recordings, some of the great posters we saw, if you can combine imaging with electrophysiology, we can start understanding and answering these questions, so ultimately we can prevent. Earlier this year, the National Institutes of Health in America had a 3-day symposium on prioritizing, discovering, and advancing in arrhythmia therapeutics. I would encourage all of you to log in online, listen to these talks. There were a total of 6 sessions. And this was co-chaired by Beth McNally and myself. Beth is the editor-in-chief of JCI. We think that this is it's a very nice opportunity for many of you to sort of get a feel for how science can go all the way from molecules to humans to in silico. This workshop, of course, concluded with these important statements that what is going to be very important for arrhythmia biology is to understand the heart at the meso and other spatial scales, especially in terms of functional control. We need to really do much, much more basic science. We can't just be doing just outcomes or, sort of just data analysis of patients. We really need to start doing the hard work to really understand very fundamental mechanisms. And of course, this is one of those areas where things like biomarkers and systemic measures, control, understanding things like inflammation is going to help us with wearables and the kind of new diagnostic techniques that are coming in. Where will this all lead to? It'll lead to going back to in silico so that we can actually now start creating models. Our current models are very, very rudimentary. They're one-dimensional cables. We have to start somewhere. It has helped us to a certain point, but the whole field has come to a standstill, which is, of course, the big message of our paper. And our hope is that we'll probably come to a point where we'll be able to actually do simulations that will become more and more realistic. So even if we, say in the next decade, come to the level of how weather prediction works, that would be very useful for arrhythmias. We may not be able to predict something 4 or 6 months into the future, but 3 or 4 days, prior to an event, if you can actually take preventive measures, that becomes very meaningful, right? So much like how, we've been able to make advances in other fields, we need better tools, we need better experimentation so that these models can actually help us. This morning, I was very impressed by the CARIM presentation about the pillars of science you're doing. Many years ago, when we started off our big effort, we put together an international consortium that you can see over here, We had the same pillars, except that we had mouse and rat work. Now we do just mice, pigs, and you can see the main vertical here is humans. And all these other approaches, functional mapping, transcriptomics, bioinformatic tools, all of this works across various model systems. But eventually, what is going to be very, very important is great that the work that your group is doing on iPSCs are going to be very meaningful, because we really need to get closer and closer to understanding what actually happens in humans. So we've been talking about a lot of collaborations with your university. We have a long track record of collaboration with investigators in Netherlands. So our hope is to do structure function studies, get a whole variety of data sets. And the end game would be I'm from Los Angeles, so I have to give you a Hollywood quote. So at least well before 2054, we want to be able to give the minority report for human hearts. And I'll conclude my talk with the comment which I promised I would show you, and that is international engagement. When you look at the contribution of people like Hein Wellens and Heel Janse, you realize that they are the greatest example of international engagement. We are doing a project of our own, and that is creating what is a part of the computable human project that we are doing. But we are also using this opportunity to revisit a historical wrong that was done to innocent people. And if you grab this QR code, you can download this entire atlas. So there are a series of atlases we are doing for the human heart, which is also computable in a way. And it's going to help us, in our scientific efforts. And eventually there are going to be a total of 7 volumes, 7 atlases for the heart. And subsequently, we're going to map the rest of the human body in collaboration with many teams. In fact, our first 2 international sites of collaboration include the Oxford University and the Indian Institute of Science. And I'd like to sort of conclude by thanking my collaborators at UCLA and, of course, internationally. And most importantly, a special tip of our hat to funding agencies, because it's public dollars, donor funds that drive science, and the greatest privilege is to help patients you never get to see. I'll stop here on time, and being aware of the fact that it's the end of the day. Again, thank you so much for this great honor. I'm very inspired by seeing the young people in the audience. Good luck to all of you in your careers, and you make use of all these wise professors who are deeply interested in your career development. I was reading the CARIM's annual reports over the past many years, and when Professor Reneman very beautifully talks about this vision of bringing physicians, physician scientists, pure scientists, and keeping them in a context like this, and having taught at the DASCAM course that Professor Wolders had organized. And of course, the long discussions we've started to have with people like Professor Schotten. Very impressive. Good luck to all of you, and go on. Netherlands should get a few more Nobel Prizes. We don't care about the Nobel Prizes, but I know that what you're going to do is going to help my patients. So thank you so much.
Thank you very much. Fantastic. I'm sure there's many questions, but maybe as you address the young people in the audience, and when they see this kind of multidisciplinary work, and they wonder, if I were ever to treat a patient at this level, what would you recommend in terms of how they should be taught and what disciplines? I mean, you're a professor of cardiology, radiology, and biomedical engineering, and you wonder, with all this complexity, how would I ever be able to master this kind of information to treat my patient in the way that you would like it to happen?
Thank you for saying that, Professor Wolders. What I would say is, look to the person sitting right next to you. Talk to everyone around there. We are a communal creature. Human beings are not meant to be sole. It's not an individual sport. It's a team sport. And science and patient care probably require more team effort than anything else. My vote would be is, go look at your friends in astrophysics and astronomy, look at other fields. People very aggressively, openly collaborate. I think open science is very important. In fact, we should put all the data available in the public domain so that people can verify your results. They may be able to give you a better interpretation of your own science, which is good. Because there's a saying, which I often quote, a UCLA coach, John Wooden, is a basketball coach. He said it beautifully. He says, deeply care about what is right and not who is right, and be eternally curious. It doesn't matter. Whatever be the research problem, there is some expert somewhere who will teach you how to do this. If Professor Durrer did not go talk to the Department of Physics and have someone build him the electronic equipment, we would never have intracardiac EGM recordings. Similarly, Einthoven actually was a biomedical engineer. He essentially created an instrument. Think of it, right? 100 years ago, string galvanometer, think about this. It's an actual instrument. All of what he did was actually previously known. Waller and other people have said, oh, there is a recording you can get on the surface and so forth. But essentially, he was able to collaborate with someone he understood enough interdisciplinary science. So the answer to your question would be human beings have always done it. It's just that we tell a story in a way where it seems like, oh, how the hell is it possible? It is possible because as you go through life, you're interacting with all these other people. Today, there was a poster where the radiologists have done a photon counting CT paper. You see how it is. It's a cross-fertilization. I think we artificially divide fields of medicine. Last week, actually, I was spending an entire afternoon doing liver ablations with my interventional radiology colleagues. We spend a lot of time looking at innovation of the kidneys and innovation of the gut, only because if you take a little bit of time, you end up learning new things from other people. We would have never done cardiac sympathectomy if not for talking to other specialists and reading the literature. Always read. I'll give you one other little clue. This is something that Hiel Janse taught me, which is there are still libraries that have bound copies of journals. So instead of just downloading the PDF, sometimes walk by the library and pull out that volume. Of course, go look at your article, but also just flip through the article before and after that. Sometimes what you actually see, even in that type of a setting, will open your mind to something else. Because AI, LLMs will give you the exact specific answer, but it'll never give you the context of how the human mind works. So be curious, talk to everyone. And this is the most exciting stage of your life, when you're young. I was very inspired by reading, Professor Janse's book when I was a medical student and when I was doing my PhD. So I had never met him in person at that time. And for me, the happiest moment in my life was when he visited UCLA. I was a full professor by then, was to give him a copy of my doctoral dissertation. I consider that to be the happiest day of my academic career. It's way more important than a Nobel Prize. Celebrate these people, okay? They are right among you. Thank you. It's a long-winded response.
Yeah. And how fitting is that to the mission of CARIM? Any other question?
Students. I think they're all very sleepy, Paul. Comments, questions?
Well, great presentation. Thank you so much. And it gives a lot much to think about. And I just have a general question, actually. What I see in the last couple of 5 to 10 years, I see the field of cardiology is moving towards more like neurocardiology. And we've been trained hardly in that. Really, on average, a cardiologist is not busy with that so much. However, you see now in VT, the stylectomy, you see in AFib, you see the GP ablation, invasive vagal syncope. More and more we focus on that. How do you see the field is moving? How do you feel, what do you think in 5 to 10 years, how we will be treating our patients very differently, much more focus on the neurology of the heart rather than just on the structural part?
Thank you, that's a good question. Look here, when I did this, the only reason we were able to do neuroscience so well is because electrophysiology is the same. In fact, when you do patch clamp studies, I'm sure Uli would tell you, all our instruments are named for neuroscience. When Sackman and Nair won the Nobel Prize, it's AxoPatch. Even the Axon Instruments, a company that makes our patch amplifiers, everything was done in the neuroscience world. We'd applied it to cardiology. So it's excitable tissue. So in other words, it's a biological principle. I think in clinical practice, to answer your question, I think we should look at the patient in their entire context. We should literally start off with whether they got a good night's sleep, what is the context of their life. And earlier today we heard pollution affects every aspect, right? Inflammation, stress. So things that were sort of general advice is now quantifiable. I think we're going to get biomarkers. We're going to be able to get biomarkers for inflammation. Look at this whole revolution with GLP-1, GLP-1 agonists, right? It's able to have impact, heart failure with preserved EF. It's impacting diastolic function. So all of that came from gastroenterology, So I think the way to look at that is whole body is what I would say, and I call it the internet of the human body. So neuroscience is not even just limited to an organ. I think we should holistic, but not in a wishy-washy way. It's something that can be highly, deeply studied. In fact, that's why the Amarayat project itself started off. We wanted to understand the nerve, control of the human body, and then we realized one of the best atlases came from Vienna, Penkopf, and then we learned about its bad history, and we went about doing that project to sort of correct it. But in doing so, we are now beginning to realize everything connects to everything else. No human being stands alone. And I think the entire human body should be seen as a single system. And perhaps that may be the only role we would have as physicians, in the sense that someone who can actually talk to another human being, put together all the data, and we'll have to treat the disease and a patient holistically. Yeah, there'll be some very specific high-tech in and out type of intervention, but still it's going to be in the context. Think of this. I never thought we would treat serious ventricular arrhythmias by dealing with the stellate ganglion. It's amazing, right? Patients in incessant BT is dying. So that's eye-opening in a way. Cancers are going to be treated by neuromodulation. Metastasis of cancers under neural control. Whoever thought that, right? So I think that's where I would encourage all the young people in the audience, read about other fields. Go look up a term called interoception. Interoception, internal sensations. Like how we touch, see, and see external sensations, there's this whole area of biology called internal sensations. So interoceptive biology, these are the fields that are going to revolutionize our world. So I'm happy that you see the wave of neurocardiology, but neurocardiology has always been with us, right? When Sir Ian Black got the Nobel Prize in Imperial Chemical Industries for beta blockers, that's actually an autonomic intervention. We quite don't think about this. The signal from the heart went to the brain, and the brain now says, the brain interprets this as hemorrhagic shock. So the renin-angiotensin system is activated. So it is just that now we can record from those nerves, we can become even more sophisticated. Again, physiology, science, and good basic science. Uli?
Shiv, fantastic talk, and I'm happy that Kevin already covered one of the most important challenges of the science, and that is the neurocardiology field. I'm going to ask about something else, and that is the use of artificial intelligence. I share your enthusiasm, particularly about deep learning. I see that you apply this also in your center. In what way? So if you look at how difficult it is to bring markers, and I mean functional biomarkers, like QRS duration, for instance, into an actual application, then one sometimes may wonder, will this ever work with deep learning results that are hard to translate from one center to the other? There is no consensus about how large do the validation cohorts need to be, where do they need to come from, and so on and so on. So there's a long, long list of steps we have to go through. And please understand, I'm not negative about that, not at all, because it can help us a lot to guide us to new questions. But what is the most important intended use of AI you are interested in?
It's a great question, and look, it's probably the most talked about subject. I'll give you a short answer for that. One is, many of you should listen to an interview by Bill Gates on this. And I agree with him. He's very thoughtfully, he says the biggest impact AI would have is actually going to be in science. Of course, everyone talks about protein folding and those kinds of problems. But I think it's going to help us in science in two ways. One is, in the past 5 years, the fact that ECG can teach us so much now tells us we have to definitely try to explain it, because that is explainable. There are certain things that may or may not be explainable, but what is explainable, we can I think of it as like a tunnel that is being built from two different directions. Large data coming from large population data sets, and of course our foundational little pieces of knowledge that we have of specific reductionistic biology. But these two worlds will meet. And the magic is for us to come up with, if you have to go like drill for oil somewhere or prospect for something, we can use AI as a powerful instrument that will help us almost like focus on an area of science. The second aspect of what you say is, that's more of a practical problem. However, more and more data in the world is fundamentally digital. And there's a lot of digital data sets that are being created as we speak. So some people think that in the future we may never have even randomized studies. Every patient, eventually there'll be enough patients who are having continuous monitoring of some sorts, periodic monitoring, and especially tests like ECGs, which are time series data sets, which are obtained by electronics that don't have dramatic differences between, like for instance, it's unlike a blood test, which can have so many differences, even if the same lab does it. Things like ECG are easy to get. Other time series recordings, we'll be able to actually validate that, is my sincere hope. But again, AI is something unbelievable. Someone recently told me, a very experienced person in this field said, right this minute in November 2024, the AI that we are using is the worst AI you'll ever use in your life. Think about it, right? We don't think of it that way. The worst AI that you'll ever see in your lifetime is right now, which means in 5 years it's going to be unbelievably more powerful, but that'll help us tackle bigger problems. Yes, there's a lot of bad stuff people say, but fundamentally, it's like the Industrial Revolution. I think it's going to help us. Hopefully it doesn't add to our time pressures, but hopefully it helps us answer some of the mysteries of biology. Biology is way more complex than anything else AI has ever been used for. I think it'll be humbled by what we're going to come across. But hopefully it'll make our life fun, and we can inspire all the young people in the audience. It's you people are the future. Please come help us in this phase of our careers. See some good being done for our patients.
Fantastic. I think we will stop here. And Chief, it's not only the content, but it's also the way you tell your story with such an enthusiasm, inspiring people, always a laugh. So we owe you a great round of applause.
Thank you. Thank you. Thank you so much.
Well, thank you so much, Shiv. With this exceptional lecture, I think there belongs an exceptional sculpture with it. And this is a sculpture made by one of our famous Dutch sculptors, Kaaije Spronken. It's a bit of a contemporary sculpture. So if you can recognize some kind of mermaid in it. So I'm not sure if it's still out. And if it's okay, there's a little tag with it. Of course, it's not anymore. Daar. So there's a little.
If it's written in English, I could read it.
Because some of them, there's a little sticker there, the metal plate, and that will have your name and the Reneman prize. And we offer it to you for on your desk. And if you like the art more than the little placard, you can put the placard on the back. So that's why we provide it. So
this is a very beautiful memory. Thank you all so much.
Congratulations, and thank you very much for your lecture.
This will be proudly displayed at UCLA. Thank you. Thank you so much. Grab my laptop. Thank you.
Okay, then we'll come to the conclusion of this beautiful day, and that is the awards session. It has some cumulative awards that we pass out during the year. And the first session will be about Tillman's big mouth, because in the opening session I told you that actually the results were known of the PhD call, and I was the whole day I was harassed by everyone. Yeah, who won? So now we decided then to show you the winners in this first slide. And actually I'd like to ask Constance Baten to come over here and lead this part of the ceremony. Because normally Christian Wouters is the chair of the Research Council, because he also had one of the applications. He was conflicted, and then we appointed Constance as an ad hoc advisor to oversee the really complicated evaluation of the, I believe, 18 applications? 17 applications, and also oversee the ranking and then the advice to the daily board of CARIM. Let me check if this will work. It is not. Haal er even uit. Het is ook maar goed dat ik dat gedaan heb. There we are. Als je nog een keer op drukt, dan komt de uitslag. Ja?
Okay. Yeah. Well, this was a little bit of a surprise for me. I found out during the break that I get the great honor of announcing the recipients of the 2024 CARIM PhD call. As Tilman already said, well, it's not 18, but we had 17 eligible applications, all describing interesting and exciting research projects, and for us the difficult task to assess those. So with a team of 13 reviewers, we assessed all the applications. So first of all, a great thank you for all of those who contributed in the reviewing process. All applications were assessed by 3 independent reviewers, and we assessed the applications on overall quality, embedding within CARIM, collaboration within CARIM, and international visibility. And based on those scores, an average was calculated and a ranking was made. We communicated our results with CARIM, and CARIM took over our advice. I won't keep you in suspense any longer. So congratulations to the 2024 CARIM PhD call recipients, Bern Hermans, Judith Koosmans, and Stefan Heijmans.
Thank you very much, Constance. Oh, that goes wrong again. So, of course, this is not so nice news for the applicants that did not get it, but as said, it was a very competitive challenge. All were very good, but only a few, of course, can win. But maybe it will help that we have some drinks later in Thyssen, so that we can share with you some drinks to recover from this maybe not so nice part of the presentation. Okay, we'll move on. And now we will come to the let me check. It's not going as I would like it to go. There we go. And now we come to the HS BAFTA awards, the Harry Struikelbodier Award for Talented Academics. This year we only had PhDs and a postdoc, so we didn't have any pre-PhD applicants that actually passed the test, the rigorous test that we do with the CARIM and the Research Council. So we only have PhDs that can use their grant to visit a broad institute, and of course a postdoc that will be able to travel outside to another country, preferably far away, with the HS BAFTA postdoc grant. And here are the winners, the PhDs and the postdoc. And if they can please come forward, all of them, they can pick their little medal and take a picture with me. And if your medal of choice is not here, everyone wants the golden, then you can exchange it at the CARIM Bureau. Then we come to the poster prizes. So we had an extensive evaluation of the posters during the lunch break. And then we said division, for the division blood, we had the poster judges Eline Kooi and Steven Meeks. From the division vessels, poster judges Sabine Dame and Sam Heuts. And from the division heart, we have the poster judges Camilla Soragni and Matthijs Kluitmans. And we gave them the task for the division of blood to evaluate the posters from vessels, from the division vessels to evaluate the posters of heart, and for the division of heart to evaluate the posters of blood. And then I will just give you the winners. 50% of the rating was of the performance, explaining the poster, how you did it, the interaction, 25% layout, and 25% content. So this is actually opposite what you would normally do if you would submit a paper. But in this case, it's so important to try to get your knowledge across to other people that we thought presentation, having the X factor, keeping people at your poster was actually an important issue in this evaluation. So for division, let me see, vessels, the winner is Aidenis Eda. Please come forward. For the division heart, Michel van Oeteren. And for the division blood, Tom Konings. We then come to a very important prize, that is the CARIM Dissertation Prize. And for that prize we had a very professional jury, and we had 63 PhD theses that they had to go through. And then with 3 people, that was a lot of work. And eventually they came up with 3 runners-up, which I will show on the next slide. And from that 3, in the end, of course, 1 again was chosen. And here are the 3 runners-up: Nguyen Nguyen, Anne Willers, and Amé Buzio. As you see, the Thesis Award Committee consists of Paul Volders as the chair, Casper Schalkwijk and Roy Koenen. I believe they're all here. So you can discuss the outcome of the evaluation with them later. But of course, only one, again, can be the winner. And the winner is Nguyen Nguyen. I have a lengthy... Oh, come here. I have a lengthy jury report that I would like to read, so you can stand here or hide somewhere. Nguyen got her PhD as a double degree from the University of Lugano and, of course, the University of Maastricht. Her supervisors were Frits Prinsen, in the audience, Professor Angelo Auricchio, Kevin Van Ooy, in the audience, and Professor Rolf Krause, also from Lugano in Switzerland. And the title was Multimodality Imaging in Cardiac Resynchronization Therapy in Silico and in Vivo Analysis. And the jury report said, Nguyen received a double PhD degree, already told you, from Maastricht University and from the Università della Svizzera Italiana in Lugano. Prior to her PhD, she also obtained 2 master's degrees in technical medicine in Twente University, Enschede, and in medicine of Maastricht University. And currently she's specializing in cardiology at Maastricht University Medical Center Plus. For her PhD studies, Nguyen reassessed the value of the electrocardiogram to improve the selection of heart failure patients who will benefit from cardiac resynchronization therapy. She also developed a strategy for better positioning of the left ventricular pacing lead for resynchronization therapy based on multimodality imaging. And finally, she investigated the influence of this synchrony and subsequent cardiac resynchronization therapy on local repolarization patterns and pro-arrhythmia in the ventricles of the heart. The latter work was the foundation for a project proposal awarded with a Decker Clinical Scientist grant from the Dutch Heart Foundation. I guess you can already recognize the writer of this evaluation, that's Professor Volders, because we're not done yet. Nguyen was born in Hengelo, the Netherlands, as the daughter of Vietnamese refugees. She's a beloved spouse and mother of 2. In her work, she expresses an enormous drive in almost everything that she does. She's an example, a real example for her peers. Her supervisors emphasized that most ideas for her publications and PhD chapters came from the candidate herself, rather than from her supervisors. And on all of the docent papers related to the PhD, many with significant impact, she is the first author. Nguyen is ambitiously following an ambitious academic career in cardiology, particularly in the fields that she has already embarked on during her PhD years. CARIM and the committee is very proud to hand the Dissertation Award 2023 to Nguyen Nguyen. Very delicate Surprise. Then we will proceed with a novum. That is the Anna Maria van Schuurman stipend for a young, talented female academic. Anna Maria van Schuurman, I introduced her last year, was a Dutch scientist, humanist, engraver, painter, poet, and writer. She basically can do anything she likes. She's self-educated. Her father was also an academic, so she spoke, I think, like 6 or 7 languages. She did everything really well. And actually, she was also the first student that was enrolled in the Dutch university in Utrecht at the year of its opening in 1636. And the fun thing also is she really, at early age, already recognized what was wrong with the world, and especially with the academies in the world, that there was not too much chance for female admittance to those gremia, I would say. So you can also see from her hand she wrote some very important pieces in literature. And the important thing is that when the university in Utrecht opened, she was allowed to design the opening words for the university. And in that, she already said, if you look at the translation, at the last 2 sentences of the 15th stanza, "But you might ask, what is troubling you? Well, these sanctuaries are inaccessible to women." And by that, she actually negotiated that she could enroll in the University of Utrecht as the first female. She had to sit like behind the curtain to not distract all the males in the lecture halls. And this is actually the first woman. So I thought that would be really nice that our stimulation prize carries her name. And then we had assembled a committee, and the chair of that committee that evaluates the prize and the ranking of the runners-up, we would like to have here now Nienke van den Akker. I would almost give you an applause.
Yeah. Thank you very much, Tilman, for this applause, because I did not do much. What we did as a committee, we first set up the rules, how we're going to tackle this very important job, was given by us by Tilman and the rest of the daily board. And we decided that this is not only a unique moment because it's the first time we grant this stipend today, but it's also very unique because it will be the only time that we will do it at the CARIM Day. Because the laureate will be asked to organize a symposium around the first week of March, when International Women's Day is also present. And next laureate will be awarded during that symposium from now on. So very unique today. So what we did is we sent out a call for proposals, and we had a very, very short deadline of only a month. So we were really happy that we had a whopping 10 applications, and they were all really very interesting and good proposals, and we were really had difficulty to choose. So the way we did it was quite comparable to what Constance just explained, so I won't go into detail there. But we had a committee of 5 people, and from those 10 applications we have a top 3, which is actually 4 people, and there will be an alphabetical order on the next slide. So as you can see, the committee was next to me, Casper, Ingrid, Job, Judith, and Tara, and we made this top 3. And the top 3 were 4 people, namely Sabine, Miranda, Uyen, and Rachel. And who was actually the top? Would it be Uyen again? Yes, it will be Uyen again. Uyen, congratulations. We also had a quite elaborate report. I'm not going to read it out today. I'm just going to congratulate you.
And the sculpture is from Wil van der Laan, who also made the big angel of Maastricht on the Groene Leuper. And then it's very nicely typical for Anna Maria van Schuurman, modest, wise. And we have to take another picture also with me, Yuyen. The next topic will be the CARIM priori, and this is probably already very familiar for you. There was like a small period in Florence, intermittent part, void of the reign of the Medicis, and then the city government was formed every 3 months by draw. And actually the whole situation looked a little bit like CARIM. You can see that the bold black is Florence, the bold red is CARIM, so it looks alike. And then we said we're going to do this with the CARIM board. So every year we draw 2 members, 1 male, 1 female, to sit with us in the board and govern CARIM for a year. For us this is really exciting because we get all like new tips, new ideas. And the other way also because people then get to know what we actually do in the board. That's basically nothing. Because then the guys that go out of the board and the girls, they can tell actually what we do. So there's no secrecy in anything we do. So we really like it. So it's giving us more transparency and people realize that there's basically nothing that we can do to change anything in this environment, in this valley of tears that the Dutch government and of course also our faculty is giving us. Okay, so within CARIM we have 58 registered employees. Not all of them are paid, some are just our guest researchers. There are 154 structurally paid employees. Then we take out the board of CARIM, we take the bureau out, we take people out that we don't like, and then we end up with 110 people, scientific personnel, and 44 technical personnel. From those group of 154, there are 90 males and 64 females. Last year it was 94 males and 60 females, so we're also doing better in that aspect. And then we're going to have 2 pouches, 1 pouches with males, 1 pouches with females, and then we'll draw 3, and if the first one doesn't want to do it, or just succumbs because of all the emotion, then the second one will be chosen, or the third, and if then not, we are going to do another draw. And then unused, of course, names will be put back. And tradition says that the winner of the Harry Krijns Award will do the drawing. So Kaya, please step forward and do us the honors. So we'll contact these individuals soon and then ask them if they would like to do us the honor to join our board of CARIM, and then we'll inform you who will and who will not. All right. Actually, I forgot to show this actually. But I can do it now. These were all the names that were in the bags. At least you can check if you were in there and start a lawsuit. Then the final, the most important prize, the prize of all prizes, that is the CARIM Commitment Award. And this is to a person that has exceptionally well served the good fortune of CARIM during the last year. And it does not have to be scientifically, but also emotionally or just general support. And the person who will get the CARIM commitment this year is a man. And it is a man that has been thrown in front of a bus, and he survived. Maybe a better metaphor is that he actually had to lift a sinking ship, and not only a sinking ship, the sinking ship was filled with mutineers as well. So he reconnected the mutineers back to the crew. He built up the ship again, and then full sail towards the board of our hospital, and also helped us to revive our very important Maastricht study, which is, of course, the intellectual property of CARIM, and made us so famous and is not ready yet. He all did this with an immense amount of energy and in a very special diplomatic way. It is a very gentle man. He has a natural tranquility that is almost overwhelming. It is a fantastic man, and we like to keep him forever, yet he's leaving. And he's leaving to Rotterdam, to one of the finest kidney institutes that we have in the Netherlands, in one of the finest cities that we have in the Netherlands. But he's very much wanted. So I think when we give him this, this CARIM Commitment Award, put it on his desk, he will get homesick and return to us soon. The CARIM Commitment Award 2024 goes to Mark Hemelder. Who probably left the stage already. He's not here. Okay, I'll give him this to him personally. Okay, with that, this concludes our day. There's a couple of people I would like to thank. First, I would like to thank our microphone runner, Angela Habibi. Thank you for doing us the honors again. I'm afraid that next year you won't, I hope you won't be around next year, because then you'll have your PhD. So, but then again, maybe you'll stick around a little bit, and then I'll invite you next year to do this again. And then, of course, finally, our ladies from the Bureau, my eternal gratitude for all the organization and support, not only for this, but also through the year. It's maybe difficult to see them. Flowers among flowers are always difficult to distinguish, but thank you very much. For those that will travel home, be careful, safe travels, and for those who not going to travel home, let's follow us to Thyssen, and we have a nice glass of champagne and then some buffet that is also organized by the ladies, and we'll have a lot of fun. Thank you very much. It was a tremendous good day, and see you next year.